Hello, everyone. As you all pop in, I'm just gonna start with a quick welcome. We're so happy to have you here on your weekend with us for the next day and a half for the MedSLP Learning Lab. Just a quick announcement before we start. If you are interested in CEUs, members, the link to the learner assessment will be available in the course section tomorrow after our last session. That learner assessment must be completed within 14 days of the live course. You must attend both days in order to get credit for the live course. If not, you can take the quiz for the recorded course that will be up on the website on Monday. And I'm going to just introduce our first presenter, Dr. Christine Sapienza, who's going to teach us all about RMST.
Thanks, Casey. Hey, good morning, everybody. So glad to have you. I just want to thank Medical SLP Collective. It's such a great session today. I know you've got a whole round of speakers on different topics and a couple people talking about strength training and the paradigm associated with strength training, which I think, as you know, over the last, probably 10 years, and you'll see a slide on it in just a second, the amount of evidence-based outcomes that we've had regarding strength training specific to respiratory muscle strength training has really grown logarithmically, and that's very, very exciting. And I'll tell you a little bit about that in a minute. We only have an hour together today, so there's a couple of things that are important to me. One, try to give you the most basic understanding about the protocol, about the devices, the differences between the devices, some of the contraindications. Your questions will be important. Casey's going to be monitoring the chat. We're going to cover a lot of it. So what we'll do is we'll look at those questions, and if things haven't been covered that are important, Casey's going to kind of handpick those so we make sure we get those things answered. If there's something I say, during the talk and you're like, hey, I didn't understand that, wave a hand, put a message in the chat, and we'll try to get to that as well. For those of you who don't know me, I have been in the field of higher education now for unfortunately, 35 plus years, which means I'm getting older. But it's been an exciting time. I have done a lot of work in the area of voice, in the area of airway protection. In my career, I've written several textbooks. I have a graduate voice disorders textbook. I just finished up the 5th edition of that. So as you can see on the financial disclosures, I do receive an honorarium from Plural Publishing. But for those of you who think that maybe Dr. Sapienza receives a royalty or some type of a spin-off from the sale of these devices, I don't. We invented the EMST 150 when I was a researcher academician at the University of Florida with two other individuals. One was a respiratory physiologist, the other was a physical therapist, Dr. Paul Davenport and Dr. Danny Martin. And when we were at the University of Florida, we sold off the rights to the EMST 150 to Aspire Respiratory Products, who now is completely responsible for the sale. I always receive an honorarium when I educate about the devices. And today I'm going to talk to you about the EMST 150 because that's been the longstanding device. We'll talk about the EMST 75 and the IA adapter that comes from Aspire Respiratory Products. But I want to also introduce you to, Power Breathe's devices as well. And we'll talk a little bit about the differences in device types, because as the years have gone on, what we're seeing is just like, people who make shoes, people want to make more and more respiratory devices. And so it gets a little bit more difficult as a consumer to be able to determine, well, which device, which price point, how are they different, which one should I choose? And, what happens if my company or my hospital is only, vending this particular device versus this one? Is it still useful for us to be able to use? The other thing too is, we can't in 1 hour go through every single type of patient that this is applicable to, but I think we can make some really, good generalizations about what the literature is telling us about respiratory muscle strength training, not only as a tool for strengthening respiratory muscles, but as you may know, the literature has expanded so terrifically over the last 25 years that we now see this very sort of large generalization to other functions that are critically important for the things that we do as speech pathologists. And that's in the area of, how does it affect speech production? How does it affect voice production? How does it affect swallow function? How does it affect cough function? And so, the beauty of being where you are today in 2025, soon to be 2026, is you're not practicing back in the year 2000 when these devices weren't even available. You're not practicing in 2005 and 2009 when we didn't know half of what we know now about the evidence base associated with RMST. So I think it's a good time to be a speech pathologist, and I also think, from a learner perspective, that we want to realize that RMST now is really considered to be one of the strongest tools, devices, and I will say exercise-based or behaviorally based treatment protocol that we have for the specific evidence that I'll share based on the amount of published literature. So when we talk about evidence-based outcomes, and we use this term a lot in our field, and we say, well, I only want to use an EDB, evidence-based outcome, with my patients. But if you think about it, most of what we have in the area of speech, voice, and swallow, there's little tidbits here and there's little tidbits here on different techniques. I would say comparable to like a Lee Silverman voice treatment program, which has been in our field for well over 30 plus years. RMST has gained so much credibility because it has gone through the peer review process. And I think that's what's really critical to you as a consumer of these devices, as a user of these devices, that you understand that things don't become validated because somebody puts up a website and says, here, use this one. It's $39.99 and it's going to help improve swallow. You must look back at what these companies who are vending these devices have actually done in the peer-reviewed literature, right? Is there evidence out there, whether it be not just simple case studies, because those are very weak research designs, but group studies, sham studies where people have looked at the comparison between an active device and a sham device. Have they put the device through a randomized clinical control trial? Is there a paper that has done a systematic analysis of a whole bunch of papers to tell you whether these things are working or not? So that's really critical as a consumer. I get very bent on, there being what I would say, copycatters out there that basically will take things from, one particular website and say, hey, look, it helps cough function. And then only to realize they never did a study on cough function with that device. They simply took a piece of literature that used another device and generalized it. So we have to be, as speech pathologists, we have to be smart. We have to be really good consumers of what we're buying. And I think that goes into objective number one, right? Objective number one is let's know the differences between the and devices and what's out there. Number two is let's talk about what some of that evidence is. And we certainly don't have time to go through everything in terms of anatomy and physiology and all of the different literature that's out there, because now we're looking at papers that are well over 200, 300 papers that have been defined in the RMST literature. And then it's certainly any questions you might have, and I will talk a little bit about dosage in the protocol, but shoot those questions. So I currently, am still working academically. I've been through a lot of things in education. I've been a department chair, a dean, a provost, And now I'm sort of sitting back and enjoying, some of my own time and doing some teaching and doing a lot of education and work in the device field. So I'm excited to kind of be back to the roots of doing my research and academics, but have done a lot of work, and you certainly can read that about me if you wish. So when we talk about our patients, right, and you're thinking about, well, who is respiratory muscle strength training going to be for, right? First of all, right, point number one, these are devices. Point number two, right, there's something that is affordable, right? Is handheld, so it's tangible, right? It's physical to the patient. They like it, right? Because it empowers them. They feel like they have something they can control, right? Number three, we're starting to see these integrated pretty heavily into a lot of medical centers, into a lot of outpatient care centers. All right, so these are going to be devices that are at the forefront of choices that you can make that I would say are complementary to other therapies that you're using to build skill, right? Strength has to come first, then skill follows. If somebody's not strong enough, has too much weakness, it's going to be really difficult to start to train them on skill. Likewise, we can't ignore skill. We can't just put somebody in a strength training protocol and hope everything's going to be okay with speech and voice and swallow without looking at a skill-based training as well. So this is a complementary treatment, right, that builds off the fact that many of our patients, many of our patients are dealing with weakness, right? Weakness. This is not a device that's going to help people with, having central nervous system drives causing spasms. It's not going to help with people that have central nervous system drive that have problems with tremors, right? Primarily, these are devices that really in the literature have focused on weakness. So what does weakness, accompany in terms of the different types of patients? Well, think about it. Obviously, post-stroke, post-TBI, Parkinson's disease, multiple sclerosis, ALS, right? Those are a big category of people that have neuromuscular conditions. Pompei's disease, right, is another big area that these devices have been shown to be highly successful, right? And then you go to other types of conditions, right, that are a little bit different than the kind of quintessential classic big categories of neuromuscular disease, right, or neurodegenerative diseases. And you think about, well, how do these devices help the muscles involved in laryngeal control? How do these devices help in the control of swallow? And not so much control, but strength of those muscles, which ultimately, when you improve strength of any muscle, respiratory, laryngeal, supralaryngeal, you will positively affect coordination. Strength has to happen first, coordination follows. The beauty of strength training, right, is that you're making the agonist muscle stronger. And so that makes the antagonistic muscle group a little bit more subdued. So we get better coordination when we improve the strength of the very muscles that we're working on. And so when you think of this weakness, right, and this dysfunction, it can manifest in a whole bunch of different ways. It can be what we consider to be upper airway, which is anything from the mouth to the cheeks, right, to the tongue, to the velopharyngeal port, right, all the way to the pharyngeal muscles. And then down we get to the glottal level, right, the vocal fold level. And we think of all of the muscles in the larynx. And then as we move into the respiratory system, the diaphragm, right, which is our primary inspiratory muscle, right? Those external intercostal muscles, which are lining our ribcage to help us move our lungs. I mean, here's a question, right? Are the lungs, functional without muscles? Are the lungs a functional organ without muscles? Yes or no, right? And you have to be able to answer that question because so many people are not going to be able to ventilate if they don't have strong diaphragmatic muscle strength or diaphragmatic muscle strength, strong external intercostal muscle strength for inspiration, right? And then you have a whole bunch of accessory muscles that help with inspiration. But the answer is no. The lungs are a passive organ. They do nothing without respiratory muscle strength. You must have strong diaphragm. You must have strong intercostals. So if your patient is, suffering from just the simple symptom of dyspnea, this breathlessness, this inability to feel like they are ventilating appropriately, oxygenating, dyspnea and breathlessness can be one of the most debilitating symptoms that your patient has that's going to be primarily due to an inspiratory weakness, right? So when we think of respiratory muscle strength training, we have two categories, right? We have trainers that are inspiratory that work on the very muscles that I just talked about, diaphragm, external intercostals, and all the accessory muscles. And then we have expiratory that's working on that big abdominal group that we know of, right? I'm not going to list them all, but you have a whole host of abdominal muscles, right? And it's the expiratory device that we'll talk about that has really now, when you look at the next kind of 3 blocks, has really been shown to improve a disorder of cough known as dysphagia, a swallow disorder, right, dysphagia, and also voice disorders, dysphonia. So I like to collapse it into 4Ds when I think about patient care. What are they suffering from? And these 4Ds are very, very common, and they cross over. It's very, very, very common, right? Think about it. Disorder of cough, disorder of swallow. Disorder of swallow, disorder of cough, right? And we call that collectively an airway management problem. Those are 2 big symptoms you're going to deal with in all of these patient populations that you're thinking about. And feel free in the chat to kind of put in, what about this patient? What about that patient? Let me flip back a little bit, right? Let's talk about people that have airway resistance problems. Different story. They don't have respiratory muscle weakness. They have emphysema. They have COPD, right? They have asthma. Those are disorders that we think about as an airway limitation. And when we talk about our airway, we're still talking about the oral cavity. We're still talking about the vocal fold level. But we're then going into, right, the lower trachea, the bronchi, the bronchioles, which are not the muscular system per se. They're the conduit. They're the conduit to allow air in and out of our body. Again, critical for oxygenation and expelling CO2 out of our body, right, for health and wellness. But not always are we going to use respiratory muscle strength training to help people with airway limitation. So there is an evidence base for patients that have COPD that we should share at some point with each other. I probably won't have time to focus on that. There is a literature that supports the use of inspiratory muscle strength training for patients that have COPD because we have to make that diaphragm stronger in order to pull air into that narrow airway with more force. So when RMT first started, the very basis of these devices was for use with people that had emphysema and COPD from an inspiratory standpoint. It allowed there to be greater sucking pressures to move that air through a narrower space, gave those folks, those patients, a relief of dyspnea. So you can find that literature for COPD and emphysema using inspiratory devices. When we talk about dysphagia and dysphagia and dysphonia, and I will argue that as we continue to progress through the literature, we will then start to see, and are starting to see, the development of the utilization of expiratory trainers to help folks with things like dysarthria, which really is a disorder of the respiratory laryngeal and supralaryngeal system. there is emerging evidence that the devices are now on the expiratory side are starting to help people with lip strength, starting to help people with cheek strength, starting to help people with some tongue strength. And I think that literature is going to continue to emerge. I want to flip back to the slide real quick because look at the extensive nature of RMST publications, right? And just 30 seconds on it. This is cumulative. So when you look all the way to your far left, this is saying in 2025, cumulatively, we now have close to 250 peer-reviewed publications on the topic of RMST. If you go all the way to the far right represents the years of about 1975 to 2025 on the very far left. I'm not sure if you can see my mouse, but so here we had like a dearth of evidence, and now it just accumulates. And so it's going to be exciting to see what 25 and 26 are going to bring us. The interesting thing is it started out so locally, coming out of just a couple of people's labs, and now we are seeing the utilization of the devices globally and the science coming out globally. I love it, right? It's coming out of Asian countries, Middle Eastern countries, European countries, obviously the US, folks over in Greece. And so, you've got literature coming from a whole host of different groups, which is I think the most excellent standard, right? Is that it's not coming out of one specific laboratory with bias. It's coming out from all over the world. That's important. That's important. So where are we today? It's a consumer product. It's no longer just a scientific device. It's a class 1 device, which means it's an exercise training device. It's got FDA approval. And we're going to talk specifically about why I am such a firm believer in the utilization of pressure threshold devices. And I want to take a minute to demonstrate those, take more than a minute to demonstrate those. So what you're seeing on your left-hand side, right, are a host of devices, a host of devices that are produced by Aspire Respiratory Products, okay? So this block here is Aspire Respiratory Devices, emst150.com. And that's where on that website, as a healthcare professional, you've got access to the devices, access to the prices. There's a healthcare professional website there that has a ton of literature for you to refer to. There are training videos on that website so that, in this quick 1 hour, you're not going to see everything, but the training videos will walk you through it. And this is the device, the blue on the far left was the device that was invented at the University of Florida. That is considered to be the EMST 150. Why do we call it 150? Is because the pressure range, the cap, goes to 150 centimeters of water pressure. Why do we measure pressure in centimeters of water? That is the standard unit of pressure from a long time ago when people used to use water manometers to measure pressure. So the green one in the middle, that's referred to as the EMST 75. And we'll talk about, well, how do I decide which one? And then the one with the adapter on it, this one here, this is the inspiratory adapter. So the blue came from UF, and then that moved over to Aspire Respiratory Products. They designed what we would call a lighter threshold device, an EMST 75. And then the IA adapter was actually developed out of Duke. And they moved that device over to Aspire to flip the device to become an inspiratory device. So expiratory only in the blue and the green, 150 centimeters of water cap on the blue, 75 centimeters of water cap pressure, centimeters of water pressure on the green. And then depending on which device you insert, you can either have an inspiratory device that goes to 75 or an inspiratory device that goes to 185. And no, Jamie, that they're not contraindicated for vocal fold paralysis or paresis. In fact, they can be very helpful, and specifically for cancer and PEG tube. Um, the PEG tube, as long as the PEG tube is, you're doing it, before you have fed and it's stable. The PEG tube, it has been used with individuals with PEG, and it's not doing anything to adversely affect the PEG tube. We actually want to use, just to touch on your question, and we can have time hopefully to answer that in more detail. These are the EMST, the expiratory device, which I'll talk about, you'll see is actually helpful for people that have vocal fold paresis or paralysis on one side. And cancer, there's literature that has come out of multiple labs showing to use it as a pre-radiated condition to make things as strong as possible, and as a post-radiated condition to help break through some of that non-movable fibrosis and try to get as much activity as you can out of those muscles to move that hyolaryngeal complex up and forward. So not contraindicated at all, actually considered to be a therapeutic technique that literature supports. Let me quickly talk about why I am a high, can't stress it enough, advocate of pressure threshold devices. And, hopefully if you walk away with anything, you really want to look to two primary companies to get a device. One is the Aspire products, and then the one on the right is Power Breathe. Those are the two main companies, EMST150.com, PowerBreathe.com, that only sell pressure threshold devices. I am not a fan of resistance devices. I'll tell you why in a little bit. So, and I'm looking at your questions, and we'll try to catch as many as we can, but I want to make sure that I get through a little bit of the demonstration of the device. So when you're looking at the EMST, and I'm gonna pop up, this is the EMST device here. And actually, Casey, would it be better if I stopped sharing my screen for a second so that they get a fuller view?
Yeah, let's try that.
I don't know if that helps. Does that make me a little bit larger?
Yep, it does.
Okay, great. So I've got a different color mouthpiece on it, but basically, you've got the device, and when you have the device, and I don't know how many people have the device or not, there is a couple of things that are going to be important, and obviously I'm not in the best view, but I'm going to note a couple of things on the device. So this is the EMST 150. It starts at 30 centimeters of water pressure. Okay, why? And I will explain about the breather, Krista. The starts at 30 centimeters of water pressure, not zero. So number one is this device appropriate for the very frail, for the very weak? The answer is no. Okay, 30 centimeters of water pressure. What that means, folks, is that your individual patient would have to be able to have enough strength in the respiratory muscles in order to break the seal on that device. The way a pressure threshold device works is there's a spring inside of the housing. Okay, trying to get it in the best view here. There's a spring inside of the housing, which is that big, sort of wide, almost looks like a UFO middle part of the device. That spring will not open up the valve. This is really important. Will not open up the valve unless your patient produces an adequate pressure to open up the valve. Those individuals who are very late stage disease, very acute, probably, your immediate post-stroke, your late stage Parkinson's, your late stage MS, your late stage ALS, they're not going to have the ability to generate an expiratory pressure that high. Okay, so then when you go back to your slide and you say, well, how do I choose the 150 versus the 75? You're going to choose the 75 for your more frail patients. But then if people are like, well, that's not enough, Chris. Tell me how else. How else can I know that I should choose the 75 versus the 150? You want to know what the simplest answer is? Listen to their cough. Listen to their cough. If their cough is weak, they're going to be a user of EMST 75. If you've got a weak cough, you cannot break the seal on an EMST 150. People that have a weak cough must start with the EMST 75. It's going to be a much easier device for you to use, and you're not going to have purchased something where your patient will fail. So the simple thing is, how acute are they? And what does that cough sound like? If you got a wet, gurgly cough and a weak cough, you're having problems with feeding, you got to go to a 75. Okay. So listen to how they work. All right. Simple. You're going to take the device and you're basically going to take the cap and screw it counterclockwise, and that's going to set it at its lowest threshold. Most speech pathologists don't have a way, bear with me here, I'm trying to get through a lot of material, but most speech pathologists don't have a way to measure what we call maximum expiratory pressure and maximum inspiratory pressure. See, what we have to know about our patients is how strong are they? And we measure respiratory strength empirically, scientifically. According to the American Thoracic Society, we measure how strong somebody's expiratory muscles are with a measure called MEP, maximum expiratory pressure. And we measure how strong the diaphragm is through a measure called MIP, or maximum inspiratory pressure. Well, that's all well and good, but in order to do that, you have to have what's called a manometer in order to measure somebody's MIP and MEP. These are great tools, right? These tools allow you to measure empirically, and what's been done in all the research studies, trying to get that in good view, is to measure somebody's MIP or MEP. This is a $2,200 device. It's very simple to use, and I can, click up to the line that says MIP and MEP, and it will allow me to make those measures. Unfortunately, 90% of the people that I talk to don't have a manometer, right? And to do my MEP, I blow as hard into it, and it says that my MEP is 83, right? To do a MIP, I would just suck in as much air as I can. So to do a MEP, to do it appropriately, I would have the patient take as big a breath in as they can, blow as hard as I can, do my maximal effort, and it's going to record a number. To do a MIP, I would blow all my air out and suck in. No, it is not the same as a spirometer. We would never, ever use a spirometer to measure pressures. A spirometer is to measure lung volumes, completely related to somebody's weakness, but a completely different measure. So we must always think of pressure. A spirometer measures volume. It will not help us define how weak our patient is. There are only two measures to define respiratory muscle weakness, and the basis of that is your maximum expiratory pressure and your maximum inspiratory pressure. But what the heck? We don't have one of these. We don't have it. It's too expensive, right? So we have to find a way as clinicians, and we have developed a protocol and a way for you to be able to train your patients without having to, go and get one of these manometers. And another course that's coming up, I can tell you and direct you on cheaper manometers, and I will do that. I just don't have the time to do it today. So officially, if you do want to measure people's MIPS and MAPs, there are cheaper ways to do it. But 90% of us are going to go right to the device. And what we're going to do is we're going to go counterclockwise on that device so it's set at 0. And 0 for this particular device is 30 centimeters of water pressure. I'm going to have the patient take a maximal breath in. Listen, do the task right. Do it wrong, the devices don't work. All right. So you must have your patient take a maximal breath in and then blow out as hard as you can until you hear the seal break. So I'm coaching the patient. Chris, I want you to take a big breath in and blow as hard as you can. That's one trial. You heard the seal open, no problem. Repeat the task. Chris, I want you to take a big breath in, as big as you can now, as big as you can. Big breath in and blow. It's not in front of my teeth. My valve is below, I'm sorry, not below, behind my teeth. I may have to make sure it's in my oral cavity. I have to make sure my patient has a tight lip seal. I'm holding the cheeks gently. And I'm breaking the seal with no problem. Why? I'm a healthy female. 30 centimeters of water is not hard for me. So what I'm going to do when I get this device, you guys will, I don't think you'll see it on this, but I'm going to go back, share my screen for just a quick second. And if you look at this device, there is a little screw on the cap right there. And you're going to use that little screw as a landmark. And when you get the device, there's these little pillars, and there's 4 of them. So think of it like hands on a clock. And what I'm going to do is I'm going to take my setting that's all the way counterclockwise, and I'm going to just turn it to the next pillar. And this will be very obvious when you get the device. So I turned it about a quarter turn, and I had Casey send you the calibration chart for these devices as to what happens when you turn, whether it's the EMST 150 or the EMST 75, a quarter turn. And so when you look at your sheet, right, that's provided by Aspire, God, it's hard to get it's hard to get the camera to focus. Anyway, you have a sheet by Aspire that's a calibration chart, okay? And if you turn in a quarter turn, each quarter turn is about 7.5 centimeters of water pressure. So now I'm at 37.5. Big breath in and blow. I'm going to now, for demonstration purposes, I would do that with my patient. I would go another quarter turn. I would repeat. Big breath in and blow. I would go another quarter turn. And if I look at my calibration chart, I continue to see where I'm at, right, as I go through these quarter turns. And I do again. And I notice it's getting harder for me to do because I've gone 2 quarter turns. So I'm at 52.5 centimeters of water pressure. I'm going to go another quarter turn, which is at 60. I'm going to do another quarter turn, which is bringing me up to 63.75. It's not a linear device. It doesn't incrementally go the same centimeters of water pressure on every turn, but I've got a chart. And that's hard. Okay, I'm at 63.75 centimeters of water pressure. The protocol, let's come back to the shared screen for a second. The protocol says this: we must do these trials, 5 breaths equals 1 trial, and we're going to do 5 trials through the device. And we're going to do it for 5 weeks, okay? And they're going to train every week, all right? I'm going to stop sharing. So I'm going to have my patient in front of me, and the very first thing I need to do, and you're right, Kirsten, there's a little bit of back and forth. We're not truly obtaining their MIPS and MEPS, but we're getting them darn close to where we want to start their training. And I felt effort at 63.75. Now remember, we don't want folks straining. We don't want to see their carotid arteries popping out of their neck. We don't want to see their eyes bulging. We don't want to see them complain of a migraine headache. We don't want them to feel dizzy. We want to get them at a training that is effortful but comfortable for you to be able to do 5 sets of 5 trials. That's 25 breaths through a device. Okay. So for me, 63.75 centimeters of water, I'm not sure I could do 25 breaths through that. So as you're talking to your patient, you say, Chris, and you have an effort scale, make your effort scale. Take a pencil, make a 0 and make a 5 and segment it into equal increments. You just take a ruler, 1, 2, 3, 4, 5, 0 or 0, 0, 1, 2, 3, 4, or 1, 2, 3, 4, 5. Make every line between the numbers equidistant. And you say, Chris, what was your effort level when you did that trial? Right? And so I do the trial, and I tell you that's a 4. I'm not sure I'm going to train somebody to start at a 4. So I'm going to take my device and I'm going to back it a quarter turn. And that's going to bring me to 60 centimeters water based on my chart. And I'm going to show you a set of 5 trials. Trial 1, trial 2, trial 3, trial 4, trial 5, okay? Then I'm going to rest. I'm going to rest maybe 30 seconds, talk to my patient about something else, and I'm going to set and get ready for my next set of 5. I'm going to ask him how effortful was that to do those 5 trials. Okay? No different when you're using the EMS T75. You have a calibration chart for that device as well. It's different than the 150, but you're going to go through the exact same process. So very simply, make yourself an effort scale. Easy to do. And it's not, anything that's hard for anybody to do. Use that effort scale to know, just like if you were at a gym, man, that weight's too hard. I'm not going to be able to do that amount, 8 repetitions or whatever you do at a gym for your biceps. Skeletal muscle physiology is the same, whether it's the limb, the arm, the respiratory muscles, the vocal fold muscles, the oral muscles, it all responds to these adaptations. I'm going to go back to the slides for just a second so I can share that with you, and then we'll go back and look at the other devices, right? Muscle physiology says we've got to progressively overload the muscle in order for it to respond in a neuroplastic way. That's why each week, what we do is once we find that setting for that person, for Chris, the patient, I leave that device at that setting for 1 week. And I have them train 5 days a week, 5 days a week. And I have them just train one day, one time, right? Those 5 days, one time, and do those 25 breaths at that setting. Then when they come back in, I go back through the process to see whether or not their MEP or their ability to go to a higher setting has increased. And typically, after 2 weeks, if not a week, they're absolutely ready for that device to go up another notch, maybe a quarter turn, maybe a half a turn. The cool thing about muscles is they neurally adapt very quickly. I mean, within 2 weeks, when we're training our muscles, neuroadaptations happen very, very, very quickly, right? So these protocols you have to trust. They've been in just about every study. They work, and the evidence base that we have that's shared with you on the slides, whether it's cough, swallow, etc., voice is based on this protocol. Now, there are some variations we can make. I'm going to stop sharing my screen. There are some variations that we can make. If our patient can't train 5 days a week, the minimum I want to see you train patients is 3 days a week. Okay, any less than that, they're just not gonna respond as well. The muscle's not gonna have the ability to kind of break down, repair itself, and create that improvement in strength. All right. So, Michelle, to your question, how much effort are you aiming for? I don't want them to feel uncomfortable. I don't want them to feel strained. I'd like them to train at around between a 3 and a 4. I just don't want, in contraindications, I don't want people to feel dizzy. I don't want them pushing so hard. I don't want there to be extreme effort. I want there to be a moderate amount of effort, right? And I don't want it to be at a 1 or a 2 because then I know they can go that much higher. I just want it to be safe for them. If your patient can't do the 5 weeks, then train them as much as they can. Your job as a speech pathologist is introduce these devices to them, even if it's an acute care. Introduce the device to them and then make the appropriate progressive note to wherever they're stepping down to. These things are going to be used in rehabilitation from acute care all the way out to outpatient care. The exact protocol that you use for the EMST 150 is the same for the EMST 150, just a different calibration chart. Now, when we want to do inspiratory, right? We just take our device and we slip it into our adapter. And now, and in fact, I'm going to just take my device out and turn it down a little bit. And I'm going to breathe all of my air out. And this one honks when you break the valve. It's a little strange, but it does. That means they broke the seal. So you're just putting the device into the IA adapter, right, in order to change it to an inspiratory device. You follow the exact same protocol. The power of 5s, they're going to do the same protocol that we just showed you for expiratory, and you're going to advance it just like you would with expiratory. Obviously, we're using inspiratory training for different purposes. Let me just review this really quickly for you. If I want to help people with airway protection, if I want to grab the evidence out there on improving cough function, I'm going to use an expiratory device. If I want to grab the evidence on how expiratory activates the pharyngeal muscles and helps to close the vocal folds, right? I'm going to use an expiratory device. Everything we know about reductions in penetration aspiration, about improving pharyngeal pressure development, in terms of improving hyolaryngeal complex elevation, in terms of improving, and back to the point about paresis, vocal fold adduction is an expiratory device. Everything that we know about improving vocal loudness is an expiratory device. The vocal folds actually adduct when you do a high expiratory event. That's why it's great for people who need vocal fold closure. When you choose an inspiratory device, you're working with people that feel breathless. You're working with people that have difficulties with oxygenation. And you can use an inspiratory device when they're oxygen supplemented. Just let the people in pulmonary nursing know what you're doing, but that's not going to create a problem. Oxygen levels don't fluctuate when you're using these devices. There's been studies that with pulse ox that because the breakage of the valve is so short, you're not spiking oxygen, but what you're doing is you're helping the inspiratory muscles get stronger so people can ventilate on their own better. So inspiratory for people that have low oxygenation is going to help with their minute volume ventilation. It's going to make their diaphragm stronger. It's going to make their inspiratory muscles stronger. If you have any question about the complexity of the patient, always for our own liability, ask the physician. Um, you know, I don't want people to overtrain. So to your question, more than once a day, it's not necessary. I mean, you've got to give the muscles some time to recover too, right? And they're already training every day of the week. You're actually going to damage the muscles. You're going to, there's no sense in any of the exercise physiology literature are they telling you to train 3-4 times a day. It's silly. You're going backwards instead of forward. You don't need to. You just need to have the appropriate load. That's why we don't go into the gym and lift a 2-pound weight. We go to the gym and we try to find the maximal weight that we can repeat so that our muscles will neurally adapt and eventually become hypertrophic, get bigger, be able to create more force, right? So that's very important. We don't want people to overtrain. Now, really quickly, I think, and I want to go back a couple of things and make sure I answer some questions. So there is, in the device world, and somebody asked a question about this. In the device world, we got to use pressure threshold devices because I'm going to tell you this, okay? Resistance devices don't work. And they work to some extent, but a straw is a resistance device, okay? And so this is a training device. It's a straw. It cost me a penny. I can just take it from McDonald's. Doesn't cost me anything. So that was a joke. It's a tube of narrowing diameter, right? So that makes my muscles. Does that make my muscles stronger? Okay, here's another tube. It's coffee stirrer. Okay, those are resistance devices. Here's another one, the breather. That's a resistance device. I'm going to tell you in a short period of time, as quickly as I can, what the differences are. Pressure threshold devices only open up their valve when you produce the pressure that you have dialed into the device. It makes the muscles stronger because they must contract in order to produce that inspiratory or expiratory force, aka pressure. The power breathe devices are also pressure threshold devices. They have been on the market longer than the Aspire respiratory devices. They are developed out of the UK. They are for sale on Amazon.com. They are also of a wide variety of inspiratory and expiratory devices with different ranges. They work equally as well as the Aspire products. So you have choices on which pressure threshold device to buy. They have a similar protocol. I like the protocol we developed. It has been consistently used in the literature. Can you, if you have a frailer patient, can you modify the protocol? Absolutely. The protocol is really trying to get people to do their maximum through the device. And that's how you sort of, as I think somebody said, it might take a few times for me to figure out where to start with the device, right? The cool thing about the Power Breathe, I just want to show you this really quickly, and you can certainly email me and ask me questions, but they have what's called a smart adapter that attaches right to the device itself. You just take off the mouthpiece and it attaches right to the mouthpiece. That is a built-in manometer that they developed for close to, I think it's like a $300 device. It's so cool because it's a built-in manometer that connects right to the device itself. It has an app that is able to be seen on your phone for the patient to get direct biofeedback. So when you're looking, if you're working with patients that want something more sophisticated, long-term use, right? These devices have to be continually used because we all know I'm a great example of detraining. I haven't been going to the gym as much because of some schedule issues, and my muscles and my legs need help, right? Because they've detrained. But the cool thing is I can retrain and rebuild my muscles back up probably within 2 to 4 weeks if I'm consistent. But people will detrain. Okay, people will detrain. I love the smart adapter. But here's the answer to the question about resistance devices. This is critically important for you to remember. Resistance devices are flow dependent. Listen. So the calibration of those devices is so hard to figure out because guess what? They're only calibrated at one flow. So if your patient completes the task with a different flow rate, you will never know what those pressures actually are that are produced through the device. We've known this since 1927. The reason we refer to the other devices as pressure threshold is because you must produce the pressure to open up the device. The training effect is set by you, and the valve only opens as a function of pressure. With resistance devices, it's flow dependent. My bias is rather than buy a resistance device, go out and buy yourself some straws. They don't work as effectively. There has been a dabble of peer-reviewed literature now coming out showing some effects, but the majority, 90% of what you know about swallow, about cough, right? From voluntary cough to enhancements of cough reflex to those things about swallow to that improvement in voice and to now the changes in lip and cheek muscle. That is all utilizing a pressure threshold device. Okay, so you have to be an educated consumer. You have to be an educated consumer. You cannot just utilize the device because it's cheaper or because it's available. And yes, these devices have been shown, Julie, to improve velopharyngeal closure because when you do a high expiratory pressure, the velopharyngeal port activates. Levator veli palatini, tensor veli palatini actually contracts. So absolutely. And you know, the thing about Carly, the amount of time in between sets, here's the thing. I'm going to say it right now. We have done a crappy job looking at dosage. We really don't know if 3 days a week or 5 days a week or, 5 reps. We're going with the protocol that's been developed, that's workable, that's easy for people to remember. But one thing that the American Thoracic Society will tell you, and the literature will tell you, we need more studies on dosage. We do. We have to be able to, I hope in the future, maybe only train people a couple days a week because we know that 2 days a week is the same as 5 days a week. So we've got to clarify that. So in terms of clarifying the protocol, Kelly, it's you're doing one trial, you do 5 trials, right? And you do 5 sets of those 5. So you're doing 25 breaths through the device 1 day a week at the setting that you've decided on the patient. So it's not 5 trials per day. It's 5 sets of 25 breaths through the device, either inspiratory or expiratory. Casey, you tell me what you want me to answer. I know you're running into, we got a couple of minutes.
Yeah.
Let's see what we can
So
do.
one question came through the Q&A. What's the role of expiratory or RMST in complete AIS spinal cord injury at levels like C3 and 4?
Well, C3, C4, you're knocking out your inspiratory muscles are going to be you're in a complex case. Everything's gone. If your spinal cord level is that high, The only thing you're dealing with that you've got left is some accessory muscles of inspiratory. I would go with trying an inspiratory trainer to activate those accessory muscles, but it's not you're not going to do expiratory because you don't have any thoracic innervation.
Would this be appropriate for a patient with cerebral palsy?
Yeah, I mean, it just depends on, go look at the symptomatology. There's no reason that, in fact, the very first study that was ever done utilizing a face mask with expiratory muscle strength training was done with a cerebral palsy child. So what are the symptoms? What are the symptoms? And if the patient can understand the directions, has cognitive ability. These things are not harmful. We got these devices set. It's safe. Contraindications, uncontrolled hypertension, right, where somebody's blood pressure is spiking all the time. We got to be careful with that. Really complex cardiac issues. We got to talk to cardiologists. Uncontrolled reflux, which means no medication or something. If you do a lot of expiratory training with somebody that's got uncontrolled reflux, you might agitate it. But look at the indications on the Aspire website. They're very few. They're very few. And we're starting to use these devices post-stroke, almost 2, 3 weeks after the stroke, right? So yeah, you can use it with pediatrics, absolutely. There's MIP and MEP data published for pediatrics. Look at the American Thoracic Society website. It's all going to be about, can they understand the directions? So typically 6, 7, 8 years old. Somebody below 5, it might be a little bit more tricky.
All right. So we are just about at time. Chris, thank
Perfect.
you so much. I know a question came through about the calibration. Those handouts are actually posted on the course page underneath the slides. So they're on the course page. If you still have trouble finding them, just DM me and we can help with that. Chris, I want to say thank you so much for sharing all of this information with us.
Well,
Um,
thank you so much.
yeah, and we're going to jump into our next presentation with George Barnes and Ross Dunbar.
Hi, everyone.
Hi.
How's it going, Casey?
Good.
Hey, good day. This is Ross.
And this is George. We're happy to be here. Excited. Should we just jump into it?
Yeah.
All right. Ross, you want to take the intro?
Yeah, and I'm gonna pull up our screen and share here. So good day, everybody. I'm gonna give me just 1 second. And some slight technical difficulties. So are you seeing my screen?
Yes.
Okay, great. Sorry about that. And hmm,
Here we go.
all right, but now I lost my controller sorry about that. So George, if you want to just do a quick introduction, and I guess while I'm kind of moving through this a little bit until I find my
Yeah,
visual,
sure.
but yeah, we're welcome everybody. Thank you for having us. We're speaking today about optimizing tongue endurance and focusing on strength and stability. And so we have a few disclosures that I hopefully will be able to. Let's see. Okay, I'm having some technical difficulties. There we go. Are you seeing it now?
Actually, it looks like we just lost it. It's just a white screen here.
Hmm.
We were seeing it before, actually.
All right.
Okay, we got your slide deck now. It's just not in presentation mode anymore.
I think if you just go up to slideshow, you should be able to run it that way.
Yeah. Yeah, how about we do this? Can you see it well enough?
It's not in slideshow right now.
Right, but for some reason when I click into slideshow, it's not.
Oh, yep. Now we got it.
Okay. All right, so sorry about that. Here are the disclosures for both George and I. So I'm the CEO and co-founder, and George is our Chief Dysphagia Officer, and we're both employees of Progia. And in terms of our objective for today, two things primarily. One is just focusing on the clinical rationale for device assistance in defining lingual strengthening. And then obviously a device overview and just some brief understandings of advantages about the devices that Progia Medical has available. We're going to do a quick roundtable introduction, and then we are going to move into the evidence of supporting lingual strengthening. And then we're going to move into some current evidence based research around the device and lingual strengthening. And then we're going to move into the device overview. Oops. So just quickly about myself. Again, I'm Ross Dunbar. I'm the CEO and co-founder of Progia Medical. I've got a background in operations, small and large entities, and a myriad of different industries from medtech, biopharma, stem and gene therapy, and a myriad of industries. In terms of just a quick background about Progia, and then I'll hand it over to George. Progia was founded in 2023. We're here in Minneapolis, Minnesota. We have formed a company in early 2023 with myself and Gary Graham, who's the other co-founder. Gary and I have known each other for over 20 years, and we established the company to acquire some technology from an entity that was called Swallow Strong. Some of you may know that device. It was invented and brought to market initially by Dr. Joanne Robbins. We have established the acquisition and moved that technology to Progia in early 2023. Dr. Joanne Robbins still is an advisor to us and works with us as we embark on our relaunch of our product. So we further developed the Swallow Strong device, and now we have relaunched it under the name Swallow Therapy System. And that was done in late 2024. And we've been in market for just over a year. And now we've launched a couple of additional devices called the Insta and the modular swallow therapy system. And we're also working with other organizations and professors. Dr. Melandraki, George Melandraki, is an individual that we're helping commercialize and going to be bringing that into the planned Progia portfolio in the future, which is a wearable sensor. But right now we're focusing on the lingual devices. And so with that, and I'll just quickly as I kind of outline the presentation, I want to make sure that you understand from a personal perspective. I have been impacted. We've had family members, and that's really how I got into the business, is via an introduction about the technology. And as I started to learn more and understand the technology that existed at the time of our acquisition and the impact that we'd had in our family between ALS, Parkinson's, and some other swallowing disabilities, that we decided to, Gary and I decided to launch into the device. So with that, I'm going to hand it over to George, and I'll let him introduce himself.
Thank you, Ross. And thank you, everyone, for coming on today to learn about lingual strengthening, which is the topic that we're going to cover, and on a Saturday morning, nonetheless. Whenever I do a talk like this, I'm always so impressed with those of you who prioritize learning and growing in our field. You could literally be doing anything today. It's your time away from work, away from the craziness of what I'm sure is a very busy and overwhelming schedule. But instead, you've chosen to be here, dedicating your time and energy to learning, right? Learning to be a better SLP and being a better SLP to better serve your patients. So that alone gives me hope that we're all going to make a huge difference in this field for our profession and for those who we seek to serve. So once again, thank you. A little bit about myself before I get started here. I'm George Barnes, board certified specialist in swallowing and swallowing disorders. And for the past year, I've had the honor of serving as chief dysphagia officer at Progea Medical. So my mission is really to help people eat and drink the things they love. It's as simple and complicated as that. And working with Ross and Progea really has been a fun, exciting, and fulfilling way to achieve that mission. And what I feel I do best is basically take complex concepts, break them down, filter them out, and get the valuable takeaways so that you and I can use them to make our patients' lives better. So similarly, my role with Progea is to take our innovative research-based technology and communicate its capabilities so SLPs have an understanding of the practicality behind them and the ease of use of devices in general, and Progea's devices. And so my goal is to ensure that the devices basically act as an extension of your expertise, not just a gimmick with bells and whistles that make a lot of noise but don't really do much to help the patient, right? Which is why we're all here today, to help the patient. And so while it's incredibly important to get access to these innovative tools, and I know access is complicated, and that's a talk for another time, but it's a priority to get access to these tools and get them in your hands to improve swallowing for our patients. But what I feel is even more important, and Dr. Sapienza touched on this as well, is to acknowledge what I consider and what many in the field consider to be our most important tools and assets. What's that, you might be asking? It's the knowledge and expertise of the SLPs in our field to wield those high-tech tools. So knowledge really is the foundation of everything else that comes next. It's the building block that really, if missing, it's going to crumble our chances of using high-tech devices effectively. So today we're going to try to make sure that we get that knowledge in your hands as well in order to use devices effectively. Specifically, again, we're going to be talking about lingual strengthening, assessment as well. Really so that you can have the practical insights and take those insights to your patients and help them achieve their goals. Okay, so with that in mind, we're going to talk about lingual strengthening, lingual functioning, and the basics here. Thank you, Ross, for changing the slide there. So, are we building a bicep or a marathon runner? What's the purpose of exercising the tongue to begin with? If we don't understand these exercise principles, specifically as they relate to the tongue, which you'll notice is a much different muscle than many or most others in the body, it's actually a muscular hydrostat. of which there are it's really only the tongue and the throat that acts like a hydrostat. And they're unlike other muscles that we're more accustomed to exercising in the body. So if we don't understand that first, it's really hard to understand the other principles here. So let's say you're starting an exercise routine for your patient, right? You've maybe identified some weakness. So you first are going to measure their maximum isometric pressure. That is how much lingual force they're able to generate, particularly against something, whether it be your palate or a sensor or a tongue depressor. And devices are the way that you can get that measurement in an objective, quantifiable way. So say you get that number, you realize that there is a deficit there, and you begin exercising their tongue. And you have great news for the patient. Right after the exercises you've done, their pressure generation has skyrocketed. Okay, you and the patient celebrate. You did it. Objectively, the tongue is stronger, and you can prove it with these hard, cold numbers. But then you watch them during a meal. And while they seem great for the first 5 minutes, they then slowly begin to fatigue. Their endurance starts to drag, and they begin to show signs of difficulty again. Okay, so what did we do wrong? The tongue is not a bicep, right? We're not looking for a 1 rep max here. Yes, device-assisted intervention for the tongue should focus on strength, but also on optimizing endurance. And this is really important. So sure, we want to improve objectively and quantifiably to make our rehab managers happy, to make the insurance companies happy, and everybody loves to see their max go up in kilopascals. But more importantly is the goal that the patient has, which is to improve functionally. Okay, next slide, please, Ross. The tongue. Okay, when you picture the tongue, remember that it's not your typical muscle. It's highly specialized. It's actually closer in form to the tentacle of an octopus than to an arm or a leg. Kind of blows your mind when you think about it that way, right? But it's true. And it's important to realize that its primary job during the meal is not one massive push of the bolus from the mouth to the esophagus. We're not snakes, right? We don't eat once a week or once a month. And if you're like me, you're constantly eating, and maybe to the point of detriment, but that's for another talk. Our tongues, the human tongue, is meant to deliver sustained, coordinated, repeated sequences of pressure generation, swallow after swallow, meal after meal, and day after day. Think about it this way. The average person swallows about 50 times each meal and about 700 times throughout the day. Imagine doing 700 bicep curls every single day. Your arm would fall off, right? So we're not looking for a simple power generating force from the tongue. Instead, we're looking for sustained pressure generation over extended periods of time. And we know that age-related decline or presbyophagia reduces that force, which justifies lingual resistance training for this population as well as for many others, like those with neurological disease. Okay, because of those constant repetitions, the tongue requires a unique type of muscle to function called what we talked about before. It's called a muscular hydrostat. It's one of the most impressive muscles in the human body, actually. And you can see that on this slide, it's unlike skeletal muscles. Think of it more like a water balloon. It squeezes and stretches and changes shape without changing its volume. So like when you squeeze a water balloon, it stretches out, right? And the tongue has the added benefit of not popping when you squeeze it too hard. But similarly, when the tongue contracts in one area, it simply expands in the other. Okay, next slide, please. Okay, lingual muscles. So the tongue has two main muscle groups: intrinsic muscles that change the tongue shape and extrinsic muscles that move and position it. The coordination of these muscles is essential for three main functions: forming the food into a bolus, keeping the bolus contained so that it doesn't fall out of the mouth or fall back into the throat before you're ready for it, and generating the pressure needed to drive the bolus from the mouth and through the pharynx. Now, let's look at the intrinsic tongue muscles for a moment and figure out why it is that the tongue is built so differently from, say, skeletal muscles. Let's look specifically at the posterior region of the base of tongue that generates the base of tongue retraction and propulsion of the bolus. Now, these parts of the tongue contain a higher proportion of what's called slow twitch type 1 muscle fibers. These fibers are built for fatigue resistance because a meal is essentially an endurance event. It's a marathon, not a sprint. We have 20 to 30 minutes typically of sequential swallowing throughout a meal, unless you're like me at the hospital and you eat your lunch in 7.5 minutes. But if we only train for, say, a maximum isometric pressure, we are optimizing those fast twitch type 2 muscle fibers, but we're neglecting the type 1 muscle fibers needed to finish that long distance race that is a full meal of swallowing. And in stroke patients, research demonstrates that deficits in oral control, specifically tongue control on the MBS-IMP, correlate more strongly with reduced endurance versus reduced pressure alone. The big takeaway here is that the capacity for sustained pressure dictates the ability to maintain lingual coordination and control throughout an entire meal. Next slide, please. Okay, metrics for lingual function. So what does all of this mean for your therapy, right? We want this to be practical. So let's say your patient has poor oral containment and control and decreased base of tongue retraction resulting in anterior loss and oropharyngeal residue. And while it's tempting to focus solely on pressure generating power and just focusing on those kilopascals for strength purposes so that we can push the bolus through the pharynx like a boxer against a bag, that is not the key. Instead, our goal is to target all of the following. Strength, of course, that maximum isometric pressure. We're not going to leave that alone. It's just not going to be the whole picture. And so that's simply pressing the tongue as hard as possible against the hard palate. Isometric endurance, which is holding sub-maximal pressure, so less than your maximum, kind of like holding a plank with the tongue. And then we have isotonic endurance, and this involves rapidly repeating contractions at a sub-maximal pressure until the patient fatigues, kind of like doing crunches with the tongue. And then we have power. This is the rapid repeated exertion of near maximum pressure. And then there's speed, which is the rapid repeated exertion of minimum pressure, kind of like a light rapid tapping of the tongue with no specific pressure minimum. And then functional reserve, which is just a concept to keep in mind. And this measures the difference between a patient's maximum pressure and their pressure during a functional swallow. Okay, so the goal is not necessarily to work harder, but to work smarter. If endurance or coordination is the issue, maxing out every single repetition isn't going to get your patients the results they're looking for. Next slide, please. Okay, exercise principles. So first I want to acknowledge that Dr. Sapienza touched on at least some of this. I only caught the end during some of the Q&A. But we're going to talk about some of these principles, and I apologize if some of this overlaps. So unfortunately, as Dr. Sapienza mentioned, we still don't have any research-based dosage guidelines for really any of our dysphagia exercises, but for lingual exercises as well. So what common practice is today is to apply the long-standing principles that have guided skeletal muscle exercises over the years and apply those to the tongue and the pharynx. But we need to acknowledge that this is not a perfect solution because the tongue is not a skeletal muscle. It's kind of like using exercise principles to get really good at playing the trumpet. It's kind of useful, but it's not a perfect match. Okay. So with that in mind, let's talk about the principles, keeping in mind that they are not going to be a perfect match for you when you're doing your lingual strengthening, but more as a guide, kind of a foundation of where to get started. So in order to induce biological change, a therapy duration of at least 8 to 12 weeks is typically recommended. Anything less than that is likely insufficient. So to ensure the patient is working hard enough, we use a dose prescription based on 4 components. Intensity, which is the percentage of the patient's max used in exercise. Repetitions, the number of times the action is performed per set. Frequency, the number of sets per day and days per week. Duration, the total number of weeks the exercise is performed. And that's the main four. And we can apply these dose components specifically to both strength exercises and endurance exercises. And again, take these numbers with a grain of salt. Remember, they're meant to be applied for skeletal muscles. But for strength training, intensity is typically set between around 60 and 75% of the patient's max. Common starting point for repetitions is 3 sets, 10 reps per day. Frequency is usually 5 days a week. For endurance training, which is essentially a press and hold of the tongue, intensity is set around 50% of the max with a hold time that is challenging but still achievable. Repetitions can range from 10 to 25%. Frequency is often 2 to 4 sets per day, but only 2 to 3 days per week. So for both strength and endurance, you can actually use a rating scale. It's a rating of perceived exertion scale, like the board category ratio 10. And this can help you guide your prescription, since again, these numbers are not directly applicable to lingual strengthening. Okay, next slide, please. Little review of the evidence here. So is it worth going through all the trouble of having your facility purchase a device? We want to ask ourselves these questions, not only for ourselves, but also because we know the administration is going to ask. I'm a parent of 2 young boys, so I know exactly what it feels like to pay for things that nobody actually needs. So what does the literature say about lingual resistance training, and do your patients with dysphagia actually need it? Systematic reviews have confirmed that lingual resistance training consistently and reliably increases raw maximum isometric pressure across diverse populations. Furthermore, a major randomized clinical trial involved typically in aging results, and they demonstrated remarkable flexibility of the tongue's response. So all tested dosing protocols were actually equally effective at increasing maximum isometric pressure. In other words, the training works regardless of dosing, at least in this study. But here's where the magic happens. Researchers took a look at functional transference, which is how the progress we make from a given exercise actually translates to functional improvement. And they found that only the group receiving maximum intensity with real-time biofeedback, that is with the use of a device, showed statistically significant improvements in swallowing function in the form of saliva swallows. So it was the biofeedback that facilitated the functional transference in this study, which makes sense, right? Biofeedback is kind of like your coach telling you if you're swinging the racket the right way, or if you're singing off key when you're singing. You know, without biofeedback, we're just doing a lot of the wrong things over and over again and never leaving room for improvement. And this is where the device-led exercise comes in. Using a device with your lingual resistance training provides visual feedback to optimize neuroplasticity, ensuring the patient practices that coordinated motor control required to successfully transfer the gains they make during therapy into a functional swallow. So the objective quantifiable numbers we get from our devices are great for assessment purposes, but it's the feedback that encourages the right level of power, endurance, and control. And with that, we have real progress during real activities like eating and drinking, whatever it is the patient wants to eat and drink. Okay, next slide, please. So that's the therapy component of lingual strengthening. How about the assessment component? Picture the last time you had a bedside swallowing evaluation. How did you assess lingual strength? If you're like me, you used a gloved finger on the cheek or a tongue depressor to get what can only be described as a very crude measure of lingual function. It's not very objective, not very quantifiable or scientific, is it? So device-led assessments allow you to get that hard, cold data at the bedside, so you're not guessing at what's going on. This allows you to assess risk, justify an instrumental exam, and make more informed judgments before you even start the therapeutic process. Because the patient may not even need therapy, or they may look fine but are actually suffering. The point is, we simply don't know without a device. And if we establish that the patient does in fact have decreased lingual capacity, then we're going to have a device to actually work on the rehab component. We get our diagnosis, and then we offer a prescription in the form of device-led lingual resistance training. And then don't forget about that biofeedback component. Remember what the study said about how biofeedback helps you take those gains and put them in the right direction to actually impact mealtime success. By using the visual components of our devices in real time to get that feedback during the exercise, you're providing a direction for them that they wouldn't have otherwise. It's the difference between showing them a number on a screen or a display in the form of a meter versus just telling them to swallow hard and hoping for the best. Without feedback, it's sort of like wandering in the woods without a compass. We have no idea where we're going or what we're doing. It's that sensory input that ensures that the strength you build actually translates into a safer, more efficient swallow. And remember, you're not just building stronger muscle, we're programming a smarter muscle that's well equipped to address the patient's specific deficits. Okay, next slide, please. So, takeaways. What can we do this week to improve our practice? Remember to stop treating the tongue like Arnold's biceps. It's closer to a tentacle than to an arm, and closer to a marathon runner than to a bodybuilder. Start measuring endurance versus just mere strength or power. Prioritize device-assisted biofeedback during your therapy to maximize functional transference and actually achieve the goal that matters most to your patient: swallowing a pill, finishing a meal without becoming exhausted, or keeping their coffee in their mouth so it doesn't spill out and embarrass them. And number 3, use devices for both objective assessment and to prescribe and guide treatment. So, all in all, we need a map to understand the territory, but also acknowledge that the map is not the territory itself. We need to understand how many kilopascals the patient can achieve in order to understand if there's a deficit, but the goal is not to increase kilopascals. The goal is using the biofeedback to help the patient with their actual goal. Say, complete a full meal without fatigue, without struggle, and with confidence. That's the power of device-assisted lingual training. Okay, now Ross is going to show you some of the devices and talk to you a little bit more about how device-led therapy can help your patients, really help you and your patients in therapy.
Great. Thank you, George. Yes, so transitioning to the device, and we'll leave about 10 minutes at the end of the session for questions and dialogue. So hold your questions, and I'll work with Casey and George to facilitate any questions that arise, and we'll have a dialogue around that. So as of today, Progea Medical has 2 devices that are focused on lingual strengthening. One is what we call the Insta, and the other is the Swallow Therapy System. The Swallow Therapy System was our flagship device. As I mentioned, that we acquired the predicate device from Swallow Strong. We've evolved it. We've listened to many hundreds of speech-language pathologists over the last year or so, and came up with a better mousetrap, if you will. And along that way, in those discussions, it became very apparent and a need for a tool, not just in the outpatient therapy cycle, but also in the acute and early rehab cycle. So listening to those speech-language pathologists, we developed what we call the Insta. And I just want to pause on that for a second, because as part of our vision and our strategy as an entity, and what we want to be able to provide speech-language pathologists is a toolbox. And so as we engage and learn more and evolve our entity, it's important for us to get feedback. And so we're always welcome to that. And we want to be alongside of you to create these tools. And so the Insta came out of those early discussions, and about 9 months later, we had the Insta. And so just diving into the specifics a little bit more about each of the devices. This is, and I don't know if you can see these. I've got both devices here. The Insta is a smaller device, and the therapy device has a myriad of different components, which I'll cover here in just a minute. In terms of the Insta, we tried to address a fundamental, and George touched on this, a fundamental issue in that early stage assessment cycle. It became very apparent that there wasn't a tool that could give you an objective measurement. And we focused on trying to answer a fundamental question, which is what is the lingual strength, not just visually, but also lingually. And so we developed the device to answer the question so that you could have an objective tool. And so as in terms of the tool itself, just to at a very high level, we're trying to provide an objective measurement on the not only just in one place, but the anterior and posterior portions of the tongue. And so you'll see on the device or the mouthpiece a series of what we call bite locators. So you can bite down on the device, the mouthpiece, in the different locations to obtain that measurement in various places. And what's critical about this is you have the ability to have a very stable, repeatable measurement in different locations. And we focused primarily on adult applications, but because this is a single sensor that can measure in multiple places, you can also use this potentially with pediatric patients as well. So the idea here is that you're going to have a disposable portion and a reusable portion. So the handle is a very simple, lightweight tool that you can carry around in the microfiber pouch that's provided. And the mouthpiece then is a single patient, multi-use per patient device that just needs to be washed off, and then there's a storage container that you can set at the bedside. And it ultimately is giving you that objective reading in kilopascals. Oops. Sorry about that. Can still see my screen, I hope.
Yes, we can, Russ.
Okay, good. So in terms of some of the advantages of this device and what we're trying to make sure that we cover is that it's going to allow you to get that objective reading so that you can do a number of different things. It can guide your overall protocol. It will allow you to launch in a very secure manner, a innovative and interventional plan. You're also going to be able to justify with expertise, and so you're going to have that objective reading. In terms of some of the other aspects around the Insta device, it's a clean device. It's a portable device, and it's a very cost-effective, efficient device that you can move with you from room to room or patient to patient. So moving on to the swallow therapy system. This has a kit kind of mentality along with the device. You have the what we call a tablet and the mouthpiece, which is the blue portion. The tablet is a pre-programmed system that allows you to get that biofeedback. And within this kit, you can also buy what we call a modular swallow therapy system, which allows you to have a lower cost clinical model, which I'll explain here in just a little bit. But the basic components of the system are a tablet and the mouthpiece. And the mouthpiece, which is based off of the original technology, it has four sensors. The mouthpiece also has what we call a bite locator, which is similar to the Insta device, but it only has two locations. So you basically form this device or mouthpiece, excuse me, into the top of your mouth, and it allows for a customizable solution so that you're getting a very secure location and a repeatable location, which addresses some of the stability aspects with our device. And honestly is an advantage with our device. So you form the device mouthpiece into the upper part of the mouth. The lateral sides of the device are flexible, so it allows for much more comfortable fit. And you can see on the picture on the right, there's uh, the sensor is thicker in the posterior part of the device, and that allows for the sensor to come down into the oral cavity better. And so you get good range of motion. You're getting a direct sensor measurement with this device. And so it allows you to get that solid, repeatable, stable measurement in kilopascals. So just moving on, just to give you a little bit more of an understanding of the device when you're operating with it. This is a very high level overview. So you've got two basic screens within the system. You've got a patient view, which is on the left-hand side. That's very simple. You either start your therapy or you look at your history. Then on the right-hand side is the clinician portion. And this is password protected. It allows you to gather data and information and only alter it when the patient is in clinic. So just to give you a little bit more background around the device and its functionality. So the system is set up to be very efficient. You move from left to right in the protocol. So on the left-hand side is the setup, which is some just very basic clinical or clinic and patient information. So it's HIPAA compliant, so you can put in whatever identification information you need. And then the next button is around the tutorial portion, which has 3 videos, training videos embedded in the system. We also have an independent IFU or instructions for use that allows you to guide the patient and also be as a guidebook for you as a clinician. But we also have it embedded with the system so that the patient can take it home with them, use it in a home setting if they choose, and then it's also available for caregivers if they're not with them in the clinic. And then the furthest button to the right is just a macro opportunity for you as a clinician to change the device, the cognitive, or excuse me, the views based on their cognitive capability, date and time, etc. So this is all a wireless closed loop system that's secure. The third button, or excuse me, I'm going to just go into the tutorial just for a brief moment. Within the tutorial section, you've got the videos, you've got the training around the mouthpiece and the forming of it. And then before you go and set the baseline, we want to make sure that the patient has the ability to understand the capability of the device and how it fits and feels in their mouth. And so we go into this device example. And the device example allows the patient to put it in their mouth and experience it. It also gives you as a clinician an opportunity to understand their swallow. In this example, you can see the delta between a standard swallow and an effortful swallow across all 4 sensors. You can turn off and on the sensors depending upon their situation. So if they say they have a glycectomy or they have had a stroke and they've got a diminished portion of their tongue, you can turn those sensors off and on. And so this allows you to really start to understand where they're at and develop a very refined, very focused therapy session. So once they've gotten acclimated to it, you're going to move into the next portion, which is where you're going to be setting a baseline. This is very key. So our device is meeting the patient really where they're at. So it's fully calibrated. We calibrate every system and device before it leaves our factory. in Minneapolis. And so we want to make sure that the patient establishes that baseline. So you have the ability, as I mentioned, to turn the sensors off and on. And once you've determined that, we'll say they want to use all four sensors, you go to what we call our baseline setting. And this part of the process is taking three measurements at a minimum and then coming up with a mean and defining what their actual baseline measurement is. So this is their starting point. So once you've done that, now you move into developing their therapy protocol. And as George mentioned, we're wanting to focus on endurance, stability, as well as pressure. And so on the left-hand side of this screen, which is all again in the tablet, you've identified the baseline, which in this particular case, it's referred to as the maximum pressure, which is 29.5 kilopascals. So that's what came over from setting the baseline. And you have the ability to modify what the goal percentage is. In this particular case, it's set at 80% and 5 repetitions. It does the math for you. It calculates what their goal is. And in this particular case, the patient's set at 5 repetitions and 23.6 kilopascals for their therapy goal. And then on the right-hand side is all about endurance. And here again, you can modify to deal with the isometric, isotropic aspects that are part of the tongue strengthening protocols. And you can either have a very aggressive or a moderate scenario when establishing that endurance. And basically, you're wanting them to press and hold. They have a window of opportunity to hit and press that target, but it's totally adjustable by you as the clinician. So that's where you as a therapist really hone and define the protocol and their therapy plan. So once they've established that with you, now you can move actually into their therapy session. And so this screen just explains at a very high level what is going on within the therapy portion of it. So once you click the start button, you're going to have a screen. And in this particular case, I'm just showing the difference that you can alter within the system. So the top screen is a very simple view of the therapy, and the bottom portion has more information. So you can adjust this based upon their cognitive capability and what they feel comfortable with and what they want to know. So once you've done that, you're starting their therapy. The objective is to move the needle into the green, and then, as I mentioned earlier, you want to hold it for at least 2.5 seconds. And so once you have done that, you're either going to get a thumbs up or a thumbs down. It's got some haptics that allow you to get that immediate biofeedback, which is what's going to motivate the patients. And so once they start to work through their therapy cycle, they also have the ability to look at their history. And you can look at it both in terms of a tabular form, which is on the top, or you can convert it into a graph. So very simple, press of the button to evaluate. And the graph is intended again to be a motivator so that you can get that biofeedback and understand if you're actually improving over time. How am I doing on time here? So I think we're doing good. So good. And so just moving into some of the advantages and gets kind of basic aspects of the system. One, just to repeat, the therapy system has 4 sensors. The Insta has just the one, and is meant for a different type of engagement with the patient. And so allowing you to have both an acute and a therapy cycle as part of your protocol. So you've got the 4 sensors so you can adjust it. You also have a consistent direct measurement by inserting your teeth in the bite locator and allowing you to know where in the mouth the patient is pressing. and it also allows you then to have that stable reading. Also, there's an ergonomic handle aspect to it, so you're not diminished if you have a diminished condition or situation with your extremities, then you have a more comfortable ergonomic fit. It also is wireless, and it pairs directly with the tablet. And we currently don't have any on and off switches on the therapy system except for on the tablet. So once you're connected, it's very simple to pair it and use it. And as I mentioned earlier, it's also customizable. And then in terms, additionally here, I think you're getting that real-time feedback with the device. So you're knowing what your pressure, what your endurance, and your goals are. It's obviously a visually engaging device. You've got the tutorials as well, both within the system and then also within an IFU or instructions for use. And then last is, I think this is important because of the demands on you as speech language pathologists and the industry in particular, where there's a lot of desire to be efficient, engaging with the patients. And so our system allows you to get that biofeedback system, be engaging and obviously efficient. And also, we believe that our systems are cost effective. So I think with that, we'll open it up to questions and dialogue for either the research and clinical supportive evidence as well as the device. And feel free to scan the QR code that will take you to our website. So Casey or George, if you could help me facilitate any questions, that would be fantastic.
Sure. Casey, is it okay if I
Yeah,
read?
that's totally fine.
Okay. All right. And just stop us if we're getting into any kind of uncharted territory with, the barriers between continuing education and other initiatives.
Okay.
But I'll just start at the top here. So we have a lot of people wondering about cost. So
Sure.
the very first question, how much does the Insta cost and the per patient disposable pieces?
Sure, sure. And I'm going to refrain from this presentation from giving a specific quote because we like to work with clinics and individual practices and also individual SLPs. But basically, what we are communicating and what we are trying to establish as a good model is that from a return on investment, you will be less than or around 3 patients for the device in terms of a total return on investment, and then also around the individual or the consumable portions, which are the mouthpieces. You will overcome any net loss within 3 therapy sessions. So we try to work closely and do work closely with the hospitals and organizations that we're engaged with. And so we understand that cost is imperative. And we obviously don't have a HCPCS code, which is what would be used for DME devices, so durable medical equipment. So that is not established. That is one of our goals that we're going to be pursuing and engaging in a study so that there would be coverage. But right now we're not in a group setting like this. I'm not going to provide direct costing, but what I will tell you is it's extremely competitive. The Insta is significantly lower than obviously the therapy system. But the consumables are what we want to make sure are driving your model as clinicians in a clinic so that you get that good return on investment.
And then there's the last question that just came in is, an estimate range, if possible, comparing more or less with the IOP with its disposable blue bulbs.
Sure. Yeah, so in terms of that comparison, we are significantly less, and depending upon the volume and the scenarios, as I mentioned, significantly less. You also, with the consumable, you have multiple bulbs that you typically have to purchase over a therapy cycle, so a 10 to 12-week cycle. So with our device, you only have to buy one portion of the consumable. In terms of the Insta, that is, again, you're going to have the anterior posterior, the secure bite locator, and that is, in terms of the consumable portion, is right around the cost of the bulbs. And the handle is significantly less than the IOP and also than the tongometer in terms of what the handle costs.
And then along the same lines, Ross, Courtney asked if the main device, so the swallow therapy system, the blue part, is that also single patient use?
Yeah. So great question. And so a couple of things. So hopefully you can see this. So we have a tube. We have our base and core system because we launched into the VA initially. They wanted an all-encompassing system. So we created that. And so the handle is all one piece. The way and what we just launched at ASHA is a modular system. So the mouthpiece from the neck here to the mouthpiece is removable. And so that is what we call our consumable and is for a single patient. Depending upon your model and how you want to run your business or how the hospital wants to, or long-term care operations want to manage the system, you could either have a system where they can take home or they can use it in the facility. But the handle and the tablet are all part of what we're saying is a reusable portion. It's wiped down. You wipe down with like a cavi wipe with a HP cavi wipe. And we also, I guess, just so you understand our vision a little bit more, we anticipate that we'll continue to evolve this system. We're also, as I mentioned earlier, we're working with Dr. Melandraki to come up with another tool, which she's announced through her IEAT lab, and the wearable sensor for the pharyngeal aspect measurement in an effortful swallow cycle. So we're also going to have that as an additional tool. So we're looking at ways to create a complementary toolbox for all lingual and other aspects of your swallow therapy cycle.
Okay. And just to clear up, there's a couple of questions about, how the patient is able to kind of take it home and how the therapy, the speech pathologist can communicate with that patient as they're doing their exercises, as they're getting their results.
Yeah. So here, I'll just show you here. I'm going to connect to the device. And right now, you can hopefully see it here, but this gives you a little bit of an idea. So it does not today connect with the internet. So we did that on purpose for security reasons and some of the challenges around cybersecurity. We are intending on within the next year, and this would all be part of a rollout and an upgrade if you were to purchase a system today. But we would update the system to be an app-driven scenario, but we want to integrate those other tools at the same time. So you'd start with this. You would have a visual cue The intent would be for them to take the device home. We've gotten a lot of really positive feedback around the actual tablet and the use of the tablet. It's integrated with the case, and so it's very easy for the patient to take with them back and forth to the clinic. And so you can guide them and you can observe them with the device, and also then they can bring it into clinic. And this device and the data can be downloaded on a stick or with a stick, or you can actually, eh, uh, I guess, write it down within your clinic.
So that brings us up to almost 12 o'clock, and I know we don't want to go after. So there's just a question about our contacts. I put my email address in the chat. Ross, I don't know if you want to do the same. I know people can also go to the website and contact us there for any other questions that we didn't cover. Since we are at 12 o'clock, and I know, Casey, we're on a tight schedule, I don't want to be disrespectful for those who come after us.
Yep, and you can go to care@progiamedical.com. So that's another way to get in touch with both George and I.
Well, thank you both so much for this presentation. And just also wanted to add, like George said, he added his contact information in the chat. I'm also going to add Chris Sapienza's as well, because I know there were some questions. So please feel free to reach out to everyone with any questions that you have via email. And I'm going to introduce our next presenter.
Sounds great.
Michelle Hofnagel.
Thank you, everyone. Appreciate your time.
Thank you, everyone.
Thank you for the introduction, and thank you for hosting me. Can you hear me okay?
Yes.
Good, fantastic, excellent. Thank you so much. Well, we'll just jump right in. So hello, I'm Michelle Hofnagel. So we're going to start with introductions. I'm going to tell a little bit about myself and then share my disclosures. But I'd like to give you an opportunity to maybe take a moment, take a breath if you need to run to the restroom, if you need to grab a snack, because we, much like our patients, also can have a change to our attention. We can have a change to our ability to continue to focus. And so maybe right now I'm going to ask you to check in on yourself and be aware of, if you need a minute, if you need a break, this would be a perfect time because you don't really have to learn about me. And then we can dig into the meat of this. So my name is Michelle Hofnagel. I am a speech language pathologist. I have I also am board certified from the Academy of Neurologic Communication Disorders and Sciences. My disclosures are I do receive a salary from UF Health Jacksonville and an honorarium from the medical SLP. So I am a speech language pathologist who's been practicing for just over 17 years. And I have worked in acute care, outpatient. I have worked in head and neck cancer, inpatient rehabilitation. So only have not done skilled nursing facility, home health, and assisted living facilities. And also, I've only ever worked with adults. But that doesn't mean that what we're going to discuss today couldn't be translated to the pediatric population. So I'm here to discuss today about attention. Awareness, attention, and working memory, and how it can impact our abilities at home, at work, at school, and in the community. So I'm hoping that this will be very interactive, and I'm hoping that what you learn today will not only help your patients, but that it will also help you, maybe your family members, loved ones, friends, because we all can have the ability to improve our awareness, improve our attention. So without further ado, let's just jump in. So I didn't prepare a PowerPoint. There are some handouts that you'll have available. So if you have questions, and I really do, if you have patient-specific questions, if there's examples, I really do want to make sure that this is interactive. So without further ado, let's jump in. So the base for all of our cognitive communication skills is awareness. If I don't have awareness, I don't have the ability to improve my attention because I don't know I'm not paying attention. If I don't have good awareness and attention, I also don't have working memory. So let's dig into these and let's describe them a little bit further. So Dr. Amishi Jha, J-H-A, she is a neuroscientist who teaches at the University of Miami. And where I work, so I work right now in an outpatient clinic where I have the privilege of serving veterans and first responders who have experienced a traumatic brain injury. I've been in this clinic now for just over 4 years since we opened. We're one of 6 academic sites where we get to treat this population. And as a clinician, I came with some good cognitive communication skills. I knew how to target attention. I knew how to target memory. But what I didn't have is actually a really good way to basically explain to my patients what is awareness, what is attention, and what is working memory. And if I can't clearly explain it, how in the world am I going to target it? And so a colleague that I work with, she's absolutely incredible. She is a somatic movement and mindfulness therapist. And so not only has she changed my practice, but she's changed me personally. And so maybe, just maybe, what I'm going to share today, I think it'll actually have an impact on you as well. So that was a side note. So let's go back to Dr. Amishi Jha, a neuroscientist at the University of Miami. She wrote a book called Peak Mind. You have that reference. I highly recommend that you read it. It's a very awesome book with great information. But my colleague that I work with, her name is Bethany, she introduced this book to me and these topics. And so the reason I'm referencing it is because it's going to be the easiest way to frame awareness, attention, and working memory. So, thank you very much for posting that the handouts are available on the website. So let's start with awareness. What does it mean to be aware? That means I have insight into what's going on. So I can be aware of lots of things, right? I can be aware of tactile information, auditory information. I can be aware of visual information. I can be aware of how I'm perceiving it, right? Like an example of a person who has really poor awareness. Let's say you're wearing a pair of shoes that don't fit, but you're so busy focusing on everything else that you're working on, you don't realize that your feet hurt. Maybe you don't realize that you're getting that blister, right? We're so focused on the task at hand that I'm not aware that there's this noise over here or that my feet are hurting. And so that's a breakdown in awareness. We know that before we can help our patients improve their attention and improve their working memory, they have to have awareness. So one of the best ways to target awareness is through, we can use a video, the person can watch themselves. But let's jump into what is awareness. So if I'm Dr. Amishi Jha, her reference is awareness is like a floodlight. So my floodlight goes on and I'm aware of everything around me, but I'm not really paying attention. Have you ever been going to get the scissors, you head towards the room, you walk through the doorway, and you don't remember what you went in there for? That's actually our awareness. So it's a little bit of a floodlight coming on, and now I can't remember what I was going in there for. We retrace our steps. That improves our attention and our working memory, which I'll describe in just a moment. But so think of awareness as kind of, we've got this floodlight. So imagine you're a patient, any one of our patients in any one of our settings. You just had a stroke. Doctors and nurses are coming in. You're thinking about, how am I going to do my job? How am I going to maintain my family? What am I going to do? You're stuck in this floodlight. Can you imagine remembering what your medication recommendations are, what the doctor said you'd have to do, how many appointments you have? It's overwhelming, right? And so this information, I'm hoping you'll not only use it with a patient with a cognitive communication impairment, but this information could actually be shared with any and all patients. Imagine your patient has dysphagia, but they're so overwhelmed by what's going on, they can't pay attention and they can't remember. So this is going to impact them as well. So I actually highly recommend with every patient, no matter what diagnosis, maybe you give a quick crash course in how our brain works. Because understanding the difference between my amygdala and all of my brain flashing with this floodlight, I need to be able to get back to my attention. So let's shift from awareness, where I'm aware that something's going on. So hopefully you were aware if you needed to run to the restroom. You were aware if you needed to have a snack. You're aware if maybe you needed to stretch for a second, because I challenge you to now give me your attention, right? And so first thing I would love to ask you to do is pull out a piece of paper And hopefully you have a pen and a paper handy. And I want you to just draw some type of a line, any type of a line. Ready, go. Okay, cool. So hopefully everybody just drew a little bit of a line. And so now you're probably like, okay, what is Michelle making me do? Why are we doing this? If that is the case, you maybe were in floodlight because you weren't paying attention to what you're doing. You're trying to problem solve everything that's going on. So now let's talk about attention. Attention is like a flashlight. We all have one flashlight. I'm saying this again. We have one attention. The default mode network of all brains is for our mind to wander. While I'm talking right now, while George was just talking, Dr. Sapienza was talking, there's a potential that your brain went somewhere else. It's normal to have this happen. Brain injury, stroke, trauma, dealing with a lot of stressors, this happens more often. So if we were in a pitch black warehouse right now, and I've got my flashlight, I've got my attention, and I'm shining it at different objects, this is what I'm noticing. Maybe this is what I'm hearing. This is what I'm seeing. And now all of a sudden I hear a scary noise behind me. I drop my flashlight and the floodlights are on. I am now paying attention to nothing and I'm trying to take in everything. So I'm going to challenge you and I'm going to challenge your flashlight. So you're going to go back to the line that you just drew. And I want you to pay attention to what the pen or pencil feels like while you trace over that line. The world does not exist. Right now, I'm just asking you to get a hold of your flashlight. So ready? Let's do it. Did it feel different? Because if it did, you just got a hold of your flashlight. That's our attention. So thank you for paying attention. So there are types of attention. We have one attention, but there's types, right? We know sustained attention. So sustained attention, the way we describe it to our patients, is it's like when you are sucked in. You ever watch a really good movie, you're sucked into a podcast, this amazing conversation, and the whole world disappears because you're selecting your attention. Selective attention for sometimes our really impaired patients is actually one of the hardest things after awareness. And for our highest level patients, they're good at more complex attention, but they've lost the ability to have sustained attention. And so before we can work on complex tasks, we have to reestablish basic attention. So attention, we know sustained, we've got our flashlight. So what is selective attention? We all know what this is, right? Right now, if your kiddo is making noise or your puppy's running by or somebody walks in and out of the room, it's requiring your selective attention to keep your flashlight trained here while ignoring non-target information. So if you describe to your patients, they know that feeling, right? If you have them say, hey, what was the last time you were like really sucked into something? Okay, sweet. That's what sustained attention feels like. What's the last time you were able to do that, even if there was background noise? A lot of times our patients will say, well, man, I'll watch TV and I don't hear my spouse talking to me. That's a beautiful example of selective attention. And so if we can help a person remember when they felt it, then we can have them start to recreate that feeling. So the final attention is our complex attention. And this is what we do most often. This is where we are switching our flashlight from task to task quickly. In order to switch, we have to remember where we left off. So our attention muscle, this ability to pay attention, it never turns off. We never lose attention. We lose control of attention. So just like our eyes, our vision, if we can see, our vision doesn't turn off. Our hearing doesn't turn off. Our sense of smell doesn't turn off. We maybe get tired with our eyes or we get tired of listening. We can get tired of controlling our attention, but our attention never turns off. It just goes to the default, which is mind wandering. So we practice bringing it back. So this idea of complex attention. If you are cooking and you look at a recipe and you add the ingredient and then you shift right back to the recipe and then you add the next ingredient, congratulations, you have good complex attention. If you do that, but you forgot which ingredient you needed to add, that's actually breakdown in working memory, which is a part of attention we're going to talk about in just a second. So this switching attention between two related things, look at the recipe, add the ingredient, or unrelated things, look at the recipe, add the ingredient, carry on a conversation with your spouse. That is complex attention with multiple variables. Imagine the last time you were sitting in your office, you're prepping for your patient, your phone rings, you get an email, your colleague is asking you a question. This is all complex attention. The more often we switch our attention, the more tired we get. It is called vigilance decrement. Vigilance decrement. So what we train patients is how do we maybe reduce some distractions? Let's say you're in acute care and your patient, okay, they're overwhelmed. So you've gotten them out of floodlight. You've helped them get back to their flashlight. One way to do that, literally as simple as it is, grab a pen or a pencil or your finger or their finger or a dot on the wall. I don't care what it is, but if you just have them look at it, they can blink for 30 seconds. You just have them focus on the pen. By doing this, they found their flashlight. And by having that flashlight, now you have their attention. And when you notice that it wanders, give them a second. Have them notice if they can become aware that the flashlight is wandering, you can bring them back. You ever see it in your patient's eyes, like their eyes, they kind of like start drifting off, or they're not listening? So the beautiful thing about describing to them that it's a flashlight, all you have to do is a quick visual cue, and you're able to get them back on track. And I apologize. So selective attention, I don't know if you just heard it. My doorbell just rang. Nobody ever comes to my house, but my attention just went ring and back. So let's hope that nobody rings it again. But here we are in life, right? Things never happen in a bubble, not for our patients and not for us. And so I think this is where knowing how our attention works helps us have control over it. All right, so now let's move on to the tertiary step of working memory. Working memory is a dry erase board in our brain. It uses disappearing ink. I just wrote that. Michelle just wrote. A dry erase board is in your brain and it uses disappearing ink. So if you remembered that, it'll be there when you go back for it. Remember my example of going to get the scissors? So we walked through that doorway, going through doorways, turns on our floodlights, wipes the dry erase board, we drop our flashlight, we don't remember what we went in there for. So then we can work on improving this, right? I can improve my recall if I associate it, if I visualize it. And so we can practice this with our patients. So these are the three core concepts. So working memory, attention, and awareness. Any questions on that? Feel free to type them in, shout them out. Let's just make this more fluid. So when you were listening to George talk just now, and he compared the tongue to something, do you remember what it was? If you do, 1, you were paying attention, and 2, it made it onto your dry erase board, and then 3, that's already in your long-term memory, because our working memory is the conduit between right now and our long-term memory. And so if you remembered, oh, he said an octopus tentacle, you pulled that from your long-term memory to this present moment. Our patients that say, I can't remember anything, it's probably because they weren't paying attention. Okay, so how do we use this therapeutically? What in the world do we do with this? So let's break it down, because I think keeping some of those workbooks, don't throw them all away. Those workbooks can be a great way to establish this foundational ability, because life is therapy. But if I give a patient, okay, I want you to go home and I want you to pay attention while you're cooking, they don't have a foundation for that yet. And so Kristen and Casey, the amazing people at MedSLP, they put together workbook style examples that you can take a look at. But so if you happen to have a Walk textbook, it's referenced off of, if you were to check out Walk number 2, page 58, think of this like visual scanning task. I'm shifting my attention to read Aisha's question. So the complexity of the task or newness of the task seems to affect the complex attention. So for example, cooking a new recipe versus one that you've made before, 100%. Absolutely, right? So if my working memory knows I'm familiar with this, I'm able to quickly pull it back to my working memory. And so it's going to be easier to shift along versus new learning. right? So imagine our patients, you're teaching them new swallow exercises. This is going to be a lot harder to pay attention and encode than if you were to have them just do something that they've always done. So an example of that, if I'm training a patient on how to do chin tuck against resistance, well, if I'm going to, so we're going to do it, right? So physically, we're going to improve that encoding because we've actually done the action. But then I like to use an association. Think of the sculpture Rodin, the thinker. And so we're going to do the thinker. So now I've made an association to help the person think about how they could be using this exercise. So maybe they'll remember because they'll think about it to do it later, right? So that can be something to do, but you're 100% right that the more complex, because we haven't done it before, is a little bit harder. So back to what I was saying, because my working memory succeeded. So if you were to do like the visual scanning task with your patient, so the complex line that you and I drew, or maybe you just drew a single line, it doesn't matter. That's a way to grab a hold of your attention. Have your patient do that. Have them draw a line. Have them trace over that line and notice their attention. Have them do a more complex line and see if they keep their focus or if the mind starts to wander and bring it back. If you're doing this visual scanning task, like the example from the walk, having them do this, thinking, this is on my attention and this is like reading. So I'm going to pay attention to these targets and the whole world doesn't matter. And I'm going to notice when my flashlight is hijacked. I'm going to notice when it's distracted, and I'm going to bring it back to the task. And hopefully your patient will bring it back to the task without judgment. Because if I go from I'm paying attention to circling, the one that you have on the example is to circle the M's and the R's. So if I'm MR, 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 oh, I wonder what I'm doing for dinner. Oh, dang it, Michelle. So if I get further and further from my target, because I'm now being self-critical, I am hurting my attention, right? And our patients, I think we as humans, we do this all the time where we're pretty hard on ourselves. So if we can help our patient go, we're all right, and we're just practicing. So let's bring our focus back. And so if you can help them like either ground it back, like where are my feet? Take a breath. Okay, back to circling these letters. And then how do they do that when they are reading? And I'm just reading, so my attention, please forgive me. I'm shifting over to make sure I don't miss anything on comments because I'd rather keep this dynamic. When it comes to working memory, distractions take up space in working memory. Yeah, so like right now, honestly, I have pinned what I'm going to come back to, what I was talking about, right? And I'm shifting over to here, right, which is complex attention, which is why working memory is a part of attention. So I'm holding on to this, shifting over to here, reading this, and then being able to come back. And so as we are helping our patients work on the foundation of awareness and then the foundation of attention, we then also can include memory strategies. So if my patient is really low level, they're not going to be able to switch back and forth with this. This is where they're going to need to write things down, make a quick voice memo, or we're going to really watch them struggle. This person that can't switch back and forth between tasks and can't do complex attention, they're going to need somebody else to help them manage their activities of daily living because it's too impaired to be able to manage it. So there's a lot of people who can do this, but they don't do it well. They maybe feel overwhelmed. They maybe feel exhaustion. For the scope of this talk, we're not moving into executive function. I really want to keep it to awareness, attention, and working memory. So anything beyond the scope of that would be executive function, which is not under what the intent of this talk is. So we're going to keep it really concrete. So this could be a very impaired patient. It could be you're a very, very high level patient. Awareness is the foundation for all cognitive communication, followed by attention before we can target memory. Because if I'm not aware that I'm not remembering, I can't use a strategy. And so that's just going to kind of keep reinforcing that. The book that I referenced at the beginning was Peak Mind by Dr. Amishi Jha, J-H-A. Thank you for putting that in, Kelly. And so she also has a TED Talk. It's like 18 minutes long. She talks about mindfulness because mindfulness training is one of the best ways to get a hold of our attention. So let's throw out another memory task. So behind me in this little cabinet, I actually have a crested gecko. It's a little, he's a little gecko. And I opened the door so that you wouldn't have glare in your eyeballs. So maybe, just maybe, he shouldn't escape. But if he does, please let me know. So now I've asked you to shift your focus from here, maybe checking in on Orville, if you remembered his name, and shifting back. Okay, so now we've unpinned, we're going back to this. So our patient has now gone through and they're going line by line and they're practicing, where is my attention? Am I focused? And as soon as they're distracted, you could maybe have them keep a tally of how many times they got distracted. That improves awareness, right? And so, oh, I was distracted. Oh, I was distracted by being distracted. I was being self-critical about being distracted. Tally each one of those and then bring our focus back. And absolutely, I love this idea of self-monitoring because the patient can go through and say, okay, how many of these did I miss? How was my focus? How was my attention? And then we can start to we are going to bridge from these workbook type tasks to functional tasks. What is something you do in your day-to-day, maybe reading, where you're forgetting what you read? I love that comment, Megan. So I do use these strategies myself. We can all improve our attention. So right now, I hope our flashlights are here. So let's go back to this idea. So we've just done this, maybe this line drawing task. Maybe now we've done this letter circle identification task. And now we're going to read a sentence or a paragraph, depending on what our patient can do. And we're going to implement that. We're going to see how they do with their focus. How many of our patients tell us, I read that whole page and I have no idea what I just read? And that doesn't help us, right? And so the problem with that, if they have reading comprehension, the reason they don't remember what they read is because they weren't paying attention. Their brain was in mind wandering, and how many pages went by before they were aware that they were in mind wandering. And so the sooner we can get a person to notice that their flashlight is distracted and bring it back, the sooner we can get them to make progress. So let's talk about a couple more worksheets that can be helpful. So there's also things like matching. And so let's say you've got a word written or a number written, and then here's like a for example. So the example is in your sheet, but like this is walk 1, aphasia rehab, page 21. I love to present this verbally to my patient. So here we go. We're going to try it. Are you ready? I'm going to say a word. When you hear that word repeated, you're going to raise your hand. So, and then it's going to keep rotating. So it's not going to keep being that same word, but when you hear a word repeated, raise your hand. So if I say cute, charm, dots, mate, cute, kitten, anyone, kitten, pulse, rated, Tuesday, mode, bitten, Tuesday, raced. How'd you do? Were you focused? Or were you like, what is she talking about? Where did I go? Ah, right? We can start noticing in ourselves our own attention. And then this is going to help us notice it in our patients. So let's put ourselves in acute care. Let's say your patient doesn't have a cognitive communication disorder, but they're hospitalized and they have something else going on. If we gave them a quick crash course on awareness, attention, and working memory, and now I'm targeting dysphagia. I say, hey, you know what, because how many of our patients have autonomy when they're in the hospital or outpatient or at a skilled nursing facility, right? We lose this independence. We rely on other people. So we can help reinstall this feeling of independence in our patients no matter what we're targeting. So for example, let's say we're in inpatient rehab and my patient has dysphagia. So I'm going to do chin tuck against resistance, and I'm going to do an effortful pitch glide. Those are my 2 exercises I'm pulling out of the hat. Okay, so I've already educated my patient on them. I'm going to say we're going to do a chin press against resistance, and then we're going to, after every chin press against resistance, you're going to do an effortful pitch glide. And then when we're done with this, I want you to remember to tell me what therapy you have next. Okay, so now you would do your chin press against resistance, and then you just look at them. They're in charge of saying, okay, now I'm going to do an sweet. And then you could also add a little bit of self-monitoring, like Dr. Sapienza was saying, using like an effort scale. So you could mix this up for complex attention any way you want. We're going to do 2 reps, and then you're going to rate how much effort you put into it. We're going to do 2 reps, rate your effort. And then you're going to do an effortful swallow, and then you're going to have them be aware, did my swallow move more? Did I palpate my own throat? Or look in a mirror, or use, all these amazing technologies and things that we're learning about, did my strength get better? So I'm just encouraging us, we can do more in a session to help our patient's brain, even if we're targeting voice, targeting motor speech, targeting dysphagia. We can still help them really engage this attention, awareness, and working memory. Okay, so let's move forward. Any questions or thoughts? Feel free to like throw out specific patient examples. What's popping into mind? How are we thinking about this base idea? And then how does that translate to life? Because for me, the workbook can be a great way to establish awareness and establish attention. If I don't have awareness and attention, I can't work on executive function. I can't tell this patient to go home and improve the way that they perform at work, improve the way they manage their finances, manage their medications. So I love this question of how do we track the data for these skills activities? So for me, so I know what I'm targeting. So let's say I'm going to be targeting, maybe I'll have 3 tasks running at the same time. So maybe I am going to set up a prospective memory task. So now if this is my dysphagia patient, I'm just doing this because I want to help improve their brain. I'm not keeping data on them remembering to switch between tasks. I'm going to make sure I'm optimizing their exercises, but at the same time, I'm just going to help their brain. But let's say I am keeping data on prospective memory. So I want my patient to remember. So I'm targeting memory strategies. I'm either going to set an alarm if I want to do a time-based task, or I'm going to just have them internally remember at a certain time. So let's try it. So right now at 12:40, let's all just remember to think about Orville, make sure that he's doing okay. All right, so that's now on your dry erase board. Hopefully it's not the only thing and you're not like, oh no, oh no, oh no, oh no, because now that's going to hurt your attention for the rest of this. So we're back, we're thinking about Orville at 12:40 and we're here. So my patient has a prospective memory task set up. I'm going to keep data on that. Did they initiate independently? Yes or no? Did they remember independently? Yes or no? Okay, so I can keep data on just that component. And then I can also keep data on, if it's the visual scanning, I could do a couple of things. I could do an analog scale of how much effort did you put in to pay attention. I could keep track on how many times did you feel like you were distracted. I could keep data on how many cues did I have to give to redirect attention to the task. So it depends on the severity of your client. If they're super impaired and you're having to give total cues to redirect their flashlight or to be aware when they're distracted, that's a beautiful thing to keep data on. So for me, I just know what it is that I am targeting. So let's say I'm going to target awareness. So whatever task I put in front of them, be it verbal and listening for a target, be it visual scanning, be it responsive naming, I'm going to see if they're aware of their mistake, if they're aware of their attention wandering, maybe if they're aware that they need a repetition. So you can keep data on that. I hope that answered the question. Or, we can just be accuracy. So like how many of the R's did they miss when they were circling? And it could be like, how fast did they do it and how many R's? But really, truly, I feel like if we add too much complexity, so I want you to do it fast and I want you to, then the person maybe they're so like, and they're like wrestling through it that they don't actually, okay, backing up. Michelle got ahead of herself. So if we're in floodlight, we are not actually paying attention. So I can be in floodlight and try to complete a task. That isn't effective use of my brain, and our patients are going to be exhausted, which is why if we can get them back to their flashlight to complete the task, they do better. So like I love to say, this is a safe space to make a mistake. I expect you to make a mistake on this task. I expect your mind to wander. We are practicing getting a hold of our flashlight. And so whatever the task is that you put in front of them, be it reading a paragraph, be it writing, any task, if what you're targeting is awareness and self-monitoring, you have just now succeeded. And so now they can carry that over to, I'm going to shine my flashlight in a 5-minute conversation with my wife. I'm going to notice when I'm distracted and I'm not listening to what she's saying, or I'm not listening to what I'm saying, and I'm going to bring it back. And so that would be a way to start to generalize from the basic worksheet where we're establishing a foundation and to extrapolate into our lives. So right now, if you've kind of been distracted, if we're a little bit like, what in the heck is she talking about? Feel free to ask clarification questions. I'm here. I want to make sure we're thinking about how this can help with, every one of our populations, every setting that we sit in. Like, attention is definitely the foundation. So imagine you've got your patient who is in acute care. They don't have their ability to like kind of advocate for themselves. They know they need to take their medication, but they are kind of waiting on the nurse's schedule. How could we, as the provider, help them with attention and problem solving? Like, where is their memory so they can say, okay, when I watch the news at 6 p.m., I'm going to remember that the nurse should bring me my meds at that time. So now I've got my working memory and I've associated an event that should happen. And now I could advocate for myself. I could hit the call bell and say, hey, I think it's time for my evening meds. And maybe we'll irritate nursing by doing this, but oh well, at least the patient is advocating. And maybe if they still wait for the nurse, were they able to do it? So maybe they still had to wait for the nurse, but they independently thought about, I would have been able to initiate this at home and I would have been successful. So for patients that read through paragraphs and will realize that they zoned out after only a little while, in my clinical experience, which strategies have effectively helped in making reading and recalling fun? So I like to have, what does the person like to read? So sometimes practicing with something they don't love can be good for attention, right? Something kind of dry and boring, once you have it established, can still be good. So we know salience is great to get a hold of attention. And the reason our patients perform better when something is salient is because it grabs their attention. So I actually like to maybe pull out a basic research article, or I love to grab materials from my PT colleagues. So when they're targeting the vestibular system or how stress can impact balance, I'll go grab one of their articles and then we'll read that in my session so that the patient can carry it over to their PT session. So they're learning new information, right? They're learning about their vestibular system and they may find it a little bit boring, but it's very pertinent to what they should be doing. And so we break it down. Where's our flashlight? Okay, let's get through sentence 1. Let's pause. Could you teach it back to me? What did we just read? And if we don't have that, let's read it again. Okay, where was our flashlight? Did you visualize it while you read? Are you able to associate this with anything that you already know to make those connections on the working memory even better? And I think that that's a really great way to start helping with that. And recall then becomes fun because what you're going to do is you're going to get a dopamine dump in your patient's brain, and they're going to recognize that they can read and they can retain. And so even sometimes something as silly as like, we're going to pretend we're going on a picnic. I say a something, you say a something. I say a something, you say a something. But like we do where you have to repeat it back. So like if I said picnic basket and you say blanket, now I say picnic basket, blanket, frisbee. Picnic basket, blanket, frisbee, fruit. Picnic basket, blanket, frisbee, fruit. Right. And so we're just kind of keep adding to it. This can be nice turn taking for our patients. It can be nice word finding for our patients. Their floodlight might go on because it's a little bit of confrontation naming plus memory because they're having to remember what you had just said. It's a great way if you don't have pen and paper in front of you, you're in acute care. It's a really good way to just work on that attention as well as the word finding. And on that, I might only keep data on they remembered 6 out of 6 targets, or they took turns in a task with 80% accuracy, or I'd keep data. So I wouldn't keep data on everything. I know what I'm working on, and I know all the different components of the brain, but I know my patient's goal and what they need to improve. And that's what I would keep data on and document. Because our brains, we're doing a whole bunch of things at one time, right? And so just know what is the patient's functional goal and then how to target it. How do I work with people? Oh, so yes, similar to the idea of using body doubling as an ADHD strategy. Body doubling. I don't know that I'm familiar with this. And if I'm not, I'm going to learn and I'm going to just say thank you. So if it's something I should know right now to answer your question, sweet. Otherwise, because I'm going to unburden my working memory and I'm going to write it down, body doubling. Thank you. And I'm going to look into that. So how do we work with people on the ASD spectrum and with ADHD? So, and have an acquired brain injury? The same thing works. So it may be a little bit more challenging, but these same strategies work because the brain functions are the same. So we know that with ADHD, a person may become hyper-focused. And so maybe that's more that sustained attention. And so we're going to practice awareness of how long have I been sucked into this YouTube video, or how long have I spent on this? And then how do I shift from this and back? I love the idea of attention and awareness in relation to dysphagia. I find that tactile cues, I apologize, my thingy just moved and now I have to find it again. See what's happening in my brain? Tactile cues are very important to awareness for bonuses of severe cognition impairments. Yes, because when we're so tactile, so just think about our awareness and our attention and our working memory. If I'm going to remember to go get the scissors, if I think of it in my head and then I walk through that doorway and I forget it, it's because I only thought about it. If I literally say it out loud, I thought it, I moved my mouth, and I heard myself say it. That's 3 modalities to get it on my dry erase board. So when it's wiped, I can rewrite it on there without any effort. And so that's an important thing. Are we 1 minute late? Did we remember what we were remembering? Okay, cool. Moving on. And so I always think about, so brain injury clients have many internal distractions and lots of distractions. So my patient population, lots of trauma, lots of internal distractions, and I will promise you that this works. I'm going to back up. I want to give just kind of a quick case study because this also helps with like PTSD, tinnitus. So I think it captures what you're saying there, Courtney. So, and thank you for working with this amazing population as well. So the line drawing, this is also one of your attachments. This is something that I made. I just made it in Word. It's nothing fancy, but we do know that writing, like prediction, like actually writing in cursive is an executive function task because we have to plan on what's the next move. It helps with prefrontal cortex development. Anyway, so line drawing. So this little piece of paper, I will give to one of my patients, my most complex, I'm talking like super high level, running their own business, amazing professionals who've had a traumatic brain injury, maybe PTSD, maybe, military sexual trauma, you name it. And I'll give them this and I'll say, pick one of these lines. And usually they look at me like I'm a little bit crazy. Like, just pick one of these lines and pick one of these highlighters. I have a little bin of highlighters. They get to pick whichever color they want. A lot of times a person who's had trauma has a hard time with choice. And so by just giving them a choice, you turn on their floodlights. And again, you reassure them that they are safe and that they're in this safe space, and we're going to just practice this attention. So one of my patients just recently treated, he made a choice. He decided he was going to do the top line. So he grabs a highlighter and he goes through it. And I asked him how it went. And I'm looking at him the whole time. He did not breathe. He was definitely in floodlight. He got it done. And I asked him, how much work was that on a little single straight line analog scale from like 0 to maximum effort? He put it greater than 75% of the way for how hard he worked to trace that line. Okay, so now we're aware of how hard he worked, and let's try it again and let's pay attention. So let's breathe first. Let's kind of ground, right? Maybe shake out a little bit of that tension. This line's not going to eat us. We can do this. So now, same highlighter, another line you pick. And I want us to think about breathing while you do the next one. So he traced along the next line and he breathed. Super robotic. He said it was better, a little less effort. So then we talked a little bit about what breathing could look like. Maybe diaphragmatic breathing. I explained a little bit about, I pull out my mirror because I love visual and I love tactile cues, right? So a little bit of like, palpating their little stomach while they breathe in. And he's like, well, I was a scuba diver. I trained people in scuba. We did this in the military. And I knew that if I talked, I had to regulate my breathing better. So I'm like, okay, sweet, let's do this. So let's count out loud while you do the next one. So he just quietly counted 1, 2, 3, 4. And now we rated effort. And wow, was that way better. Okay, sweet. Now I want you to repeat. So we're generalizing. Repeat that same ability, that same attention, that same awareness, that same effort without a floodlight. And let's do one more. And so he did that. And it was awesome. So now we've done 4. And so his homework that evening was to take the paper home and do the last two in a different environment with recreating that same experience. And what this did was is establishing his confidence that he could regulate his nervous system, he could grab a hold of his flashlight, and he could pay attention. And so whenever we kind of got a little bit worked up in other sessions, because that was session number 1, I would just say, remember the lines. And he's like, oh yeah, okay, good, I got this. And so our second to last session, I put a blank of this sheet of paper just on the table in front of him. And I had the privilege of having one of my colleagues come and shadow the session. And we decided we were going to go on a field trip. We were going to go down to the coffee shop and practice like integrating all of the different areas that we had targeted. But I set this in front of him and he described to her what that paper meant, what it felt like, and how he did it. And then we moved over to the coffee shop and he was able to have his back to the door. He picked the most challenging place to sit. He was able to ground, breathe, and engage in conversation, initiating, turn taking, topic maintenance, thought organization, word finding with a novel communication partner in a distracting setting. And so we took it from the most basic, simple workbook, drawing lines on a piece of paper to establish a foundation to accomplish his most challenging goals. And I think that that is super, super helpful. So back to this, Jill, I'm coming back to you with this tactile cues. Is this when a person palpates their own larynx during dysphagia therapy or other options? So I'm happy to have my patient feel my throat. I'm happy to have them feel their throat. So have you ever had one of those patients who's like, and I know this isn't a dysphagia course, but like they're like splinting everything and they're like, I'm going to swallow as strong as I can. And like nothing moves. So then I'll just have them like go, if you can see my scrawny little throat, but like almost like a yodel, right? If I drop the base of tongue, my throat descends. If I bring it up, and so if I swallow, so now I've achieved movement. I don't care if they feel my throat, they feel their throat, and you can do it with or without sound. It doesn't matter. So don't hurt their voice, right? That's not what I'm going for. Feel it, swallow. You just increase their awareness. You just increase their attention. You just increase their metacognition, their ability to think about what was happening. So thank you for sharing. So I want to make sure like more questions, more thought, more like how do we think about this in all of our different settings? So I guess my take home. So what I encourage you to do tonight. I want you to find one person. Oh, thank you. I've done this for many years for my laryngeal crazy control. In fact, a neurologist thought if he looked in my fMRI that it would be a crazy, crazy area in my brain to control all this nuts. Okay, moving on. So I challenge you to practice your working memory. If you're able to think about this, even if you just think, okay, what is my awareness? How do I get back to my flashlight? And how can I improve my working memory? If you can explain to a person what is floodlight, you know what this feels like. We all know what floodlight, fight, flight, freeze. We know what it feels like. We know when our flashlight is hijacked. So a little quick, neuroanatomy, our amygdala is out there to protect us. And the amygdala turns on the floodlight. It literally takes our prefrontal cortex offline. I can no longer pay attention. I no longer have access to good working memory. I can't sequence. I can't self-monitor. I can't deal with my frustration, right? And so I did a demo and discuss a little while back about executive function. If you're interested in watching that, we go into that realm. But so floodlight comes on. We really, truly can't just wrestle back to flashlight. I'm going to give an example. So I worked with this amazing colleague. Her name is Rachel. I loved her to death. And Rachel decided to go and work in the pediatric world, which I respect because, sometimes when you have a kid and it's just easier, but I loved working with her with our veteran population. And Rachel did an amazing job with doing an evaluation. And so I'm paying attention and I'm doing my chart review because she had done the eval and I'm going to be treating the patient in our intensive outpatient program. And so I'm just reading the note and I'm trying to prep my chart. And I can't hold on to my flashlight. And I'm like, Michelle, what is wrong? This should not take you this long. What is going on? I'm sad. Okay, I'm sad because I miss Rach. So I'm wrestling my flashlight back. So instead what I did is I turned on my awareness and I went, oh, I'm sad. I became aware of why I was wrestling my flashlight. And I took a second and I reprioritized my goal. I prioritized my goal is to take care of myself. So I stood up, I took a breath, I maybe cried for a few seconds. I love her, I'm glad she's happy, but I can still lament the fact that I don't get to work with her. And after I took that moment and that became my new goal, I was able to bring my flashlight back to the task and crank it out in no time at all. And so this happens to us, this happens to our patients. And Bethany, my amazing somatic mindfulness therapist that I personally benefit from and every one of our patients benefit from, she has shared a very simple tool. If you're hijacked and you're in your floodlight and you can't get a hold of your flashlight, and it's generating a whole bunch of content, maybe saying bad things about you, or, right, we have this internal critic. Wrestling back to flashlight doesn't work, but finding our flashlight does. So if you grounding is feet, hips, hands. Where are my feet? Where are my hips? Where are my hands? This automatically sticks us back into our body. It takes your flashlight from whatever content your brain was just generating, and it brings us back here. And then you can take a breath. And now you can get back to your goal. Because this idea of this vigilance decrement, that's what I was experiencing. And this is cognitively exhausting. So noticing what we're doing, our patients noticing what they're doing, increasing awareness, we can now start to self-monitor and self-regulate and get back to our flashlight where our memories work. Because if I'm holding up, how many fingers am I holding up right now? Why don't you remember? Doesn't your memory work? What's wrong? You weren't paying attention. You couldn't see them. And I think that is a profound example for our patients. I often will just, like, my hand is under my desk or my hand's behind my back or folded. How many fingers am I holding up? Why don't you remember? Because I tell you that their memory is bad. Their attention is the problem. And so our attention is the problem in conversation. Our attention is the problem in reading. Our attention is the problem a lot of times in word finding, thought organization. What did I say? Who did I say that to? I love to tell my patients, like, I'm not a cardboard cutout. If you replaced me with somebody else, would you say the same things? Who are you talking to? Are you talking at me or are you talking with me? Because that'll help them be aware of their own conversation. What am I saying? All right, back to questions, back to this. I apologize for that tangent. Not really, I don't really apologize. So speaking of attention, I'm distracted by medical appointments for otitis media. Can we go back and watch this again? Yes, I love it, right? We all have internal distractions. We don't live in a bubble. The more we can recognize when we're distracted, the more we can notice and we can bring it back. When you read Peak Mind, because you will, because it's an amazing book and you might just as well. But Dr. Amishi Jha says you'll run across people where you've noticed that they have the ability to use their working memory and then they are 100% engaged here. They could have been in the middle of a task. You walk into their office, they've got it, it's on their working memory, and they are here. They are ready for you. Or they may say, hey, I really want to look at this body double thing. Let me quickly write that down so I can come right back to you because I don't want it to distract me. And so then we also have external aids, right? We should help our patients using external aids because they probably don't have the ability right now to use association and visualization so fantastically. Okay. I realized that I use these strategies in my open rehab office. Sometimes I purposefully allow myself to get distracted in order to socially, yes, absolutely, right? So we let sorry, I didn't finish reading that in case this is recorded and nobody reads it, to improve our social relationships and build with our coworkers. So yes, our coworkers walking in, these are distractions, but they might be welcome distractions. So I love to have my patients, we're going to be working on circling these things. Okay, you just nailed that. You're doing awesome. Now I'm going to add some background noise. I want you to select that out. Okay, sweet, you still did awesome. Now I'm going to add some background noise that you hate. Maybe this is music you don't like. Okay, sweet. Or I'm going to turn on restaurant noises that you don't like, and you still have to ignore that. So definitely we'll look for other courses. Oh, thanks. I enjoy these courses, so enjoy those. I hope you like them. I always talk fast. You maybe need to listen to them slow. I get too excited. Internal critic. Touching on awareness training for those that can't do internal strategies but require external. So once I'm aware that I can't remember it, I'm going to need an external strategy. So let me take, like, I treated a patient, severe brain injury. He wasn't aware that he wasn't remembering, right? And so I had him in his own handwriting write his first name. I put it underneath my tissue box and I set a timer for 30 seconds. I asked him, what's your favorite color? So about 30 seconds elapsed. What's underneath this tissue box? No idea, no awareness. Okay, look, did you write this? Yeah, that's my handwriting. Okay, let's do this again. Okay, 10 seconds. There's something underneath that tissue box. Do you remember? There's something there, but I don't know what it is, right? And so by like shrinking these little timed, delayed moments, and I liked that it was his own handwriting because he believed me that he had written it and that he should have remembered. And so that was a way to increase awareness. Let's see. So touching on awareness training. For those that can't do internal, okay, I think we covered that. And also one of these days we can do a whole thing on like external aids because I love them. Do you use constant therapy for home training? No, so I don't. Life is therapy. I don't give my patients a therapy, so I might give them a worksheet to practice the same thing we did in the clinic at home, but I give them a task of, okay, what do you need to read tonight? When do you need to remember to take your medication? What conversation are you going to have with somebody? How could you teach this to somebody you love? That's their homework. They're remembering to remember, they're thinking about it, and then I want you to remember to tell me how that went. Or I want them to, like, you're going to read this paragraph and you're going to notice if you're distracted, you're going to ground and breathe and come back to it. Let's see how you do. Because really, truly, when my patients are like, I want more worksheets, I want something to work on. No, life is therapy. I want you to be successful in the life that you're enjoying. And so it can be from the most basic, like, I don't care if they're sorting something. I don't care if they're counting what's in their pantry. Any task, if I'm like, how many boxes of cereal do I have? Or what could I put on my grocery list, and visualizing it. If they're paying attention while they're doing any task, brushing their teeth, changing the laundry, having a conversation, you are building their attention muscle. And I think that's super important. But I think there's nothing wrong with constant therapy. I just don't. I just don't. But I would be open to it if somebody wants to tell me why I should. But with my patient population, they're engaged in so many activities and like volunteering and work and family. Life is therapy. Once I've given them a foundation so that they are aware of what they're working on, then every single task is therapy. So eventually, though, I currently work with adults. There is some relevant post-COVID world where brain fog is so prominent and all around. Cognitive therapy is going to become increasingly important and functional for all of us. Absolutely. So I really do. I mean, we know that people are having more difficulty. And in fact, we all have more and more demands on our lives, which is where me practicing this, my attention is better. Your attention will be better. Oh yeah. So Stacy, you just put there, I'm intrigued by my example of my client drawing the line and immediately finding the task easier by breathing and counting while breathing. I would have thought this would have been more difficult due to the attention being divided. So no divided is good, just no multitasking because we can't split our flashlight. We can switch it. So task switching or complex attention. Divided doesn't exist. Multitasking, well, I don't even like divided. Really, truly, I call it task switching. Anyway, back to this. Tangent. Do I think that it was immediately easier? So really, truly, I think all of my patients, we have them practice with breathing. Many patients, when they're in floodlight, they hold their breath. That's their fight, flight, freeze. And so just adding respiration to a task increases awareness. I'm aware of my body. I'm aware that I'm breathing. I can't be in floodlight. And so I think that's why I like it. But you're absolutely right. For a person who's just having a difficult time keeping their pen and like listening to what the highlighter sounds like, or I may do it again and what is the drag of the pen across the paper, or I'm gonna just, I mean, breathing with it or counting automatic speech is nice because it just has a cadence and we don't really have to think about it. But you're absolutely right that that is two tasks being switched between. Long COVID attention issues. So I really, and you know what, we all have attention concerns, right? We all have distractions and things going on. Thank you for sharing with your patient that you're a person, right? I share personal stories all the time with my patients. If I have a patient not doing much in life or tasks at home, how do we get them to start to bridge the gap? So I think motivational interviewing, what is one thing that a person may engage that they might like? Maybe drawing, maybe listening to music, because I can attend to listening to music. Or is it talking to somebody? Is it painting my fingernails? Any task that I do, I can do it with greater attention. And so just, I think motivational interviewing of what is one thing that a person might enjoy in their day, where might they want to spend some time. And I know we're running out of time, so let me just get to these last two, or last one. Also helpful in working with perimenopausal patients who are learning, yes, about brain fog and word retrieval, decreased attention. Absolutely. So this population also, we could benefit from attention training. So back to where I started at the onset of this, I feel like every human being would benefit from increased awareness about attention and how that impacts our working memory. Because if I'm not aware that my mind is wandering, I can't begin to change it. And because the default mode is for our mind to wander. How many times have you driven home and you don't remember how you got there? Or you hope you stopped for every stoplight? That's mind wandering. So maybe before you drive away, you grab your steering wheel, you feel it. You think of what are 3 landmarks I'm going to see on my way home? All right, I'm going to pay attention to landmark number 1. Cool. Landmark number 2, landmark number 3. Now I'm present and I'm not in mind wandering and I'm actually living my life, because really, truly, the only part of our life we can control is the right now. So our body and our brain need to be in the same place at the same time. I hope you found this helpful. Anything else?
If anyone has any final questions, feel free to put them in the chat. Just a lot of thank yous, Michelle.
Fantastic. Thank you. So I love this stuff because I personally, professionally, family, I helped my mom with this when I was just in town recently. A quick anecdotal story. Can I share a really quick anecdotal story?
Yeah,
No, we're out of time. No, they get lunch. They get a break.
go ahead. Share the
Okay.
story.
Well, okay. So our floodlight goes on. So we're either like hyper aroused, fight, or we're hypo aroused, freeze. So red, blue, green zone is I'm imbalanced. So my mom, she has a neighbor, lived there her whole life. They just moved away into an assisted living facility and the house is up for sale. And mom looks at the sales for sale sign and she's angry. She's super angry because it's for sale. And I'm like, Mom, you're not angry at that sign. You're sad that the neighbors are gone. And so we had a quick moment and so we just grounded and we breathed, but she became aware of what she was actually feeling. And so 2 days later, she looked at it and she's like, Michelle, I'm not angry at that sign anymore. And I miss my neighbors. Because I think if we're not aware, we can't begin to fix the problem. So for all of us, thank you for letting me share that last little story.
Yes, and thank you so much for the past hour. Check the comments, everyone. Just so many positive things. All right. Well,
Fantastic. Thank you very much.
we are going to break for lunch for 30 minutes, and then we will come back for our next presentation. Hello, everyone, and welcome back from our quick lunch break. I want to introduce our next presenter, Erin Forward.
Hello. How is everybody?
Pretty good. We've had lots of great conversations in the chat so far this.
Awesome. Awesome. Yeah, feel free. I'm someone who likes questions as I'm presenting. So if you have a question, I'll probably ask from some participation. So feel free to put that all in there. Let me pull up my slides and we'll get started. You reshare it so y'all can see. Okay, are we good?
Yep.
Cool. So today we're going to talk about AAC and feeding therapy. And I actually started what got me into speech therapy was AAC. I worked at a school in Pittsburgh while I was in undergrad called the Children's Institute of Pittsburgh. And like 90% of the kids there had communication devices. And it's interesting because I would help out at lunch. So like I would make all the materials for the speech therapist. And then I would also sit with an autistic classroom during lunch. And I vividly remember this little boy I worked with who would ask for garlic powder on everything. So like most of our lunch was spent with him saying, I want garlic powder. And then they'd put garlic powder on his food. And then as soon as the garlic powder dissolved, he like wanted more garlic powder. So at that point, I had no idea I wanted to, or I was interested in feeding. And it's interesting how our paths kind of take us to different places in an interesting way. And feeding eventually became another thing that I was really passionate about. So putting these two things together felt really natural to me. And I think what can be hard is both AAC and feeding do require a lot more advanced education and taking the time to learn about programming and dysphagia and feeding skill. And so to be able to be comfortable with both of these things at the same time takes a lot of work. And so today we're going to talk about using these strategies for communication, regulation, and mealtime. Financial disclosures. I am the owner and speech therapist of Nourishing Connection LLC. I opened that a month and a half ago. So it's been quite the journey of being on my own. I do contract work with Affective Collective LLC in Charleston, South Carolina. I will receive an honorarium from the MedSLP Collective for this presentation, and I receive royalties for presentations with speech therapy PD. Non-financial disclosures, I'm an expert in together floor time, which does impact my perspective and how I present and the lens with which I talk about both AAC and feeding. And that will be kind of integrated as we talk today, because once you dive into floor time, it never really leaves you. Like I floor time myself, I floor time my friends, I floor time the caregivers I work with, not in a way that I find it to be helpful for any human being. And so it was also through floor time that I better understood how to integrate AAC into feeding therapy, because feeding therapy, literally and figuratively, is very messy. And I think it can be really overwhelming to pay attention to both feeding cues and communication cues with the use of some form of augmentative communication all at the same time. However, if we're really diving into the true definition of AAC, sign language, any gestures, any different use of communication other than verbal speech can kind of fall into that category too. So a lot of us are already, even without maybe high tech or like low tech AAC, implementing some of these strategies into our sessions. And so thinking about the ways that we're doing that and how can we maybe bring in some more support for the kids that need it. So today, I won't talk too much about myself because we don't have a ton of time and y'all don't probably want to hear other things. Stuff that is not my time ordered agenda. This was a different one, but I will go back. I sent the time ordered agenda. I'll show y'all. What we're going to talk about today: identifying the importance of AAC in feeding therapy. We're going to describe 3 strategies to implement AAC at mealtime, and then we're going to identify 3 individual differences and how that impacts feeding and AAC. So we'll talk about low and high tech AAC. I'll give you my time ordered agenda verbally because I put the wrong slide in there. We'll talk about low and low and high tech AAC, we'll talk about individual differences and how that impacts our decision making in regard to what we kind of introduce into feeding therapy. And we'll do a lot of case studies, and I'll ask for some participation, and I'll ask for some questions throughout, because when I present, I always say that my goal is to build your lens. So I am not going to give you a like step by step, this is exactly what you do, because every kid we work with is different. And I don't really feel like any kid falls into a true protocol. And so my goal with anytime I present is to give you information, to give you philosophies, to give you strategies, and then to show you how to critically think to implement them with any child that comes in front of you. You're not going to have all the answers for any child that you work with or any family that you work with, but I want this to build your lens, because we all have our own lens of our own families we've worked with, courses we've taken, graduate school, mentors we've had, life experiences ourselves that impact how we show up to a session and how we show up to work with a family. And we can't really put aside any of those things. Like, those are all a part of us. And so use those as your lens for how you observe a child. Oftentimes, whether it's with feeding therapy or AAC, people will ask me, what's your treatment strategy? And my answer is more of my strategy is in the assessment. So the more I know what to pay attention to, the more I know what questions to ask, the more I know what's important, the better I can make decisions that support that family, that in turn become my treatment. And that can be really challenging at first and really overwhelming, because a lot of us want a like cookbook of this is what I do. But it's all in what you're observing about that child and that family. So we'll go into that a little bit. I've talked a little bit about me. Quick overview. For those of you that don't know me, I am, like I said, a feeding therapist, an expert in floor time. So I do a lot of DIR floor time therapy. I am from Rochester, New York, have moved around to like 4 different states. Now I'm in Charleston, South Carolina, because I wanted to be by the beach. And like I said, I started my practice in AAC. And when I went into grad school, had different practicums in feeding and fell in love with feeding therapy and fell in love with the relationship piece of feeding therapy and how important that was, and caregiver coaching and helping support attachment. And I felt like AAC and feeding really worked well together. And a lot of the children I was seeing that were really medically complex, or the autistic children that I was seeing, needed both. And what ended up, I worked in a hospital system, an amazing hospital system, but something that was always really frustrating to me is that these families would come in and they would have to see 2 different therapists, one for feeding and one for AAC. And these families were already seeing so many physicians, so many clinics, so many other therapists. And it didn't feel right to me that in our profession, like, we couldn't find a way for families to see somebody that could integrate those things together. And I understand, like I said, that it does take advanced education and training for both of these specialties. And I want to like be sensitive to that, because we don't have time to learn everything in that way. But there are a lot of pathways to help someone who's really comfortable with AAC start to get more comfortable with feeding, and somebody who's really comfortable with feeding start to implement AAC. And so that was something that was really important to me when I was at that hospital system, was to provide some education internally of how can we be better about supporting our families, and how can we be better about collaborating, whether that be the AAC specialists come in and help provide strategies for that family so that that therapist can implement them into the session, or vice versa, because a lot of my families would get really frustrated. I was one of the only therapists in a team of 30 at my location, and maybe one of 5 of a total of 150 speech therapists that felt comfortable with both AAC and feeding. That's definitely changing, but that was a very interesting thing for me to see going into a system like that. So let's think about some common questions. Is this only for children who already use AAC? And the answer is no. So I oftentimes will introduce augmentative communication with a child who is speaking and doesn't utilize any form of AAC outside of our feeding sessions. Because sometimes I have kids that shut down at the table, or go internal, or get anxious, especially a lot of our kids with ARFID, avoidant restrictive food intake disorder. And so if I'm going into working with feeding with a child and they're automatically going into their lower brain and becoming dysregulated, their access to language and communication is going to decrease. And that's expected. Like anytime I go into a new scenario, or something makes me anxious, like we know that language is something that kind of goes away first. When we're having a fight with somebody or we're overwhelmed, like it's hard to find our words. Like we know this as speech pathologists, but sometimes I think we forget that sometimes the answer is not to push them harder to speak. Sometimes the answer is to provide support for them when we're already asking them to do something really challenging. So I want to look at the cognitive load of a child and what I'm asking them to do. And sometimes that involves bringing augmentative communication in for them. So that's something I want you to think about too. If there's kids on your caseload who maybe when you're engaged in activities that they're much more comfortable with, there's a lot of language that's used, but then they get into a moment with feeding and they like can't really access what they want to say, make choices, tell us why they're feeling a certain way, talk to us about the food or understand why they don't like it. These are ways that we can introduce AAC. That can be as simple as like a menu. Like if you really think about it, like pictures of food, adding more visuals so that the child can remember what that food looked like and what that's connected to if a family's making decisions on what they're going to eat that week. That's a form of AAC. I work with a lot of families on making food schedules because sometimes for our kids who are really anxious, just knowing what that food is going to be that day can make them feel so much better, as opposed to how many of our kids get home from school. They work so hard to stay regulated at school. The lunchroom was really overwhelming. They were really stressed. And then they come home and they were really hoping that they were going to have their favorite food, pizza, because they needed a comfort food. And mom said she was making lasagna and they melt down. But if they had known all day that it was going to be lasagna, maybe it would have been easier for them to process that. So those are like some other things to think about. I also will have kids who, like I said, get really quiet at the table, or I just want them to feel like they have more control and it's going to be easier for them to communicate. So maybe it's easier for that device to say something for them than for them to say it with their words when they're trying to tell me that they don't want to eat something or that they don't like something or that they want this food instead. So just having the visual in front of them, having more sensory input, having more sensory support available to them can make feeding a much better experience. And I know our job is to challenge kids and families and to help them grow. But I'm a firm believer that when it comes to feeding, especially, our first job is to make it easier. So my first job is to go in with a family, see what mealtime looks like, see what's happening with feeding, and how do I understand what's going on and how do I make it easier? And AAC is a tool in my toolbox to make it easier for a lot of kids, to make it easier for families too. I have a 1-year-old I'm working with right now who is has a couple words. He's got some medical complexities. And he's got a lot of strong opinions on what he wants, and he can point and he can vocalize, but it's really hard for mom to figure out what he wants to eat. So I've brought in a communication advisor for a lot of reasons, but we talked a lot about feeding. Okay, if he knows what he wants, because he will see the package as soon as she brings out and nod his head yes and point, why don't we put a communication device in front of him so that instead of her having to play guesswork, he can decide what he wants, and hopefully that will help him with his volume intake or a lot of our other goals. Because if I'm spending 10 minutes trying to figure out what my kid actually wants to eat, that's so much effort they've made. And now I want them to eat a food that's like challenge. Now they have oral motor skills they need to work on. Like I've already set myself back from the thing that I'm trying to work on. How do we use AAC when mealtime gets messy? The good thing is that we have things like laminators. We have things that can clean. We have warranties. So I know people get nervous, especially with their, like, if it's a high-tech communication device, but like life is messy. As you can see, my feeding therapy is very, very messy. And don't be afraid to like really use that communication device and get a screen protector or whatever it needs to be. But those are the moments where you really need to give children access to communication. We're going to talk about and think about like what language should I have on a low-tech AAC or a device. Something that is I've been talking about a lot recently is, and I'll talk about mealtime literacy when a little bit in a couple slides, but it's interesting to me that we expect kids to try new food, but we never give them access to that new food on their communication device. How are they supposed to ask for it? Or how are they supposed to ask a question about it? Or how are they supposed to tell us that somebody at school ate broccoli and they've never seen it before? So I pick up a lot of communication devices when I start working with kids, and the only food that's on there is their safe foods, which is wonderful. I want their safe foods on there. Like, I don't want a device that doesn't have their safe foods. That's the most important thing first. But where's all the other foods? Where's the food that when Bluey eats this food in his show, I can go in and talk on their device about Bluey eating ice cream, or like Bluey making a cake, or Peppa Pig eating apple crumble? How can I build more meaning out of that to help them learn about these different types of foods? And so thinking about not just what foods do they like, but what foods are they exposed to, and what foods does family like? And how can they talk about if they don't like the food or if they do like the food? So presuming competence as well, that like maybe they want to try something. I had a child I worked with who I think he was 4 at the time, autistic, and he had LAMP, the app. And I remember one day he went in and asked for like a donut, I think, which he'd never had a donut before and never had any interest in it. And mom was like, okay. So she went and got a donut, and he ate the whole thing without like any signs of like no issue. It was like he'd been eating it his whole life. And they had watched a movie that he had seen recently, and there was a scene with one of his characters eating a donut. And she was like, oh, that must be why he had interest in a donut. But if she hadn't presumed competence, or if he didn't have access to that on his device, we never would have known. We never would have given that opportunity. So I encourage you to also think about adding some more things. We're going to talk about individual differences, and you will know from an access standpoint or a visual standpoint or a receptive language standpoint, like what they can handle or what they can tolerate on their device. But we want to presume competence. We want to give them opportunities to ask questions, because some of it might just be like them hitting broccoli, or them hitting, finding another food on there that they saw someone eat at school. And so, can we talk about it? If a kid comes home and they are like, keep pushing broccoli, I'm either going to tell the parent, maybe buy broccoli, show them a video of broccoli, show them a picture of broccoli, something so that they can build meaning to what they're showing us. And that in and of itself is supporting their feeding without food having to even be there. Another question I get is like, does this impact the interaction at mealtime? And that is something that I go back and forth with a lot, because as a relationship-based therapist, cue reading is really, really important. And I'll show you in one of the videos kind of what I'm talking about, because a lot of our kids make very subtle cues that can be really easily missed when they want to explore something. Like, it could be as simple as like they look at a food that we have in front of us, and that may be their cue that they want to try something. And so if we're not really paying attention to all of their cues, we can miss a lot of these opportunities. However, AAC isn't just high-tech communication devices. And so we have to be open to using other modalities, but also in that moment, for example, if I'm paying really close to those cues, like if that child leans in, maybe I'll go to that device and say, oh, you want to smell it? So I'm reading the cues, but I'm also giving opportunity to bring even more meaning to that. And we have to, again, be cognizant of that child and what they need in that moment. But the most important thing is it being there for opportunity for that child. Does anyone have any questions before I go to the next thing? It's kind of similar. So again, why is this important? So mealtime involves almost every body system. It involves communication, it involves engagement, it involves posture control. It is a really, really, really significant cognitive load. So we talked about this in that first question, but we also, like I said, have to think about mealtime literacy. And this was also a concept that helped me integrate both of these things together, because I was seeing a lot of recommendations for, you hear parents say, I've offered this food 15 times, or I've helped them cook in the kitchen, or I've always put like a safe food if I ever put a new food in front of them. So like all these parents were coming to me and saying like I was doing all the things that everybody was recommending to me, but it wasn't working. Like I was giving them all these opportunities, I was giving them all these exposures, but like that wasn't helping build their interest or growing foods or wanting to eat more foods. And my first question is always going to be, which is not the topic of today, like, have we looked at all of the possible referrals and possible underlying medical etiologies, and have we ruled out some of these GI, allergy, ENT, all the things? But if that has happened, then I also want to think about if the experience with the food was meaningful. A lot of kids we work with, like, it depends on how you introduce that food. Are you eating the food with them? Are they a really social kid and they really want to eat the food with you? Like, are they a kid who sees your cup as and wants the cup that looks like the adult cup because that's what they observed you use? And then you hand them this cup that they've never seen before, and they're like, that's not what people drink out of because mom drinks out of this cup. Are they a kid who has some challenges with engagement and joint attention, and really likes to play in a very specific way, and likes to line up their toys, or really likes to throw their toys, or however they like to engage with the world? And do we need to be more meaningful with how we bring food into that and thinking about their differences? And so AAC is also a way to support that mealtime literacy, to support their understanding of like what food is and what it is to me. Because again, if you have a kid that only their safe foods are on their device, why would they think any different that any other food is for them? So I need to add other things to that device. If they are having trouble connecting that mac and cheese, I look at, mac and cheese and spaghetti. And as somebody who's had a lot of experience with food, I understand that there's similarities to those two things. There's like pasta in both of them. I can bridge those two things together. For a lot of the kids we work with, those could not be more different, and there is nothing that's similar to them. And maybe they don't have the language or the understanding of those concepts and what that means. So giving more access to pictures, and if they're a kid who is hyperlexic, reading about things, logos, all of those things that can be really meaningful to them can help them build some of those bridges. They might not be the same. To that kid, spaghetti and mac and cheese may always be completely different, but maybe there's other bridges that we can make between food to help support them. And I think, let me see if it's in the last area. It's this one. We'll go into this one. So the other thing that is really, really important, especially with the medically complex kids I work with, is that I will not start feeding therapy until a child can consistently and confidently tell me no. And that's another thing that AAC can be really helpful for. I don't care what it is, if it's an all done, if it's a no in sign, if it's a yes and no button, if it's a yes and no picture, if it's a yes and no on a device, if it's a stop that, if it's a get away from me, if it's a I don't like you. I don't care what it is. But if you do not know a child's cues and you do not know when they are telling you no, you should not be doing feeding therapy with them. I do see like some videos sometimes on social media or different platforms, and you're watching this child, and all I can see is their whole body saying no, and somebody shoving food in their mouth. And maybe I don't know that child, and maybe based on some of their tone. Like I will give some benefit of a doubt that maybe like some of their tone shows different things. And I would hope that that therapist is supporting all of that and reading those cues. But I've seen it too often to believe that there aren't moments that are happening where that child is pulling back, splaying their hands, all of these signs that we know in infants are, this is too much for me. And we continue to push through it. And I care more that a child can be in a situation with food and tell someone no than I care if they eat it. Because I want them to have self-advocacy. I want them to have quality of life. I want them to feel in control of their body. There's a study, and I can send it to somebody if you guys want it, or feel free to email me. I'll give you my email. But there was a study done by a psychologist about a life plot and how you feel about yourself as a person. And they found that kids develop a life plot of whether they are agenic in their life and what happens to them, or they're kind of a victim to what everybody else around them wants to do by the age of 2. And I always bring that up when I talk about AAC, because I'll get people that will be like, this kid's 1, why are you giving them a communication device? I'm like, I introduce any form of AAC as soon as I possibly can. And that reason alone has like really shifted my perspective, because a lot of kids, especially a lot of the medically complex kids that we work with, like deserve to feel like they have control over their body, deserve to feel like they can say no. And feeding is an incredibly intimate experience. How many of us hate the dentist? I mean, I don't hate the actual dentist, but like think about when you go to the dentist, like you feel so out of control. Someone is in your mouth. Like to be in a child's mouth is a huge power move. And so I want to know that they know when anything is happening that I am going to listen to them if they feel unsafe. Because also, how are they supposed to trust their body and how it feels and feel hunger or feel any of these cues if we don't give them access to language or we don't respond to them? So AAC also allows us to give them more access to respond to those cues and to understand what those cues mean. Like if I have a communication device and a kid's like leaning back anytime I come near them with the spoon, I might be like, oh, I don't like that. Or no, thank you. Or I'm not ready, or something to just build even more meaning out of what's happening for them. We do that with infants all the time. Like when you're feeding an infant with the bottle, if they, like I said, splay their hands or their eyes get really big or their eyebrows raise, or, if you're in the NICU and they desat or Brady, like those are all signs in their body that like, this is too much for them. I'm not going to keep feeding that baby. But I too often see that happen with older kids. So I just kind of want you to think about that and like building that self-advocacy as well. Okay, let me make sure I have my sound on.
Mixing.
So if I want a kid, this is the other thing that I think about with mealtime literacy. I have a boy I was working with, and I think he probably ate like pizza, chicken nuggets, and some, like he liked berries, he liked strawberries, and maybe there were a couple other like chips that he ate. He really liked chips. And I remember one day mom was saying like he won't try any other pizza. And so I started showing him videos of like people making pizza, because I was curious like what his understanding of pizza was. I think it was like Totino's frozen pizza that he would always have mom make, and she had to make it very specifically. And we were watching the video of someone making pizza. And he goes, no sauce was on there. No sauce was on pizza, because to him, it was just the pizza that was in front of him. And how am I going to expect a child to then feel comfortable with another type of pizza if he doesn't even know the components of it? So cooking and experiences like that aren't just let's get a kid exposed to food. Because I hear that a lot. It's like, okay, we need these exposures, or like they're going to get comfortable, or we're going to desensitize them to something. And like from a sensory perspective, like there is value in like having meaningful experiences to help me feel more comfortable with these different textures and flavors and tastes and things like that. But also some of it is just to learn, because I understand macaroni and cheese and spaghetti are similar because I know how they're made and I know the components of them. But do we give kids those opportunities too? Do we talk about if things are hot or cold, or this child also who thought that pizza didn't have sauce on it. Anytime I asked him how a food tasted, he would say disgusting if it was new. And so I was talking about him, she's like, yeah, anytime it's a new food, he would say disgusting. And I was like, huh, I don't know if he means it's disgusting. It might just be different, but he doesn't have any other vocabulary to talk about like what that is. And so part of our sessions were with like pictures and videos and all different types of AAC to build understanding of like flavors and textures and tastes and how things felt. And not only does that help support a child's understanding, but it helps support their oral motor skills, because the more I know about the properties and the of food, the more I know about what it's going to do when it gets into my mouth. That's why like our 6-month-olds are like touching food and putting it to their mouth, because we have all these tactile receptors on our hands and our mouth. And so it's almost like I'm building connections in my brain of like, how does it feel on my hand? And what does that tell us about what it feels on my tongue? I'm laughing because I'm about to quote a podcast that's not professional, but Giggly Squad is this podcast I listen to with two like pop culture people. I was listening the other day and I like wanted to share it because one of the girls on it goes, you know what's really weird? I can know how food is going, or how anything is going to feel on my tongue, even if I don't lick it. And I was like, yeah, because of our receptors on our hands and our brain, that's how our brain determines how food is going to feel when we're younger, like even now when we touch it, because it gives us that information, which I just thought was funny. Any of you gigglers out there if you heard it. But so yeah, thinking about how that child's building understanding, and putting those words on communication devices and giving them access to crunchy, soft, spicy, sweet. It's not because I like need them to have that vocabulary, but I want when somebody says, hey, here's a new food, it's sweet like your fruit. If they don't know the concept of sweet, that's not going to work. Let me see. Yeah, sense of autonomy. Like, and I will even say, like I had a child I worked with who had non-accidental trauma. We were going to work on feeding. But I could feel his body like really feeling unsafe when any food would come near him. And I worked with OT, but the hand to mouth was really tricky for him. And he wasn't super motivated by it at that point in time yet. So when I saw him refuse, I was like, I need to empower him a little bit more. And so I'm not kidding. We spent weeks. He loved his tomato chair, and we spent weeks of him like he loved to move, like me to push him in his tomato chair. And so at first I like gave him that movement so he knew he liked it. And then I wanted to work on some sign language with him. So but I wanted him to I wanted to show him that he had control over his body. And so I would put my hands out and let him push his feet so that he was in control of his body moving. And eventually he would like sign with his feet, and then he eventually signed with his hands. And it wasn't until we got to that point that I started doing feeding therapy with him, because like I wanted to understand him more, and I wanted him to understand that he could say no and he could have control over what was happening. And that also built some of his like motor skills of being able to put something to his mouth, because also a lot of these kids, I want to allow them to feed themselves as much as they can, because then they can give me more information. Like I said, I want them to consistently and confidently say no. And that's really trauma informed, which is something that I'm also trained in TBRI, trust-based relational intervention. And I talk a lot about trauma informed feeding therapy. And that's really, really important to me. And that's a really, really important piece of being trauma informed, because a lot of the kids we work with have been through so much medically, and a lot of the kids we work with have been really misunderstood, and with how personal feeding is and how often it happens over and over and over and over again. If there's a negative experience with feeding, it's a lot of rewiring of the brain that we have to do, because it happens anywhere from, if you're breastfed, 13 to 15 times a day, to 3 to 5 if you're eating 3 meals or 3 meals and 2 snacks. And so what I will tell parents is that you may not see the progress initially, but we are literally rewiring a child's brain to show that feeding is positive, to show that like can be a positive experience and you can have control, and that takes a lot of time. And you can't always see what's happening in the brain initially. Sometimes it takes more time before you show that. But that I try to really emphasize that, because I care more about that than I care how much that they eat. So when we're looking at, okay, I have this kid I'm working with, I want to support them, I want to integrate AAC into my sessions, I want to know how to integrate AAC into my sessions, I like to, and if you guys do email me, I can send you a chart of kind of what mine looks like. But DIR floor time, which is what I'm trained in, is development, individual differences, and relationship. That's the theory. And then floor time is the practice. And they look at development in the context of social emotional development. So it's all about regulation, engagement, back and, circles of communication, social problem solving, all these like bigger concepts that impact all part of development. Excuse me. The R is relationship. I want to do everything in the context of relationship. I want to connect with children. I want to help them connect, because at the end of the day, our brains are all wired to connect. And then the I is individual differences. And this is a very strengths-based mindset, because I'm not looking at it as like weaknesses or faults or anything. They just are. These are neutral. Kind of like when we talk about social determinants of health. These just are things I know about. And social determinants of health would be a part of individual differences. A lot of those concepts would fit in here as well. So people also ask me in floor time, well, okay, you're talking about praxis, or you're talking about motor planning, or you're talking about sensory, but like that's not in our scope. First thing I will say is sensory should be in everybody's scope, because sensory is how we process the world. And so it does not belong just to occupational therapists. The reason that sensory is more taught to occupational therapists is because Jane Ayers was a psychologist who studied sensory and then became an occupational therapist. Just nerdy information. But we need to understand sensory. We need to understand all of these things. So when I look at a child's individual differences, it doesn't expand my scope of practice. It expands my scope of understanding. So I'm not treating the motor planning. I'm not treating their praxis. I'm not treating their sensory, but I'm keeping it in mind when I look at a child. And so this is that lens that we're building, both from AAC and feeding, to better understand what works for them. So what I like to do is when I meet a child, I'm asking, especially with feeding, I'm asking all my, clinical questions. I'm asking all my medical questions. I'm asking all my oral motor skills questions. I'm observing them eat. When it comes to AAC, I'm watching them play. I'm thinking about their cognition and their receptive language and their expressive language. But I'm also looking at all of these other things, such as, like I said, praxis. What's their medical history? What's their trauma? What's their sensory, visual, tactile, proprioceptive, vestibular, gustatory, interoception? What about their family? What about their visuospatial skills? What about their communication? I know this is asking a lot of a speech pathologist, because we already have so much that we need to keep in mind. And I'm not saying you have to ask all of these questions initially. I'm not saying that you have to know all of these things. This is where interdisciplinary collaboration comes in handy a lot, especially if you work at a place that has occupational therapists or physical therapists. But these are all things that like, I want to be in the back of your mind, because sensory feeding is not just how tactile and how it tastes and how it smells. If a kid has challenges with their visual system, how am I setting up the plate in front of me? If a kid has challenges with processing a lot of toys in front of them, maybe I'm only going to give them one food at a time. That same kid who has trouble processing a lot of toys in front of them, I'm going to be cognizant about how I'm introducing something on their communication device. If I know that a child has trouble with ideation from a praxis standpoint or motor planning from a praxis standpoint, what are the supports I'm going to put in place that support my goals? So if I'm working on a new texture with a child, but I know that their hand to mouth is challenging because of their motor planning. What am I doing to support their hand to mouth while I work on that new texture? Maybe when I'm not working on that new texture, I don't have to give them as much support because I want them to work on their hand to mouth. But we have to know all these things about a child. Otherwise, we're not really working on the goals that we're working on. And so when I keep kind of most of it honestly lives in my brain because full disclosure, I am late diagnosed ADHD, which has taught me a lot about myself, and my brain is like a spider web. So I go in a bunch of different places, but I try to keep a chart as like I learn some of these new things and I get new information that helps me then best support the children that I work with. And so yeah, think about these things because I think some of it is missed, and then we wonder why a child isn't making progress, but we're asking them to do so many challenging things. From a communication standpoint, like this is the example I use where if you're working on with a child with apraxia of speech and you're working on sounds, articulation's not my thing, so like bear with me if anything is incorrect here, but and the break you give them is an obstacle course. If they have apraxia of speech, they probably also have some dyspraxia of their body. And now the break that you're giving them is a challenge to their body, and then you're asking them to do something hard after doing something hard. So what do I know about their body that can allow me to give them a break or a moment that isn't more taxing and making it even harder for them to do the thing that I want them to do? I'll show you this video. This is a little boy. I'll show you him a couple times today. And I worked with him for about almost 2 years. He's autistic. He was 3 when I started working with him. And I was only doing communication with him for a while because a lot of the kids I work with, especially a lot of the autistic kids I work with, you'll hear, well, feeding's always been hard, but we didn't know what to do. And so we eventually started to work with feeding, but he had a communication device and we used both his communication device and a lot of videos to support his exploration of food. I like to make a lot of videos of me cooking and eating. I'm a really messy eater and I'm not a really good cook. So it actually is kind of helpful for my kids because it allows them to show them that they can be messy and make mistakes. But with him, I had to use his strengths from both a communication device standpoint, a communication standpoint and a feeding standpoint to help him feel comfortable to explore other foods. I work with a child right now who I talked with mom the other day about how when she picks up a new food, it's almost like you can see her wheels spinning of like not quite knowing what to do oral motor wise. But like with her safe foods and foods, foods that she's really comfortable with, she like has no problem. And so I asked mom, I was like, well, how does she like to learn? Like this child also has a communication device and is non-speaking. And she was like, well, she's very visual, which is something so from her visual sensory system, like that's an individual difference I kept in mind. And I asked mom, I was like, does she like to watch herself? She's like, yeah. So I was like, here's what I would do. I would put a mirror in front of you, or I would even like use your phone to record because sometimes kids really like watching themselves, like FaceTime. And I would model it for her motor planning next to her so she can see herself do it and see you do it. That's not the recommendation I'm going to give to every family, but like what I know about that child, that's going to be really helpful. And then now I have that information about her really liking visual input so that I'm going to use that communication device. I'm going to use more pictures. I'm going to model more things for her, maybe when she's playing with toy food to help bring that meaning as well. I'm also probably going to, when she picks up a new food and doesn't know what to do with it, model her on her device that like, this is tricky, or this is new, or I'm nervous, or something that helps her feel seen in that moment. Would you use a different approach or not for a child that is just beginning to transition from tube to oral feeding? I would say that it would really depend on their individual differences. So like I'm good, like what's their communication? Is this a child who has a lot of engagement and is really interested in food and is really social? Because if that's the case, I'm going to use a lot of that social being their strength. I'm going to use a lot more of like modeling family being there with them, eating with them, showing different foods on the communication device. If it's a child who maybe like isn't as engaged and we're trying to transition from tube to oral feeds, I'm going to think about like how else they like to learn. If there's a kid, I've worked with a lot of kids at the School for the Deaf and the Blind, and that's a population too that like I think is really misunderstood when it comes to feeding. And something that I try to use with any child that has less support from one sensory system is to use more support with another sensory system. So one example is I was working with a child who had cortical vision impairment and was deaf. And we were just trying to help build the idea of like exploring food and exploring food in a way where they had control. And so I asked the therapist, I was like, what is something that they really like? Like, because I was supporting another therapist. So what is something that they really like? And they really like looking at lights and they really like to play with water. So what did we do? We took a tub of water and we had lights under it to just encourage the motor planning of practice of playing with water so that they felt like they had some control. And then once we did that for a while, we started to try and introduce some food with flavor in the same bin, in the same chair, in the same motor plan, with the same words, with the same song that we used to just make them feel comfortable. And then so it's really all about, like I said, what you know about that child and what their strengths are. So like I always encourage you to think like, what is this child really good at? What do they really like? What are they interested in? How do they like to move their body? What sensory system are they intrigued by? Yeah, do they like to look at lights? Do they like textures? Do they like movement? Like some of those things that can help make this a little bit easier. And then there's different things on apps too that can be helpful, dependent again on like what you know about them and all of these different factors. I don't know if that answered that question, but I'm also one of those therapists that when you ask me a question, I'll usually say it depends because it usually depends. But yeah, and with tube to oral feedings, like also what have you been doing to build meaning even without food being there? Like, you know, have you been using AAC with them when they are getting their tube feed? Like, have you been building meaning of mealtime with the tube feed? Have you been like, are they getting their tube feed with the family so that they understand that this is connected? Are we giving them any sort of input oral motor wise while they're getting their tube feed to build brain mouth gut connection? Are we using on their AAC device that it's time to eat and just modeling that even when it's going through their tube? Like so many different things like that also to just build more and more meaning. And that's more so where like I value that AAC too, is like that meaning building and that autonomy and that just understanding of what's happening to my body. Okay, awesome. I was like, I hope I hope I answered that.
It's broken.
You want it's broken. Is that you telling us?
It's broken. Whoa. It's bad. It's chocolate. It's chocolate.
What's chocolate?
It's time chocolate.
It's time for chocolate? Is that what you just said? I think so. He's like, make me feel better, Mom.
Chocolate milk?
You want some chocolate milk?
Is that what you wanted?
Yes.
Yes.
So this is a moment like he has his device and he's a lot more using a lot more words in this scenario. But this little boy is a Gestalt language processor, has some dyspraxia in his movement. As you can see, he's like kind of all over the place sometimes. But a lot of our use for the AAC was to talk about different foods that he liked. And this scene is him in a transition. He's having to leave. So he like needs more access to his communication device. And food is something that like also helps him feel more comfort. Like it can be a regulator for him when it's his safe foods. And so those are just factors that like I'm thinking about him. You see how mom like brought the device over to him right away because she could see him having trouble communicating. This isn't necessarily in the context of him sitting at a table and fully engaging in mealtime, but like even him having that device around his neck, I think helps him feel comfortable to then be able to communicate what he wants. And if we hadn't figured it out, I would have gone to his device and been like, is chocolate milk what you want? And hopefully we would have been able to help him advocate for that. So like, even, you know, I'll tell families too, I recommend putting like pictures of the food that you have on the fridge, because how many of our kids motor plan to get up, crawl to the fridge, walk to the fridge, point to the fridge, whatever. And then by the time they get there, it took so much effort and thought and praxis and like understanding my body felt hungry that if they can't even process what they want, like think about all of us when like we're starving at the end of the day and we're talking to our friend about like what restaurant we want to go to and like nobody can decide. Like that's the feeling a kid has at the fridge. And so if you can put the pictures of what's in there on the fridge, that can also reduce some of that frustration for a lot of families and kids. Because also if their visual spatial awareness is a not necessarily a strength of them, a growing edge, I open the fridge, how frustrating it is to like if something's behind something else and I can't really tell and I can't really see where things are. So those are subtle things too that can just like make mealtime a little bit better for families because we're making that access easier. Like I said, all forms of AAC. I signed with this little girl. She had a very significant medical history. She had tracheal stenosis and had multiple airway surgeries, had some complications with a couple scopes that involved like cardiac arrest. And I saw her in the hospital and outside of the hospital. And so she was a kid who like, if you put a spoon in front of her, she wanted nothing to do with it. And so a big thing I worked on with her was like all done and more and reading her really subtle cues to help her feel comfortable because I wanted her to have full control. But that self-feeding was really hard for her. And so I had to be really, really careful with like what signs I was reading.
Are you eating? Do you want some? Are you all done? Oh, I'm sorry. There you go.
And like, I would so much rather misread a no as a no than misread a no as a yes. And so I'm gonna, especially when I'm first starting, like I like saw her move her hands and use ASL. And I was like, I can't tell if you're all done or not. I'm going to have the spoon here for you just in case. And she like really leans forward, which is when I would like, oh, I want to eat more. And, or if I had a device in front of me, I would say, oh, I want to eat more to again, give meaning to what her body was doing. And it for our children who need that visual, need that auditory, just need more sensory information to build their understanding. Like that's when that can be really helpful. I think this one. Another thing I like to think about, so think about positioning as well when you're like putting a device in front of a kid or you're engaging in feeding. A lot of our kids talk first with their feet, which is a thing like, and when you work with like when I worked with a lot of the kids from the School for the Deaf and the Blind, a lot of their hands, especially a lot of our kids that are blind, their hands are their eyes. So a lot of kids will use their feet first because it feels safer. And so this little girl I was working with introducing like solids or purees around 6 months. And she had a genetic diagnosis that we knew that communication was likely going to be delayed. So I was already of the mindset of like, we're going to bring in some form of augmentative communication. And she preferred the chair that was on the floor and us sitting on the floor with her for whatever reason. We just read her cues. But she wouldn't especially when she was eating, she wouldn't reach for the device with her hand. Like that was a lot of work. And so I put the device in, but she, even in play, would use the device with her feet. And so when I had her in the chair for feeding, I would put the device at her feet, because a lot, like you'll see some of our kids, especially our kids that are like learning to crawl and growing some of those gross motor skills, like I said, their feet also move first. It's like they get their whole body ready to go, or like they're trying to get that like core support, or everything kind of goes medial to do that. And so she would reach for, even if she couldn't get the message that she wanted, when I would see her foot reach for it, I would model what I thought she wanted and then see her reaction. And so some of these things are like are kind of outside the box, but I want you to think outside the box with all of this, because again, let's just try to make this as easy as possible. And the tricky part is the ideal position for feeding is not always the ideal position for AAC, but what is more important. And so what is like, what we need to support. And just like the idea with AAC is, I want a child to communicate what they want to communicate, even if it involves more support. And so I would rather a child have access to more, even if I have to be the one to ask the question, or, you know, I need to give them access to like the head tracking as well as direct access, so I can see where they're kind of looking, but still give them opportunity to touch it with their finger, whatever that looks like. But just be open to like things being different. And I'll tell families, like, I know some of these ideas sound strange, but I promise they've worked. And I promise that I'm recommending them because I'm working to understand your child. And I think that also really opens the eyes for a lot of kids. I work with a lot of kids with eye gaze devices.
You know, like Dr. Singer, Kathy thought of this.
And this little girl had Rett syndrome and did really well with her eye gaze device. And we used that a lot when she was eating, because a lot of her cues were really hard to read, because like she, you know, a lot of, for those of you who don't know, Rett syndrome is a genetic diagnosis that involves primarily girls. I work in Rett clinics, so I have seen some boys, but it's really rare. And they're usually typically developing until like 2 or 3, and you start to see some regression, and they're become like, it's hard. A lot of them end up with feeding tubes, and seizures are really common, but you see a lot of like wringing hands and like putting their hands in their mouth, and hyperventilating is really common, which is kind of scary when it comes to feeding sometimes. And so, but this little girl really liked to eat, but it was really hard to read her cues sometimes. So like providing access to AAC of like, what does she really want? Is she hungry? Is she tired? Is she, you know, whatever that is, was really, really helpful for mom. And then, like I said, even for me to say eat and then see her reaction, like it doesn't always have to be, I tell families a lot of times communication, and I use AAC not for them to tell me, but for me to open up the door and to see what their response is. Even like building meaning of like what colors we're painting. Like if you're engaging in food play, like, can I have a communication device up there so she can tell me what color she wants, or she can tell me, you know, what she wants to do? Because this little girl I worked with had a spinal cord injury. And so and feeding was hard for her for a lot of reasons. Like there were a lot of physiologic impacts of her injury. And so when we would do feeding and we would engage, I knew it was going to be anxiety inducing for her. So like we always had that there, and she didn't use it in any other scenario, but she always had it there so that like she didn't have to have as many ideas. That's the ideation piece too. Like sometimes ideation is so tricky in and of itself for me to tell you what I want. And when I'm anxious, that ideation goes away, not just language, but like, what can I pick from anything else? That's why it's not super trauma informed to ask like a really generic question. That's why I like to give choices. But yeah, there's lots of ways that we can, and lots of different ways that we can implement both of these things. I know these are a lot of out of the box strategies, and there's no like, this is exactly what we do, but this is how I want you to think about it. And if you want more videos, I have them and I can send them too. But per usual, I talk too much. Let me see. I think those are my references. I'll put my email in the chat if you guys want to email me or have any questions because I didn't put it in the PowerPoint, but feel free to email me, send any questions, thoughts, feelings, but thank y'all.
Thank you. Yeah, if you want to put your email in the chat, that would be amazing.
Perfect.
So people could reach out. And thank you for this amazing presentation. And yep, I'm going to introduce Allison Krantz to come on next.
All right, I think I can share once Erin's done. Hello, everybody. I hope everybody's still awake.
So sorry, I was just leaving my screen up.
Oh, no problem. Go ahead and share mine. Okay, move this over here. Well, thank you guys so much. This has been such a cool Saturday. I know that people have a lot of things going on the weekends, so I'm really excited to be here to share a comprehensive approach to adult neurotreatment and carryover the virtual rehab center. As I was listening and watching these presentations today, it just reminds me how vast the speech therapy field is and how much we need to know as clinicians for both ourselves and our patients to educate our patients on. And the virtual rehab center was really built to kind of help apply those evidence-based practices to help SLPs and also help outcomes for their patients. But I'm reminded I've worked across the lifespan. I'll share that in a minute. And some of those feeding techniques were really excellent. So let's move into it. So I'm going to start with just my disclosures. So again, my name is Allison Krantz. I do work for Tactus Therapy doing customer success, sales, and marketing. And I am receiving an honorarium from Medical SLP Collective for the presentation today. I do not have any non-financial disclosures, but I will be discussing Tactus Therapy products only today. Okay, here's the agenda. I'm just going to give you guys a broad overview to start for the first 10 minutes to talk about what is the virtual rehab center. Then we're going to talk about some case-based scenarios. So we're actually going to do a demo. I'm going to jump into it and show you some of the research-backed treatments, some of the features, and then we'll move into some other tools that are available in the virtual rehab center, like the homework side for the patient, and some flashcards and other things. And then I'll hope to leave some time for summary and Q&A at the end. If you have a question, feel free to throw it in the chat. If I want to put it off till the end, I will, but I'm happy to answer those as we're going throughout. Okay, so learner objectives. Today we're going to start by contrasting the Tactus Therapy apps from the Virtual Rehab Center. Then I would like for you to be able to list 2 evidence-based therapy approaches that are incorporated into the Virtual Rehab Center for cognition and language. Then we're going to describe how speech recognition supports patient awareness in the Virtual Rehab Center, and finally summarize how the Virtual Rehab Center supports best practices in speech therapy. Okay, here's a little bit about me. I have been an SLP for over 15 years. It's gotten closer to 20, but I don't know if I'm ready to admit that yet. I graduated from Mizzou, and I'm certified in both Missouri and California. I've been lucky to work with patients across the lifespan in various settings, including outpatient and inpatient and university and telepractice. I have wonderful stories from all the different settings, and I've loved it all. I also have my own LLC, and I began working in a non-clinical role a few years ago, and I have been with Tactus Therapy for over a year. I personally have a special interest in adolescent brain injury. I just think that's a unique population to work with. Sometimes they don't quite fit in with adults and they don't fit in with peds. And so I've been lucky to work with a lot of different adolescents. And I also have a passion for empowering SLPs to integrate technology in ways that enhance both their practice and also their patients' outcomes. And then I have 2 kiddos and a little white fluffy dog you can see hiding in the background of my picture here. I think this was from my first teletherapy setup. Okay, so I'd like to start with the background and the why of the Virtual Rehab Center. And if you all wouldn't mind just dropping in the chat, let me know if you're familiar with the Tactus Therapy app. So you can let me know if you've heard of them, if you've used them before. I might have Casey, if she doesn't mind, kind of help man the chat for me a little bit. And that will just kind of give me a good idea of where everybody's starting off as far as just knowledge of what Tactus Therapy is.
So far, lots of yeses, thumbs up. A few have not heard.
Okay, great. Thank you so much. So just to give you a little bit of background, back in 2010, Megan Sutton who is an SLP, was working in the medical field in the hospitals. She was so excited. She had her first iPad and she opened it up and was ready to use it with her patients. And she found that there really wasn't a whole lot to offer them on the iPad. So she did the smart thing and she decided to create something herself. So she, along with her co-founder, Ben Carter, started Tactus Therapy and released several Tactus Therapy apps. I think it's over 50 now. Now, the Tactus Therapy apps cover a lot in regards to adult medical therapy, speech therapy. So from comprehension to naming, a lot of people are familiar with the naming therapy app, to dysphagia and memory. And the Tactus Therapy apps are used around the world, and they're available on the App Store. And the apps are great for lots of reasons. So there's some pros of the apps. You can use them offline. They are a one-time purchase. There's no data storage, so there's no privacy concerns. But some of the pros of the apps are also kind of the cons. So because there is no data storage, the SLP can't easily find the history of the patient, built right in. There's no automatic communication between the clinician and the patient. And it's limited to the iPad or the tablet. And it's a lot for patients to navigate. So for those of you who are familiar with Tactus Therapy apps, there's a lot of different settings you can set up as the SLP. But when it comes down to the patient, it's hard for them to determine which settings might be the most appropriate for them. So in 2020, the Virtual Rehab Center was started, and in 2024, it launched. Okay, so the big question is, what is the Virtual Rehab Center? So the Virtual Rehab Center is an all-in-one medical adult-focused, all-in-one medical platform for adult-focused SLPs that are treating language, cognition, swallowing, and speech. It's web-based, so that's a big difference between the Tactus apps and the Virtual Rehab Center. It works on any device with a web browser. So it can be iPads or tablets, but it can also work on your laptops or computers as well. So like the Tactus apps, for those of you who are familiar, it is still research-based with functional treatments. The Virtual Rehab Center has over 50 treatments for language, cognition, swallowing, and speech, and it's always growing. It also includes metacognitive awareness. You can see this scale right over here. And we also have strategy training built in. So we know that in cognitive therapy, it's not just about the tasks that you're doing, but it's more about the strategies and applying them and practicing the use of the strategies. So I'm going to show you that in a minute in some of the treatments. The stimuli in the Virtual Rehab Center mirror real life. So I think of the real life for the modern day, right? So what do we do when we're alternating our attention? Well, I'm giving this presentation, but my phone might go off and I might have to figure out how to deal with that distraction. So as you can see in the Virtual Rehab Center in just a few minutes, I'll show you some different treatments that really simulate the real world. We also have things like menus integrated, and we have everyday listening comprehension, which I'll show you in a few minutes. And in that situation, you'll be listening to functional things like podcasts or the announcement from the server at a restaurant or directions. So very functional. The Virtual Rehab Center also incorporates speech recognition and a realistic mouth model. So the speech recognition really helps your patients see what they're saying. So it's sound level feedback for a patient with dysarthria, for example, or the words on the screen for a patient who's struggling with word retrieval. The realistic mouth model, we call him Seth. He is a speech entrainment therapy helper, is available for patients when you're not around to provide that model. There's also flashcards, and we'll try to show that towards the end as well. Okay, another big difference between the Tactus Therapy apps and the Virtual Rehab Center is that the Virtual Rehab Center has a handout vault. So this is a vault of different materials, over 100 research-backed PDF handouts that can be used to educate your patients and their care partners. And also there are clinical guides built in. So the clinical guides can support newer clinicians or help SLPs stay current with the best practices. With all of this research and all these presentations that I've been watching today, there's so much information out there and it's changing all the time. So being current with the research, it's hard when we're doing our jobs as clinicians and speech therapists. So when we create these treatments that are in the Virtual Rehab Center, we do a ton of research. And those, we take that research and we actually put it into blogs. And I'll show you that at the end, but you can access the blogs for free at any time. And what we do is we take those blogs and we make them into easy to read handouts that are available right in the virtual rehab center. So it might be something like how attention and aphasia. So summarizing the research of what we know right now and having access to that in the virtual rehab center. For your patients, we also have visual supports and strategy lists. Again, strategies are so important, especially for our cognitive patients. So strategies like cognitive strategies or strategies for working memory. We also have tech guides to help your patients navigate the virtual rehab center as well. And it kind of goes back to, I've had patients before, I don't know if anybody else has experienced this, where they come to me and they've been in therapy before and they say, oh, I've never heard of aphasia, right? So we know that that patient education is so important because that patient probably has heard of aphasia. They've probably been educated about that in the past, but they lost that. So having those handouts, I think, is so key with your patient education so that it can support what we're telling our patients as well. Another difference between the Tactus therapy apps and the virtual rehab center is that in the virtual rehab center, you can actually track the patient data. It's going to be automatically tracked for you. I'll show you that in a minute. You get an auto-generated SOAP report after each session. And then you can always add your patients in secure patient profiles. So you can add treatments, so you can be organized for your session. You can add handouts to your patient profiles as well. And we also have a SMART goal assistant, which can help support you in goal writing. Okay, I'm wondering, is anybody familiar, and you guys can say yes or no in the chat to this one, to the research practice dosage gap, the research that was done by Kavanagh and colleagues back in 2021? Can I just get a yes or a no? And Casey, maybe you can help me man the chat. I see lots of
no's so far and a few yeses.
Okay. Okay, well, this research really blew my mind. So I recommend you look at it. I have it in my references at the end if you have a few minutes. But Kavanagh and colleagues back in 2021 looked at whether or not there was a research practice gap in aphasia treatment. And in the research, they found that the median for aphasia intervention was 20 hours over 15 sessions in research. But in reality, in outpatient clinics, it was actually a median of 7.5 hours over 10 sessions. So what a significant gap that is between what the research is doing and what we're actually doing in our therapy sessions. And Release collaborators back in 2021 found that the greatest gains in aphasia recovery were associated with 9+ hours of therapy per week, 3 to 5 days per week. So that sounds fantastic. But I don't know about you all, but I've never been able to see my patients for that many hours. Typically, it was limited to maybe 1 to 2 sessions a week, and definitely not 9 hours of therapy per week. So we know that our patients need an increased intensity. We know that will help support their neuroplasticity and their progress between sessions. So how do we do that? So in the virtual rehab center, you get home practice for your patients for free. And once they do their practice, you can actually review the reports of how they've done, and you can adjust the plan remotely based on the progress. The home practice, it will self-adjust in difficulty. So if they get so many in a row correct, it's going to move up a level. And if they get so many wrong, it'll move down a level. So it'll kind of keep them in that frustration-free zone. And home practice isn't just for home. So if your patients are in an inpatient or if they're in a skilled nursing facility, if you have rehab assistants or volunteers or family members, they can also help support that patient in doing home practice between sessions as well. Okay, so let's go ahead and see it in action. Let's get into the fun part. I'm going to show you some case-based scenarios. And if you all could just drop in the chat if there's a certain area of treatment that you see the most, and what you might like to see. I'm going to stop sharing this screen. And then I'm going to get rid of that. Okay, and I'm going to share my other screen. Okay, I'm going to move you over. So in the chat, Casey, what are you seeing for me?
Memory, high-level cognition.
Okay.
EI apraxia, dysarthria, aphasia and dysphagia.
Okay.
Parkinson's, expressive aphasia, dysphagia.
Okay, so we want to see everything. No, okay. Okay, so I'm going to walk through and I'm going to show you a few case-based scenarios, which the good news is I do have quite a few treatments that fit into those categories. And if I don't, I'll try to talk about them at the end. So keep track for me. And if I've missed a certain area, I'll try to tell you briefly what sort of treatments we have to offer for those different areas. So let's start with some of our patients here. So these are all fictional case-based scenarios. We're going to start with Janice. And Janice is a 65-year-old resident, and she had a left hemisphere stroke, so she presents with aphasia, and she's at a skilled nursing facility. So we're going to take a look at her treatment plan and look at some different treatments that she may have in her treatment plan. So when we think about aphasia, we think of word finding, we think of comprehension, we think of reading, writing. So you're going to see different treatments that address those areas. So we do have naming single nouns, which is similar to the naming therapy and the tactus therapy app. It moves through the hierarchy level of assistance. So moving from the least helpful, so like the first letter of the word, to the most helpful. We also have phonological components analysis and semantic feature analysis for those of you who are familiar with those different evidence-based practices. But today I'd like to show you all describing actions. So this treatment is for patients who are moving beyond the single word and trying to formulate short sentences and action words. So this treatment does incorporate speech recognition, so I'm going to show you that. And you can always switch it to self-scoring instead, but the speech recognition is really valuable for feedback, so if you can use that, I would recommend it. It starts with our instruction screen, so all of the treatments start with an instruction screen, and then I'll hit the next button here. And here we have a lovely video. So the patient is going to be asked to describe the picture. So here we're looking for who plus the action plus the what. And I'm at level 3. So I can switch to a different level if I'm in session. If I'd like to start at a lower level, I can switch that up here. Or I can even go to just the verb level. So here you can make the picture bigger. Take a look at that. If I know the answer, I can go ahead and record my response. So I'm going to click record here. The lady. So I'm going to get this answer partially correct just to show you what that looks like. So here I've gotten part of it correct, but I'm missing that action word. So I can listen back to it and see what I missed. Ooh, are you all hearing my sound?
No.
I bet you aren't. Casey, can you hear my sound?
No.
Okay. That's always my thing. And I wrote it so many places. Let me share again. Okay. Okay. Let's try this again. Much easier. The lady. Can you all hear it now?
Yes.
Okay, great. So I can listen back to it. Now, if I want to try again, I can click this try again button. And now I'm going to get a model.
The woman is sweeping.
Okay, so I can try again. The lady sweeps. Okay, so now I got the who plus the action. As you can see, we're accepting answers based on the content. So it doesn't have to be the perfect, the woman or she. We'll accept different answers. We're just looking for those content units that are meaningful and relevant to the picture. So here I could go on to the next one. And when I'm, if I need a hint, I can click this hint button and I can get part of the
man is
statement here, part of the sentence here, and then I can fill in the blank. So that's an example of describing actions. I'm going to show you all the auto-generated SOAP report that you'll get after each session. So these are all written by SLPs. You'll see that the objectives section provides a description of the activity, why it was done, what the overall accuracy is. And this has all of the information that SLPs care about, right? So did the patient use a cue? Did the cue help? And then if this had been used previously, it will show what the most recent treatment was and the accuracy. So that will pull through in the A section as well. So that's the auto-generated SOAP report. I'm going to go back to the treatment plan, and I can always find that report under the patient history as well. Okay, so that's an example of the speech recognition and naming single nouns. Let's go ahead and look at a writing treatment. So we do have a lot of basic writing treatments where the patient will do a letter or type a word and things like that. This is a little bit of a higher level of difficulty. You can see on the treatment card, it has these lines that show the difficulty. And I'm going to click on the Learn More button here. And then this is going to bring us into a kind of an overview of the treatment. And you all will have access to this after this. I will send you, you'll get to see the links so you can see all the treatments. But this also talks about, how the treatment works, what is it for, what is the patient going to be doing? And then if you scroll all the way to the bottom, it gives you the clinical rationale. So this will talk about the evidence-based practice behind the treatment, and then some selected references. So here, this treatment, the copy and recall social messages, was designed for people with aphasia, to target writing goals. And it's based on TCART, which is a texting version of the traditional copy and recall treatment by Beeson and colleagues from 2013, and the structured texting approach by Fain in 2018. So TCART involves copying a single word 3 times on a phone and then typing the word from memory. And then the structured texting approach advances from single words to scripted sentences, with an emphasis on that social components of messaging. And then in copy and recall social messages, so in this treatment, the users will copy and recall 1 to 4 word phrases, and the focus is on messaging in a single exchange. So I'll go ahead and show it to you briefly. And this one is really relates to the real world, and that a lot of times when we're writing, we're trying to write on social media, we're trying to text somebody back. So it's very functional for patients. So here's an example.
Copy this phrase. Awesome.
Awesome. Okay, so I'm going to copy it 3 times.
And again.
If I get it wrong, it's going to let me know, and I'll go ahead and try it again.
And again.
Okay, and notice I'm on level 1 of 4, so I'm on 1-word phrases.
Type the phrase you copied.
Okay, so now I'm going to try to recall it. Now, if I can't remember, I can use this hint or review button. Here's the review.
Awesome.
Or I can use the hint and copy it. Okay, awesome. Now, what I love is you can add emojis if you want to, so that, again, kind of relates to the real world of, texting, or get on social media. And I can also check this little like button just for fun. So here, this might be an example of something that you'd be responding to and then typing your answer here. So I would submit this one, and then I would do another trial, and then it would go back and have me recall that original,
Copy
that word
this
awesome
phrase.
again.
Congrats.
Okay, so that's copy and recall social messages. Let's move back to the treatment plan. So this is the report. Now I'm going to go back here. Okay, let's look at a listening comprehension task. So again, there are different levels of listening. This one's a little bit of a higher level of difficulty. And in this one, I'm going to go ahead and click the start button here. Your patient's going to listen to a recording and answer a series of questions, and then they're going to either type or say their answer. So this one has some very functional scenarios. So we talked about this a little bit at the beginning, whether it's the server talking about the specials or someone giving you directions on how to get to the doctor's office. So they're going to listen to it and then answer the question. It starts with strategies. So again, a lot of our treatments have these strategies built right in. So here it talks about strategies that you can use during this treatment. So like slowing it down, but also what do you use in the real world, like in a conversation. So you might be able to slow things down that you're listening to if you have that function like on YouTube or something like that. But in a conversation, you might say, hey, can you please speak slower? Can you hold on a sec? I've had to say that if someone's really going fast. If you need the go back button in a conversation, you might say, can you repeat that? And for the replay button, you might say, I missed that. Can you start over? So these are some strategies that the patient can think about and practice. And here are some examples. So this is going to be a phone call. I can skip and just show you a couple other ones. This is a server. See? And here's another voicemail. So here we're looking at the short and simple. So level 1, it goes all the way up to long and complex. And that's going to be more complex topics as well. So listening to, about wearable technology or something like that. So let's find one. Let's do this report. So I'm going to hit the play button so we can listen to it.
Good morning, all. The forecast is mostly sunny today. No rain is expected all day.
Slow it down.
The high will be around 70 degrees. It's a perfect day to be outside. We might see some light showers tomorrow.
Okay, sounds like a good weather report. So now I'm going to go ahead and hit the next button to get
What
some
is
questions.
this report about?
Okay, so I have a couple options here. I can type my answer or I can say it. Okay, so this is a great example of a high mileage treatment, and that if your patient is also working on word finding or articulation, this would be a good opportunity to practice that with a recording, or if they're working on typing or writing, they could write their answer. So I'll go ahead and record it. The news. Okay, so it's going to tell me it's wrong, so I can try again.
What is this report about?
I can click the find button if I want it to queue up the audio for me.
The forecast is mostly sunny today.
Okay, so now I remember it's about the weather. Okay, and then it's going to walk
What
me
will the
through
weather be like today?
a few more questions. And again, I can choose the find button if I want that audio to be queued up, or I can do multiple choice if I don't remember.
What kind of weather is expected for tomorrow?
Let's see if I can remember. Showers, maybe? All right.
What will the high temperature be?
I think it's going to be 70. Let's see. 70. All right. Now, if you disagree with any of the answers ever, you can always click this override button down here. So if you had an acceptable response or vice versa, you can always override the score. Okay, then it goes back and reflects on the strategy used. Did I use a strategy? Did it help me understand? So it's really helpful for solidifying the use of strategies. Okay, so that's everyday listening comprehension. Let's go ahead and move into a reading treatment. So here we have reading functional materials. And this one has a lot of different categories that you can select from that would be relevant to your patient. Does your patient like to read the weather? Do they like to read text message exchange and emails? Do they have difficulty reading prescription labels? So you can really pick and choose based on different things that your patients read throughout their day. Let's go ahead and select menus. Just give you an idea. And here the patient is going to look at the menu and then answer some questions about it. This is level 3. So just to give you an idea, there's level 1 is minimal detail. So there's a lot of white space. There's not as much detail on this. So it's a little bit of an easier level for patients. And this is an example of moderate level of detail. So you can see a little bit more information here. And then there's maximal detail. So a lot more information to sift through on this menu. And here they're going to answer the questions. There's 3 direct questions. Let you know if you got it wrong. And then there's a connection question, which is a little bit more challenging. And then an inferencing question. So that's an example of reading functional materials, just to kind of give you all a picture. Let me go back to the treatment plan here. There are quite a few other categories that you can choose from. So this is an example of a prescription label, another prescription, an invoice. So you can really pick and choose which would be most appropriate for your patients. Okay, so that's an example of another treatment that would be available to Janice. So let's go ahead and go to handouts. So I also, Janice would have different handouts based on having aphasia. So here we have the strategies for communication partners, which would be something that we would share with her family members. It talks about how to talk with someone with aphasia, how to listen to somebody. And you can always download these. You can email them or print them off. There's word finding strategies. This one's called My Aphasia Profile. And here we could have Janice rate how she feels aphasia looks for her, because a lot of times what we think and our patients think, there can be a disconnect there. So how would she rate herself for talking versus listening or reading? And maybe an area that she really wants to work on is reading, even though that might be a relative strength for her. So we can have her have her perceived ratings here, and then we can look after a period of time in therapy and see, do we think that we've made progress in these areas that we really wanted to work on? There's also some other handouts here. So this one is paired with that social messaging treatment. So this would be one that you could, use alongside with that, or she could use while she's actually texting somebody or responding to something on social media as well. Okay, and then there's also some clinical guides like how to response elaboration training, which would be for the clinician to maybe practice with her. Okay, so that's Janice. Let's go ahead and move on to our next patient. So let's look at Catherine. I know a couple of you, Casey, remind me, but in the chat, I believe talked about executive functioning and some higher level cognitive tasks.
Yes, there was higher level cognitive aphasia with VNest.
Okay. Okay, great. So this will answer at least that question, and we'll talk about Venus in a minute here. But this is Catherine. Catherine is a 42-year-old post-concussion. She's an outpatient, and she has some cognitive communication deficits. So let's go ahead and go into her treatment plan, and then we can look at some of those higher level treatments. So for Catherine, she has some treatments that cover attention, memory, and executive function. And I love how we just listened to that great course from Michelle about attention and awareness, because all of that is so important. And this treatment called Working with Disruptions is a higher level alternating attention treatment. So let's take a look at this one first. I'm gonna click Start. So this one is very functional in that it has a different text entry task. So the patient is going to look at a credit card or another sort of scenario and have to copy over information, but then they're going to get disrupted in the middle of doing so. So they're going to get disrupted and they're going to have to handle those disruptions. So what do we do first? We talk about strategies. So again, we know that the tasks, you can do tasks till the cows come home, but the important part is learning the strategies and then applying them to the real world. So we try to make this as realistic and functional as possible. So controlling the environment, I had a patient who he was in an apartment and he had curtains, and whenever the curtains were open, people would actually walk by and it was very distracting. So just closing the blinds really helped him focus. And if he forgot to do that, it was like a whole different session. And it was very difficult for him to focus on his daily tasks, daily living tasks. So it's important to control the environment. Don't multitask. We just talked about that, right, in an earlier session. So I have to remind myself of this, but try to focus on one thing at a time. Switching at a logical point. This exercise is a great place to practice that. So when do you switch tasks? And then blocking off time. It's a good strategy as well. Okay, so here I have to select an app to do a money transfer. So I'm gonna click the Send Money button. And I'm gonna put my recipient here. So it looks like no. And as I'm doing this, I'm going to get disrupted. Let's see, no. Ooh, that's a lot to type. A good one. Okay, so I have a new message coming in. So I have to decide now, do I take this now or do I dismiss this disruption? So I'm gonna go ahead and click to read it. And here I can read the message. I left some extra soup for you in the fridge and there are leftovers from dinner to feel better. Okay, and then I have to decide, was follow-up required or was it not required? So here it doesn't sound like there's follow-up required, so I'm gonna go ahead and click this. But the patient will get distracted by text messages, voicemails, and emails, and then have to decide whether or not follow-up is required. And if I chose to ignore that, I would actually have these notifications build up, and at the end, I would have to deal with them. So I'm going to use my strategies to try to focus, switch at a logical point. And then at the end of this treatment, it will actually ask me, did you use your strategies? Could you have done a better job with your strategies? And that is a great time to reflect and talk about that more. So this is level 4 of 4. So if I would keep going through this, you would see 7 more disruptions, so quite disruptive. You can go all the way down to no stress, just to practice that alternating attention, just to enter the information, or lower stress as well. Okay, so that's working with disruptions, alternating attention task. Let's go ahead and look at another one. Let's look at remembering names. So this is a higher level of difficulty. I've had a lot of patients over the years who this is a very important thing for them, is to try to recall names. And a lot of times what they really struggle with is remembering the strategies and using the strategies. So a strategy like association, making the association a lot of times was so difficult for my patients, but once they got it, they did so much better. So this treatment really allows the patient to see the strategy, practice it, and do it over and over again until they have it down, and then they can apply it to people in their lives and really use it. So let's go ahead and go through this. The first step is going to be assessing that metacognitive awareness. So how difficult do you think this treatment will be today? So I've had patients that would probably say at first, well, I think it's going to be easy. I don't really have a problem with my memory. And so then we talk about that, and then we do the task, and then we'll go back and reflect and see, was it a little harder than we thought? Do we actually need to use our strategies? Then we're going to select a couple more strategies to focus on. So maybe going slowly, reducing distractions again for my patient with the curtains or the blinds. This would be important. I've also had patients where it's important to turn off their phone when they're doing something that requires their attention, things like that.
Look at this person.
Okay, so I see that I'm taking a look at this person. I'm noticing some physical features. I'm going to go to the next step.
Remember this person's name.
Okay, so we have Gloria. Now I'm going to repeat it.
Say the name back.
Okay, so it's going to walk us through the RAS strategy. So repeat, associate, speak, and picture. So we have Gloria. Let's see if you all can remember it today. We're going to remember the name Gloria.
Make an association.
Now, this is that tricky part, I think. So this is a good time to talk about how we make an association. What are some examples? What would my association be?
Say your association aloud.
Okay, so for me, I'm going to say teacher. I had a teacher in the past named Gloria. She kind of reminds me of her. So that's going to be my association.
Make a mental picture.
Okay, making a mental picture.
Play while you wait.
Now this has a built-in wait time with tic-tac-toe. So I have a 30-second wait. I'm at level 2, 30-second delay. You go up to a 1 to 2 minute delay at levels 3 and 4. So this has that built-in time. So as a clinician in the past, when I've done things where I've had a built-in delay, sometimes it'll be over the 30-second. Maybe I only wanted to wait for about a minute, but I've gone to 2 to 3 minutes. So this is all timed for you, so you can keep track of that.
Who is this?
Okay, so now I have to recall the name. So how many of you recall the name? See if anybody's paying attention over there. So if I don't remember, I can view my strategy. Hope I see some answers in the chat.
Yep.
I can get the, they get it right, Casey?
Yeah.
Good job, everyone. I can get the first letter if I need to, and then I can also use multiple choice, but I do remember that it was Gloria. I can hit submit. All right, and then I will move on to the next one.
Look at this person.
Okay, and then after you've learned 3 different names, you'll get a you'll be challenged to go ahead and go back to one of the first names that you learned and see how strong that association was. So when I've worked with patients in the past, if they have a really strong association, they're remembering things really well. It's when that association wasn't so great that we're not recalling, and then that's a great opportunity to discuss how could you make your association stronger? Did you really make a good association there? Okay, and then if I go ahead and click end here, it's going to go back to that metacognitive awareness scale. So how difficulty was the treatment? So maybe my patient who said, oh, it was really easy. Actually, it was a little bit more difficult than I thought. And then we can discuss that. Did you use your strategies? Did they work? Maybe I went a little too fast. I was a little too impulsive. I didn't really make an association. So you can talk about that and how you might do things differently the next time. Okay, so let's go back to the treatment plan. So that's remembering names. As far as executive functions go, we have a few different tasks here. We have ranking solutions to problems, and we also have planning task and planning your tasks. I'd like to show you planning your task today. It's a little bit of a longer treatment though, so I'm going to skip to a video. So I'm going to click this learn more, just so we can go through it a little bit faster. And here, planning your task is a treatment that guides patients through planning and completing tasks successfully. So your patient can think about something that they want to achieve, whether it's something simple like doing the dishes or doing the laundry, or I've had patients in the past who are looking at something more complex. Like I had a patient who was trying to determine trade schools that might be appropriate for him to look into, and just even the task of how do I start that was really challenging for him. So what do I need to do? What are the steps I need to take? How long will it take? Would really help for him to achieve that goal. And this treatment is based on, if I scroll down to the for the clinician part, it's inspired by multiple evidence-based treatments. So those of you who are familiar will kind of see this as I show it to you, but it's inspired by goal, plan, do, review, revise, goal management training, time pressure management, and predict, perform, evaluate. And you can find, if you go to these references, you can learn more about those particular strategies if you have not heard of them before. But here I'm going to make this a little bigger. Let's see here. I'm going to make it big. And then I'm just going to fast forward a bit. So the first step is determining what is the task that your patient wants to do. So here, the patient would like to focus on doing the dishes. And then we're going to talk about, is that a high priority right now? Is that something that you should be focused on? So doing the dishes is probably a higher priority, so that's a good one to start with. And then as the patient is going through the series of steps in this process, you as the clinician will check the level of support that's required on each step. So maybe the patient is doing really well on this part where they're naming the different items needed, so they needed minimal cues, but perhaps listing all the steps is a little bit more tricky for them. So then you can do the level of support, maybe mod or max level support here. So then they're going to go ahead and do all the different steps together. And then you're going to talk about how much time each step will take. So this is a really important part of the planning process that I think a lot of times patients forget. They don't necessarily leave themselves enough time to do something, or they don't realize how much time it's going to take. Then they go and talk more about the level of stress. Will any of these steps be stressful for you? Why will it be stressful? And then what are some strategies that you might implement? So I had a patient who was working on doing the laundry, for example, and he would note that something that would go wrong would be that he would accidentally leave his laundry in the washer, and then then it would get, gross and whatever, and then he had to rewash all of his clothes because he would forget that his clothes were in the laundry. So maybe putting a reminder on his phone or a Post-it or something like that to help recall would be one of his strategies. Okay, and then after the patient has worked through all of these different steps in the process, then at the end, they're going to get this personalized PDF that sort of outlines everything that you just talked about. What are the items that you're going to need? What are some strategies that you talked about? And then also some reflection questions. So did you make progress? Did things go as you expected? So that review, revise piece as well here. So this is something that your patient you could send home with your patient. They could come back and tell you how it went, and then you could start on maybe a different task. And then if your patients, are not ready for this higher level, there is a lower level task that has choices that walks them through this process to teach them the process. And then once they're ready, they can move into this higher level planning your task treatment. Okay, let's see, how are we doing on time? Right, so I'm going to go ahead and switch to handouts. The time is just flying by. So here are some different handouts that Catherine would have in her treatment plan. So she has things like working memory strategies. What is executive function? I feel like executive function is so tricky to explain to patients and care partners. This really walks you through with examples of what it is, what are some signs of executive function deficits as well. I know we've talked about awareness and attention earlier today. This is a handout which is great for patients that talks about awareness. So just information for your patients in a very easy to understand format. And then we also have one that talks about the different types of awareness as well. So like offline versus online awareness, treating awareness. And that would be for the clinician. So more details for the clinician. We have spoon theory, which would be great for energy conservation. So if you're not familiar with spoon theory, look that up. That's a helpful way to sort of identify how much energy a patient might be using throughout the day and try to kind of plan ahead for how long, how many spoons are going to use throughout the day. And it comes with tracking. So a lot of different handouts here to help. This also, I know we talked about managing distractions. This actually is paired with the treatment that's available in the virtual rehab center, where the patient goes through and identifies external and internal distractions, and then talks about strategies to reduce both of those. So this is great for patients to use, identifying internal, external distractions before they go do a task, and then again, reflecting on strategies, whether or not they used their strategies. Okay, so let's go to our last patient. Here we have Paulo. Okay, and Paulo is a 72-year-old. Let me go to his profile here. Patient with Parkinson's. He has dysarthria and dysphagia, and he is an inpatient. So I'm going to go to his treatment plan down here. And here for him, you're seeing different treatments for swallowing, and also using speech strategies, which will be for more for dysarthria. So I know that was mentioned as well. We have a couple different swallowing treatments you can see. So there's the CTAR, the chin tuck against resistance isometric, so the long hold, and then we have the chin tuck quick press, which is the CTAR, the isokinetic CTAR as well. And then we also have the Mendelssohn under his plan and the effortful. Let's take a look at the effortful swallow today. I'm going to click the start button, and it starts with our instruction screen. Let's go to the next one. And then all of our dysphagia exercises have a precaution screen for your patient, and they can move forward once they review that. And then you're going to select an intensity. So there's low, moderate, or high level of reps. So I'm going to start with low today, since in the interest of saving time. And then I'll click next. And here on this page, you can go ahead and look at a full demonstration of how to do the effortful swallow, where the patient will feel their swallow and talk about it in more detail. Or you can go to the next screen and skip that if you're going to do that with the patient yourself.
Swallow hard. Rate your effort after every swallow.
Okay, so here there is a video demo always available. So I skipped past that first video because it will take some time to show, but I'll go ahead and show you this video demo. If your patient is doing these exercises on their own, they can always go back and view this to help them.
Press your tongue against the roof of your mouth. Now swallow hard like you're swallowing peanut butter.
That's all practice. Okay. So now that we know what to do, we're going to follow these directions, and then the patient's going to rate themselves after each swallow. So let's go ahead and try it.
Swallow hard again.
Okay, and this does incorporate the principles of motor learning, and that it's giving feedback that's dynamic. So if I'm at a normal effort, it's going to kind of give me that cue to go ahead and swallow hard like I'm swallowing peanut butter.
Squeeze like you're swallowing peanut butter.
So it's dynamic. It'll change based on my perceived effort. And it's also intermittent.
Wow! Keep up the effort.
All right, I've completed a set. Get that notification there. And now I'm going to rate the fatigue. So after each set, your patient will rate their fatigue from 1 to 5. Let's say I'm at a 2. And I'll click the next screen. And then between sets, there's a built-in rest break that is also dynamic. So if they're more fatigued, it's going to be a longer rest break. If they're less fatigued, it's going to be a lesser rest break. This is important because a lot of times our patients doing exercises want to just kind of go. It's important to build in those rest breaks, or to make sure that they are resting between sets, because our muscles need some time to rest. Okay, so then I would continue to go on with my next couple sets, but we'll go ahead and move on to another treatment to save some time here. I'm going to go back to the treatment plan. And then let's go ahead and do using speech strategies. Okay, so here, so this one uses speech recognition, and it has sound level feedback. So the patient is going to practice saying phrases, and then the speech recognition is going to give us some feedback. So I'll show you how this works. We're going to start with strategies. So taking a deep breath, speak slowly, speak louder, exaggerate sounds. Okay, and then I'm going to pick what strategies I'm going to focus on. So today I'll focus on taking a deep breath and speaking loud. Okay, so here's a phrase. I'm at level 4 of 6. So they go from 1-syllable phrases all the way up to 6 or more syllable phrases. Let's go ahead and do a shorter one. I can listen to the model if I need to.
Keep the change.
Keep the So I'm going to purposely get that one, miss that a little bit. Keep the Okay, so I can listen back to it, and then I'm going to rate my own clarity. So I feel like that wasn't very clear at the end there, so I'll go ahead and hit a 3. Okay, and it says some sounds were not detected clearly, so I can listen to it again or I can try again. So I'm going to really focus on speaking a little bit louder this time. Keep the change. Record it again. Keep the change. Okay. And we know that that feedback really helps increase that articulation, increase that intelligibility and that loudness. So that sounded much better. And now I can go back and listen to them and try a next one. So this one gives me my 2 ratings and I can compare and contrast. Okay, so that's using speech strategies. All right, let's go back to the treatment plan. I'll just briefly show you some handouts that would be available for Paulo. So we're going to have a lot of dysphagia handouts under his treatment profile. So if I click view, this is a clinical swallow exam master guide. So this really walks through that bedside swallow exam. So if you scroll down, you'll see the EAT 10, if you're familiar with that, the eating assessment tool, built in some other interview questions. It's got the cranial nerve exam built in. So we also have things that are important like the oral care best practices for patients with dysphagia, safe swallowing practice strategies, and then at the end you see strategies, postures, and maneuvers that you might be recommending, a swallowed exercise log, and then we have clinical or handouts for like the MBSS, so what is a modified barium swallow study, we have what is FEES to help educate your patients before they go out for those procedures or have those procedures done, and just a few other ones like aspiration, risk factors for aspiration pneumonia would be a good clinical guide. Okay, so that's Paulo. I know we're getting close to the end of time here. So briefly, let me just show you when a patient has done homework. So I do have homework set up for Paulo. This is what his homework plan looks like. I've just added some treatments that I've done with him to his homework plan. And once he's done homework, I get a notification here that he's done his homework. I can click on that and see how he did, and I can view the report. So here you're seeing my homework reports versus in clinic reports, and I could modify that homework remotely at any time and always get those reports to see how he's doing. Sometimes I know patients do more homework when they know that you're sort of watching them between sessions, so you always get that notification here. We also have flashcards. I know I talked about that at the beginning, but just to give you an idea of what they look like. Here's one about childhood memories, for example. So these are great for just more flexible therapy if you're informally assessing somebody or if you do groups, maybe aphasia groups. These are nice because they're black and white cards with bold and underlined words to make it a little bit easier for comprehension. And then we also have our SMART Goal Assistant that you can use with patients as well. So if you're someone who doesn't love writing SMART goals, or maybe you just get in a SMART goal rut and you're looking for something else to do, you can use a SMART Goal Assistant where you select a skill, then it walks you through a series of questions to develop your SMART goal. So just so you guys have a little bit of a picture of that one. Okay, yes, that is okay. Okay, so what questions do you all have for me? I'm going to go back to and share my PowerPoint. I know that, Casey, some people asked about some things, so we'll revisit those. Okay, and then I'm going to do this. current slide and then just go over here. Real quick, these are the references from today, and also everything that I showed you when I clicked on that little Learn More button, there is a link to see all of the evidence behind the different treatments. So if you're curious and you want to learn more, or if there's an article I talked about today that you want to find, you can go to help.rehab.tactistherapy.com and find all of that information. And we do, like I said, a ton of research behind each treatment. So you can find more information in the What SLPs Need to Know blog series. That's also on the website you can find here. Okay, so back to questions, Casey. I know someone asked about Venus, so I can start with that one. So right now, if you're familiar with using the Tactus apps, there is a Tactus app that covers Venus. We do not currently have a treatment, but we are working on one right now, so that will be added in the near future. What else?
Another question that popped up said, how well does the voice recognition system handle accents?
That's a great question. So I think we're still learning about the accents. As far as the speech recognition for some of the language tasks goes, like if you're looking for the words, I think that that's okay. When it comes to sound level feedback, like for patients with dysarthria, it may be a little bit trickier. So you can always override scores, or you can always not use speech recognition. But right now it kind of just depends on which treatment you're using.
The next question I think was in reference to the first case study that you had shared with us. Would this task be challenging for someone who also has dysarthria or apraxia? Does it attempt to pick up on what the person says, even if imprecise in terms of speech?
That's a good question. So I think you're talking about describing actions, whether or not it picks up on, I think in that case, I would probably turn the speech recognition off. I mean, you can always try it and see, but for patients who are severely dysarthric or apraxic, no, I would not use speech recognition. So we always have self-scoring available. So you can use a self-scoring option. But if someone is severely dysarthric or apraxic, I would not use a speech recognition. That would not be appropriate for them for describing actions. Yeah, good question.
Someone else asked, will you show how to use the automatic SOAP note generator, which I think you brought up previously?
Yes. Let's see if I
So they
can.
had never seen this feature and have used VRC for other features.
Oh, okay. Well, yes, after each treatment. So let me stop sharing and then I'll try to share my other screen real fast. I do want to know what the you filthy animal.
Oh, it was to one of the phrases you had started, the ending,
Oh.
like that's the end of it for a movie, the Home Alone movie. Keep the
That's
change.
funny.
So start.
I totally missed that. But I know the reference for sure.
Yeah.
Okay, so we're back to the VRC, right? Everybody can see. Okay, so yeah, after you do any treatment, so I don't know if this person is already, it sounds like they're already using the virtual rehab center, but after you do any session, you can always get the report. It is available. So if I go to, let's say I go to Apollo and then I go to history, do you guys see that tab over here? You can find all of the reports right here. So the one that we just did, for example, I can click on report and pull that up. So it's always available for you. Now, if you go from the treatment section, so if I just go straight to treatments and I'm not in a patient profile, I can start a treatment from here and then it will ask me if I want to attach the results to a patient or discard it. So if you just want to play around, you can go to the treatment library, but if you want to attach it to a patient, then you'll see that report. So they may be just kind of going straight from the treatments and missing the part where it says you can attach this to a patient profile. Yeah, good question.
Another question, keep through, is this available in Spanish?
That's a great question. It is not. It's only available in English. If they're familiar with the Tactus therapy apps, there are Tactus apps that are available in Spanish, like the naming or the Tactus, or sorry, language therapy 4-in-1 is available in Spanish, for example. And then the conversation therapy is also available. But the Virtual Rehab Center, unfortunately, is not available in Spanish. English is our focus currently.
Is this only available on a laptop or a computer? Or is there an app for the iPad or phone?
Yep, you can use it on all of the above. So yeah, it can be used on a laptop, computer, iPad, tablet, anything with a web browser. So it really opens up the options for those people that don't have iPads but do have, iPhone or something like that. Or if you fight over your iPads in your clinic, you can use a laptop or something different to access the virtual rehab center.
Will there ever be an option to add custom targets in VRC like in Tactus naming app?
Custom target, so meaning like picking words, probably. I think that's probably what they mean. Maybe give me a thumbs up if that's what you mean. Choose. Yeah, so as far as customizing the targets, yes, we're always open to our users' feedback. There are some different settings that you can set. So when I add something to the patient's homework, for example, I can set the number of trials, I can set the number of levels. So we're always adding more, and we have lots of speech therapists that come and they look at our treatments and they give us feedback. So we're always open to more feedback. But yes, I would say that if that's something that our users are looking for as far as customizing, that there could be some more customization in the future. But it just it depends on which treatment you're talking about and how customizable and that sort of thing. So if you have specific questions, feel free to email us and I can let you know more about that.
Yeah, I think Heather mentioned in the naming app that you could add custom words.
Oh, custom words. Yes, that is on our roadmap. Absolutely. So that model that I showed you that we call Seth, he can actually say whatever we want him to say. And that's why we have him instead of a person's face. And so, yes, that is on our roadmap to be able to add custom words. Yep. Great question.
And then we'll take two more. So one is, does the patient pay to work from home?
No, so homework is free for your patients. So we really don't want finances to be a barrier to success. We know how important that intensity between sessions is. So there is no charge to your patients for home practice.
And then last, is there a way to add more than 10 patients to homework?
Good question. So they did their homework. Pun intended. So yeah, so you do have 10 active homework seats like per user. If we're talking about like a hospital or a group, that number is kind of different, but I know that's out of the scope of today's meeting. So if you're an individual user and you think you'll have more than 10 homework users at a time, let me know and we can discuss that offline if that's okay, because it kind of depends on your situation, like whether you're part of an organization or you're an individual user. But yeah, that's a good question.
Okay. Well, thank you so much, Allison. I will drop, if it's okay, your email address in the chat for people if they want to reach out with any questions that might pop up.
Absolutely. Thank you so much.
Thank you.
Okay.
All right, everyone. I'm gonna introduce our next presenter, Ashley Michaelis.
Hi, can you hear me okay?
Yes.
Perfect. Okay, let's see. All right. We good? Perfect. Hi everyone, my name is Ashley Michaelis. I'm here to present on low cost, doesn't mean low quality, resourceful voice rehabilitation. A little bit about me, my disclosures. I am the owner of Empowered Voice Rehabilitation and I am receiving an honorarium from MedSLP Collective for this presentation today. Non-financially, I was part of the MSLP Certification Exam Development Committee. I'm an ASHA member, an ASHA SIG3 voice affiliate, at least until the end of the year when they go away. I'm a professional member of the Voice Foundation. I am a member locally of Jack's Therapy and Wellness Collective, as well as a member of the Jack's Gender Affirming Healthcare Collaborative. Our time order agenda for today, I'm going to kind of use this as a loose framework because I have a lot of things I want to demonstrate for you guys and I really want to be able to give you those good demos and answer any questions you might have. So we're going to start with welcome and disclosures, and then I'm going to talk to you about why low tech matters, And then we'll hop right into demonstrations as far as, showing you a windmill spirometer, some resistance band integration, use of a paper towel, and some wall techniques. And then I'm going to show you a case study application for it, do some troubleshooting, and we'll do some group discussion, Q&A, and some take-home points. Please feel free to pop any questions you might have in the chat as I go, and I will try to keep up with them, but I'm going to ask Casey to kind of keep on top of that as well for me. So by the completion of this session, our goals are to demonstrate effective use of low-cost tools for voice evaluation and treatment, apply evidence-based principles to integrate simple materials into voice therapy, modify traditional voice exercises using accessible low-tech resources to meet client needs, and integrate low-tech strategies into individualized evidence-based voice therapy plans. To ensure that this presentation is up to date, all information was collected from sources cited in December 2025, and the therapy ideas and treatment suggestions that I'm going to show you were either created by or modified by myself using evidence presented along with my clinical experience and expertise. I do have a background in vocal performance, music education, vocal pedagogy, as well as I am, or previously was a certified PIYO instructor, which is Pilates yoga, and I incorporate a lot of the principles from both of those experiences into my practice as a voice therapist. So you may see some integration from there as well. So when we talk about low-tech voice rehabilitation, we're really talking about accessibility and functional impact. Low-tech therapy tools make voice therapy and carryover very doable. And because these tools are very inexpensive or completely free, we remove one of the biggest barriers to adherence, which is cost. Low-tech also supports independence for our patients. When patients feel really confident using something simple like a paper towel, a wall, or a resistance band, they're more likely to practice consistently. And that consistency is what drives functional improvement. Another functional or huge benefit is that low-tech tools are less intimidating for a lot of patients. Our patients may have limited tech literacy, cognitive overload, or medical trauma, and a simple tool usually feels very safe and approachable. There's no troubleshooting, no learning curve often with these tools. Again, tools like paper towels, walls, or resistance bands can also give real-time visual or kinesthetic cues and feedback that the patients can understand instantly. And finally, low-tech options are pretty flexible. We can easily grade them up or down to match severity levels or to meet patients where they are that day. And all of these tools can easily be adapted to individual preferences, home environments, or cultural considerations. And all of this together truly supports a patient-centered approach where therapy is accessible, sustainable, and directly tied to functional outcomes. So now for the really fun part, which is the demos. Before we move into our first demo, I'm curious, and I want you to put in the chat, how many of you routinely bill the CPT code 92524 during your voice evaluations? And that's the code for behavioral and quantitative or qualitative analysis of voice and resonance. Go ahead and just let me know if you bill that one. And how many of you bill the CPT code 92520, which is the code for a laryngeal function study as part of your voice evaluation? Go ahead and let me know in the chat. So from a reimbursement standpoint, this distinction really matters. If you bill 92524 alone, which is that behavioral and qualitative analysis of voice code, you're going to receive roughly $103 in reimbursement from traditional Medicare Part B. But if you bill both 92524 and 92520 together, then reimbursement increases to about $186, roughly. And that's nearly double for work you may already be doing in your voice evaluations or that you can easily incorporate into your evaluation process. Now, when we say laryngeal function study, most clinicians assume that that means you need like expensive, specialized aerodynamic equipment to take measures. And that assumption has prevented a lot of SLPs from billing that code. However, you can bill the laryngeal function study code by collecting just 2 data points, and that's vital capacity and maximum phonation time. And if you collect both of those 2 measures, from there you can calculate phonation quotient and estimated mean airflow rate, which meets the requirements for basic aerodynamic assessment. So you can add in that laryngeal function study code. And again, those 2 CPT codes are 92524, which is the behavioral and qualitative analysis of voice and resonance. And then the other one is the 92520 laryngeal function study. Okay, so again, from those 2, collecting vital capacity and maximum phonation time, you can bill that laryngeal function study code by getting those 2 measures and then calculating phonation quotient and estimated airflow rate. Okay, I'm not going to show you how to calculate either of those 2 measures from those numbers today, just due to time constraints, but if you'd like more information on how you calculate phonation quotient or estimated mean airflow rate from the numbers we're going to get today from vital capacity that I'm going to show you, then I highly encourage you to visit Dr. James Curtis's website tutorials where he walks you through that step by step. So no worries about like, oh my gosh, I don't know how to calculate that. You have that, that's in your references. Go visit his website, it's fantastic, okay? So in order to gather vital capacity, all you need is a simple, inexpensive windmill spirometer like this. Or a forced air volumeter or a digital spirometer. There's a couple of them out on the market. This is the particular one that I use in my practice and the one I'll be demonstrating today. And it's from Baseline. These devices cost around $150 to $200. So by purchasing that, you can like double your reimbursement for voice evaluations. And they'll allow you to include those aerodynamic measures in every voice evaluation without investing in high-cost equipment. These can be used between patients by attaching either a respiratory bacteria filter or a one-time use mouthpiece and then discarding it and wiping down the device with an alcohol wipe after use per the manufacturer instructions. So this is super important, not just from a billing standpoint, but from a broader professional standpoint. When we consistently include acoustic and aerodynamic data, we strengthen the clinical validity of our assessments. And we gather more objective information, we can track patient progress more accurately, and we can make stronger cases for medical necessity and interdisciplinary care. And ultimately, when we bill appropriately for our full scope of what we do, we're also advocating for better service for our patients, better outcomes grounded in objective data, and better pay for us as therapists, reflecting the value and complexity of our expertise. So as I demonstrate this vital capacity collection, I want you to think about how you could incorporate this or advocate for this in your facility, to integrate those laryngeal function study codes into your own workflow to both evaluate your clinical practice and support your patients better, okay? So I'm going to introduce my assistant that I have here with me today, and I'm going to move my computer. So this is Elodia Alcala. Everyone say hello to Elodia. Hello. She is a graduate student clinician from Jacksonville University. She was in her clinical placement with me this past semester, and she has graciously volunteered to be my demo patient today for us so you guys could see how this works. Yes, let me switch to full screen for the demo. Thank you, Jennifer. Let me see. that better? Okay, perfect. All right. Okay, so again, this is the baseline forced air volumeter or windmill spirometer that I'm going to be using today to kind of demonstrate. You measure the vital capacity using this for your patients, and this one goes from 0 to essentially 7 liters of air. And even though this is in liters, we want to take the vital capacity in milliliters. So you're going to have to do a little bit of a conversion. It's not hard to do. In order to set this at 0, this little dial on the end, I'm sorry, I'm trying to, rotates. Okay, and we're going to set it at 0 first so that we have it at baseline. Then from there, we are going to ask our patient to take in as much air as they possibly can into their lungs, seal their mouth around the mouthpiece, and then they're going to blow out for about 5 seconds, trying to get rid of all of their air. We want all of it to go through the device. We're trying to get a measure of that vital capacity, the most amount of air that they can get in. So I've already set this back to 0. I'm going to give it to my patient here. Okay. And what I want you to do is I want you to take in a full deep breath, as much air as you can into your lungs, and then I want you to blow all your air into that device. Are you ready?
Yes.
Go ahead. Okay, so she has completed that, and you'll notice that now the dial is no longer at 0, it's now at 1.3. Yep, I'm reading that backwards on the screen. So that's 1,300 milliliters. And I can compare that to normative values in my evaluation. Now, she did not blow out as effectively as she could have, and that's because I wasn't cueing her effectively. So I'm going to show you how to do that. And I actually asked her to do that, so she knew I was going to ask her to do that ahead of time. So I set it back to 0. We're going to try this again. Okay, now I want you to try that again. Take as much air as you can into your lungs and then blow it all into the device. Are you ready?
Yes.
Go ahead. Go, 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 go. So that time I really kind of pushed her to do it, and you'll notice that she has a much larger vital capacity that time through. So she went all the way to about 2.1, which is 2.1 liters or 2,100 milliliters. And when I do this, I always do 3 trials because there is a learning curve and your patients will improve as they learn how to do this. All right, we're going to try that again. Go ahead, take a deep breath in, and go, 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 go. And again, you can see she even increased a little bit more that time from that learning. And so her vital capacity is somewhere around 2.25 or 2,250 milliliters. From there, I would take her maximum phonation time, and then I would calculate the phonation quotient and the estimated mean airflow rate from those numbers and compare them to the normative data. And that will really guide my treatment in treatment planning, because I can determine from those numbers whether the impairment is respiratory in nature, phonatory valving in nature, a combination of those things. It really gives me some driving factors to kind of help base my treatment. So from there, I'm going to take the mouthpiece, I'm going to discard it because it's a one-time use. And then this part unscrews. I'm going to take my alcohol wipe and I'm going to go ahead and wipe it down really well in between my patients on both sides, anywhere that their air may have come into contact with the device. So with that alone, that almost doubles my reimbursement for my voice evaluations. That's super important. Okay, any quick questions on that before we move on? I'm gonna go ahead. Is it billable as DME? No. So it would be just like it would be a piece of equipment that you would then have in your clinic that you would use. So this one is from Baseline. It's a forced air volumeter, but there are other ones on the market. And again, I'll point you to Dr. James Curtis. He provides some links to different purchasing items on his website. So if you can't find this one or you want a different one, he has some different options that are at different price points, but they are pretty low cost. And you can advocate for your clinic to purchase one by kind of helping tell them that this is going to double your reimbursement. Like, that's huge. The normative values you can also get on Dr. James Curtis's website as well. Okay, oops, hold on. I just got myself technical difficulties switching between the screens. Okay. After my presentation, I'll try to post the links in the chat, okay? All right. So the next one that I'm going to demo is some resistance band techniques that I use fairly frequently in my therapy. But before we jump into kind of using those resistance bands for the neck exercises, I'm going to talk to you a little bit about why that matters for voice therapy. So laryngeal tension, particularly for patients with either primary or secondary muscle tension dysphonia, does not happen in isolation. The neck is an integrated system. The deep cervical flexors and extensors, along with the sternocleidomastoid muscles, provide the stabilizing foundation for head and neck posture. And when those muscles are weak or fatigued, then superficial muscles, including those near the larynx, overwork, increasing tension and making phonation and swallowing harder. So these TheraBand techniques, I modify versions of them for both patients with muscle tension dysphonia and muscle tension dysphagia as appropriate. Many of the patients that we see, those with trauma, chronic neck discomfort or pain, prolonged sitting, or poor ergonomics, show a pattern of weak, deep stabilizers, overactive superficial muscles, and inefficient load distribution. This contributes directly to persistent extrinsic laryngeal tension. So targeted PT-informed exercises like cervical flexion and cervical extension with a resistance band or TheraBand support the musculoskeletal foundation without stepping outside of our SLP scope. Many of these techniques come from collaborative learning that I've done with my PT and OT colleagues, and I really strongly encourage cross-disciplinary collaboration for working with all of our patients because it just really improves our patient outcomes and kind of our understanding of how different systems work from an integrative perspective. The exercises that I'm going to show you re-engage deep neck muscles, restore balance, and improve posture so that the laryngeal muscles don't have to overcompensate. I'm going to demonstrate some of the variations next. And I want you to watch for ways that you could potentially integrate them into your voice therapy, especially for patients whose tension patterns aren't responding to traditional therapy approaches for voice therapy. So let me just move move my computer here. Couple of things before I demo. You want to consult a doctor before starting any kind of neck flexion extension exercises. If your patient has had recent neck or shoulder surgery, recent acute soft tissue injury or acute fracture, bone or connective tissue diseases, rheumatoid arthritis, ankylosing spondylitis, spinal cord compression, nerve root compression, cervical radiculopathy or myelopathy, severe osteoporosis, vascular problems, severe joint hypermobility or instability, whiplash injury, fibromyalgia, or cervicogenic headaches. And You want to immediately stop an exercise like this and consult a doctor if the patient experiences a sharp or stabbing neck pain, tingling down the arm, headaches that occur during or shortly after the exercise, any dizziness or lightheadedness, shortness of breath, or weakness in the upper extremities. So let me stop sharing this, go back to full screen. And I'm going to move my computer so you guys can see me and Elodia a little bit better. Okay. All right. So for this, I'm going to give my patient a length of TheraBand. I use the red in my therapy techniques typically, which is a pretty light resistance. I don't really need anything more extensive than this for most of my patients, which is why I like this particular, and I can kind of self-grade it with my patients. And so what I'm going to do is I'm going to give them a length, and I'm going to have a length so I can kind of demo what I'm going to do. So what I want you to do is I want you to grab the TheraBand, and we're going to loop it around the back of your head. Okay? From there, you're going to pull out, keeping your shoulders nice and relaxed, and you're going to take your head and you're going to gently tuck your chin back into the TheraBand. You're going to get a little bit of light resistance, and then you're going to release. And then we're going to do that again, where you go back in and release. Okay, so this is where you're getting kind of away from that forward head posture, and you're getting them back into kind of a neutral position against resistance. What I love about this is you can do this with a lot of different voice techniques. So I could do this in conjunction with vocal function exercises, or I could do this in conjunction with some of my resonant voice exercises. And it helps to kind of just disengage some of that extra muscle tension that's going on. I often will do this in a very functional task with my patient, because my goal is always to work towards generalization as quickly as possible. Kind of thinking of that, I want to move them away from just sitting there blowing bubbles into a cup. SOVT, awesome exercises, but I want them to get past that, right? So I might have them do this during conversation and hold it for a good 30-second period while we're talking and release. Or if they're one of my singers, I might have them sing a phrase that they're having difficulty accessing after a particular vocal injury or muscle tension while they have the TheraBand engaged, okay? So things that I'm going to be looking for, I'm gonna kind of turn your chair here to the side, go ahead and sit, is where their chin and neck are kind of positioned, and whether they have this kind of like forward head posture, and getting them kind of back into neutral, okay? And so I'll have them do that. Other ways that you can kind of use the resistance band in therapy for voice, there's tons. You can use it for rotation, as far as kind of rotating against the band or tilting against the band to kind of help with those different neck flexors. And again, I encourage you to talk with your PT colleagues about like what all of those things help with. Oh, you can't hear me? Can you hear me now? Okay. But you can also use the TheraBand around a patient's diaphragm area when you're working on diaphragmatic breath to give them some increased proprioception and tactile input. So lots of great applications for this when you're using that resistance band. Okay, questions on that one? Okay, what areas are you aiming for in posterior head alignment, and how long do you hold? So when you're doing that like chin tuck, what it does is it kind of helps to disengage the neck flexors, and it relaxes everything a little bit. So I'm engaging them to have good posture, but I'm also kind of disengaging some of that extra muscle tension. And so I'm going to have them hold for like short 30-second to 1-minute bursts, because I also don't want to fatigue them out. But I want them to do something that is functional. Okay. And I'm going to work them away from it pretty quickly, which I'm going to show you in one of our case studies here in a minute. Any other questions before I move on to another demo? All right. So one of the other things that I love using in my voice therapy is a paper towel. Everybody has this available in their home for the most part. If not, you can use a washcloth. Kind of same concept. Most people have access to them, so it's easy for them to do this as part of their home practice. And when I use these, I'm typically using them for tongue stretches. In voice therapy, incorporating tongue stretches can make a really meaningful difference in vocal outcomes because the tongue is one of the largest and strongest articulators, and it has direct connections to the hyoid bone and then the laryngeal framework. I see a lot of patients with voice problems that have a lot of excessive muscle tension, or they're unable to isolate their tongue from their larynx. And when that tongue is tight and held in the retracted position, it can pull the larynx upward, increase extrinsic laryngeal tension, and disrupt efficient resonance. That tension often shows up as strain, limited pitch range, or the sensation of effortful phonation. So by releasing the tongue, especially the base of the tongue, we reduce unnecessary pulling on the larynx, which improves phonatory freedom. It allows the vocal folds to vibrate with less resistance. Tongue stretches can also help with improving of airflow. They can shape resonance more efficiently and support clearer, easier voice production. So even though tongue stretches seem kind of simple, they directly support reduced tension, improved resonance, and more efficient voice, all of which translates to better voice outcomes. Now, most of the time when I think of therapists incorporating tongue stretching routines into therapy, the problem is that we don't always incorporate them in the correct way, or we might not know exactly which tongue stretches to provide our patients. So that's what I want to demo for you today. When we think about tongue stretching, the same principles that apply to other skeletal muscles also apply here. So the muscle tissue of the tongue responds to stretching based on duration, frequency, and purpose. For general flexibility and mobility, holding a tongue stretch for 15 to 30 seconds is ideal. Most people who stretch do not stretch for that length of time. They typically are going to stretch for maybe 5 to 8 seconds. They're going to feel like 15 to 30 seconds takes forever. So I will often set a timer for my patients when I'm having them do these stretches to make sure they're stretching for the allotted amount of time to get the most gains. Most of the gains in range of motion happen in that first half minute. And if a patient has significant stress or reduced mobility in the base of the tongue, we may even increase the hold to 30 to 60 seconds because longer durations can reduce muscle tightness more effectively. And the key is consistency. So performing these stretches 2 to 3 times per week or daily for a lot of my patients with 2 to 4 repetitions at that 30 to 60 second hold mark helps to remodel habitual tension patterns and create more lasting mobility improvements. So for voice therapy, this is often what we're aiming for. Greater flexibility to reduce extrinsic laryngeal tension and improve phonatory ease. So regardless of timing, we also want to avoid any bouncing or forcing the stretch. We are not pulling the tongue. We are just kind of getting a really gentle stretch. We don't want to trigger any kind of protective contraction instead of kind of moving them into that relaxation. So what I do is I have them get their washcloth or their paper towel, and I'm going to fold the paper towel into a strip like this. You could also use gauze. You don't want to use toilet paper, tissue paper. It will disintegrate in their mouth. It'll be disgusting. And I have a terrible tactile problem with that. So yeah, we don't want to do that to our patients. Okay, so paper towels, washcloths, gauze is totally fine. Okay, then you're going to have them wrap it around their tongue. You're going to have them stick out their tongue, and they're going to grab onto the paper towel or the washcloth. That gives them something not wet to hold on to. And you're going to have them stretch their tongue for that about 30-second period. So if I were instructing my patient to do that, I'm going to kind of move over here to show you with Elodia. All right, so I'm going to have you stretch your tongue for about 30 seconds. You're going to take your paper towel and you're going to wrap it around your tongue so that you have something to hold on to. And you're going to stretch your tongue out. Now, when you stretch your tongue out, I do not want you pulling your tongue. You are gently stretching it and encouraging the stretch. It should be a nice, gentle stretch. You want to respect the natural curve of your tongue. Your tongue does not go straight out. It kind of comes down and it curves out. So you want to respect that, okay? So it's going to look something like this. As you're doing this, I want you to focus on taking really relaxed nasal diaphragmatic breaths. Nice and slow, try to relax those shoulders. And just stretch here for a good 30-second period. It's going to last a lot longer than you think it's going to. So from here, I have her stretch. I might have the timer going. They relax and release, and I give them a rest break. Okay, you can go ahead and relax. So now I want to kind of work on isolating the tongue away from the phonatory system. So I'm going to get a little bit of a deeper stretch and I'm going to start incorporating some phonation. So the next one that I want you to do is we're going to do that same stretch, but I want you to incorporate a yawn. This is going to stretch the tongue and get that lift of the palate. So you're kind of doing an alternate force stretch where you're getting a stretch of the palate back, a stretch of the base of the tongue forward, and it kind of deepens the stretch. Okay, so go ahead and get that tongue stretched out again, just like we did before. Good. And now I want you to gently yawn against it. Good. Perfect. And I might do like 6 to 8 repetitions of this, getting that deeper stretch. Okay. Next, I can take this into phonation. So I'm going to have them keep the stretch, and I want you to do ah. Ah. Good. And now we're going to go down. Ah. Ah. So I can do pitch glides with this. I can do scales. Ah. Ah. I can even do short phrases of songs for my singers. Or I can have them try to kind of like approximate a phrase if they are not a singer and they're just speaking voice. So I want you to approximate, hi, my name is Elodia. Hi, my name is Elodia. Perfect. And that helps them to kind of sometimes feel the isolation of the tongue from the phonatory system. You can go ahead and let go. And what you'll notice is a lot of our patients will say, like, I feel my tongue trying to like bunch back as I'm doing that. And that kind of gives you an indication that the tongue is trying to like over-engage. And so this can be really helpful for them. It can be very effective for providing that extra feedback for them. And I just love this technique for some of my singers. It can be and my speakers, it can be super effective in kind of getting rid of that extra muscle tension. I have a question in the chat that says, sorry, didn't finish. You mentioned having singers as client. Is it difficult to get insurance coverage if singing is not their profession? How can we advocate for improved singing as a quality of life measure to help get coverage? And is there a scale that exists? Ooh, that's a very complex question. So that can get a little sticky, but singing is a huge quality of life measure, right? A lot of our patients, singing is part of their identity. It's part of what makes them happy. If they can't sing, they feel depressed. They feel anxious. They have like a lot of other issues tied to that. I do have a lot of professional singers that I work with, or semi-professional singers, but I do have also a lot of patients who have problems with their singing, along with their speaking voice. And yes, you can get them coverage with insurance. You just have to be really good at documenting and know that if there's an issue in the singing voice, there is also an issue in the speaking voice. Like pretty much 100% of the time, even if the patient is not necessarily reporting that, there's crossover. And there's a lot of crossover things that we can do. In my documentation, especially with like my Medicare patients, I might be documenting that I'm practicing techniques, voice therapy techniques, during high intensity voice tasks instead of practicing during singing tasks. And so that can be a way you can kind of get around that. And you can document that it is medically necessary for improved quality of life. There's the Vocal Handicap Index for Singing as a patient-reported outcome measure. There is also the EASE, which I forget what that stands for, but that's another one for singing. I think there's a third one that I'm forgetting off the top of my head. And then I also have my own patient-reported outcome measure for performers that I use in my clinical practice, just from my experience that I have developed over the years, that gives me a lot of information about their habits and what they're doing. And so I use that as well. Okay. So reimbursement, yes, it's a challenge with voice, but it's also not a challenge if you can kind of figure out what to do to help kind of navigate that patient and document really well. And that's the challenging part, is figuring out how to document really well. And yes, I'm thinking of my Parkinson's patients right now because a lot of them have that forward head posture. And so PD patients can sometimes benefit from that neck flexion, neck extension exercise, and kind of unkinking the hose. And I love that for them. Okay. The next one that I want to go over is the wall technique. And I'm going to actually just quickly do an introduction of this, and then you're going to see me do it in the case study because I want to get to the case study. So this technique is based on the work of Dominique Marsom, and her exercise using the wall is outlined in Exercises for Voice Therapy, 3rd edition by Behrman and Haskell on page 139. That's this book. I have taken it and I've incorporated it and kind of modified it for my patients based on what I'm seeing in front of me. And I love this technique because many of our patients with voice problems struggle with proprioception and interoception skills, which makes resonant voice therapy very abstract for them and very difficult. I love this technique because it provides amplified proprioceptive input almost immediately for resonant voice techniques. And you can use it in conversation. It's wonderful. I absolutely love it. So, with that being said, I'm going to switch back over to my share screen. And we're gonna look at a case study. And you should have in your handouts for like today a series of questions that go along with this case study, and you may want to have them in front of you because I'm going to ask you to put some answers in the chat as this goes.
Let's apply some of these techniques to the case of a 45-year-old female semi-professional singer who came to me with significant concerns about both her speaking and singing voice. She reports that during a live performance, she suddenly felt what she described as a pop in her throat, immediately followed by a strong spasm-like sensation, which she stated was visible to the other performers on stage. Despite this, she pushed through the remainder of the performance. About 2 days later, she noticed she had almost no...
Hold on, I'm hearing that there's an echo, so give me a second. I'm gonna go back and I'm gonna
Let's apply some of these techniques to the case of a 45-year-old female semi-professional singer who came to me with significant concerns about both her speaking and singing voice. She reports that during a live performance, she suddenly felt what she described as a pop in her throat, immediately followed by a strong spasm-like sensation, which she stated was visible to the other performers on stage.
Okay, we're still hearing an echo. Hold on, let me see what I can do. I have to mute my mic while it's playing. Let me try that. Hold on.
Let's apply some of these techniques to the case of a 45-year-old female semi-professional singer who came to me with significant concerns about both her speaking and singing voice. She reports that during a live performance, she suddenly felt what she described as a pop in her throat, immediately followed by a strong spasm-like sensation, which she stated was visible to the other performers on stage. Despite this, she pushed through the remainder of the performance. About 2 days later, she noticed she had almost no voice at all. Since that event, her voice has remained significantly impaired. She describes a constant sensation of a rock in her throat and says it feels like she has to swallow around the rock. She also reports increasing pain with voice use and a tight pulling sensation near her right ear. Because it hurts to use her full voice, she admits she's been whispering frequently, which is further taxing her system. The patient also shared a relevant medical history. She was involved in a car accident 3 years ago and sustained cervical spine injuries with herniations. She notes that her pain at the time was predominantly right-sided, which she mentioned to her ENT because she wondered if her prior neck trauma might be related to her current symptoms. We completed a video stroboscopy, which revealed bilateral vocal fold edema ranging from mild to moderate, along with stringy mucus and a convex free edge contour bilaterally. Importantly, vibratory amplitude and mucosal wave were significantly reduced on the right side, approximately 25% for both amplitude and wave, compared to the left, which demonstrated about 50% amplitude and a 75% mucosal wave. We also observed a very small pinpoint area of non-vibrating tissue at the strike zone on both vocal folds. This could indicate an early-stage lesion, but given the timeline and symptoms reported by the patient during the patient interview, it was likely an area of healing phonotrauma. Additionally, pachydermia and arytenoid erythema were present, pointing towards potential laryngopharyngeal reflux involvement. Glottal closure was inconsistent, with intermittent phase asymmetry during vibration. Objective and perceptual measures, as well as patient-reported outcome measures, supported these findings. When we integrate all of this information, the clinical picture is consistent with phonotrauma-related dysphonia, complicated by secondary muscle tension dysphonia, and likely laryngopharyngeal reflux. Her history of neck and shoulder trauma and possible pelvic floor dysfunction may also be contributing to a more global pattern of muscular tension, which is feeding into her maladaptive phonatory behaviors. Overall, this is a complex case in which biomechanical, behavioral, and medical factors are all interacting. Our plan moving forward included targeted voice therapy focusing on tension reduction, airflow coordination, and improved vocal efficiency, along with medical management for reflux and appropriate referrals for musculoskeletal and pelvic floor evaluation. As you watch this next clip, I want you to focus on what you notice in her baseline singing before we introduce any therapeutic techniques. Pay attention to the compensatory strategies she might be using. Do you see signs of extrinsic muscle engagement? How is her airflow? Does she look like she's working harder than she needs to? Notice her posture, her physical alignment, and the overall intensity she's producing. Also, keep in mind her history of neck trauma and the musculoskeletal tension patterns she's described. As you watch, think about how these factors might be showing up in her phonatory behavior in real time. As you observe her movements, ask yourself whether you see signs of muscle tension. If so, where does it appear most clearly? In the supraglottic area, in her neck, shoulders, maybe her jaw? Finally, take a moment to listen closely to her sound. What auditory perceptual cues stand out to you? Do you hear breathiness, roughness, strain, or instability in pitch? Put any thoughts you have or answers to these questions in the chat.
Pause there. How are we feeling so far?
I feel tight here.
Okay.
I definitely feel myself pushing forward.
During this next clip, you'll see the patient using one of the TheraBand techniques. I'd like you to pay attention to the changes you hear and see once the TheraBand is introduced. First, listen for any shifts in her vocal consistency, her breath flow, and the overall ease of her sound. Does her voice seem steadier? Does phonation look or sound more supported? As you observe, think about the role of the TheraBand's external proprioceptive input. How might the tactile and kinesthetic feedback be helping her modify her phonatory patterns? Is the TheraBand giving her a clearer sense of grounding, expansion, or release? Take a look at her posture as well. Does she appear more aligned? Do you notice differences in her breath initiation or tension distribution, especially around the neck, shoulders, or rib cage once she begins using the band? If you were to quantify her response to this intervention, what markers would stand out to you? I once again encourage you to put any thoughts you have or answers to these questions in the chat.
And think about just letting your voice float out like we did last time. Remember, instead of holding it back.
Let the heavens sing His glory as the angels sing His praise. All creation exalt Him. Sing the Lord today. Let the heavens sing His glory as the angels sing His praise. All creation exalt Him. Sing the Lord today. The prophets tell our story.
Think like bobblehead.
About a newborn King. hands. All creation is talking.
Much better.
Today.
Okay, how did that feel?
So much better. It's not easy.
So it sounded much more fuller.
It felt that way.
It sounded freer.
It felt like it was easier to get the air out.
Okay, so
Now, as the clip transitions to the moment when the TheraBand is removed, continue to watch for signs of carryover. Does she maintain any of the improved behaviors without the external support? If she does, which ones persist? If she doesn't, consider what that tells us about her reliance on external cues. And finally, think about what her level of carryover reveals about her somatosensory awareness and her current stage of motor learning. Is she still in a high cueing, high feedback phase, or is she beginning to internalize and generalize the new patterns? Put your thoughts in the chat.
think back into the TheraBand, even though it's not there, right?
Let's celebrate birthday of our Savior. Lift up your voice and sing. Lift up your voice and sing.
How'd that feel?
So much better. I didn't tighten up either. I noticed, like, it just felt more. I think this may not make sense, but it's almost like because I knew I had the breath support, I didn't feel like I needed to force. Okay, it's starting to click. It's starting to click.
Yeah.
Okay,
That's perfect.
As you watch this next clip, you'll see the patient working with the wall technique. I'd like you to focus first on how this technique affects her alignment, resonance placement, and her breath-voice coordination. What changes once she's in contact with the wall, and how does that seem to influence the way her voice sounds? As you observe her, look for any shifts in tension. Does she appear calmer or more anchored when she has the additional support of the wall? Think about the physiologic target that seems to benefit most from this technique. Does it give her stronger respiratory grounding, better forward resonance, decreased neck involvement, or perhaps something else entirely? And finally, listen closely to the vocal quality during this segment. How does the sound she produces with wall support compare to what you heard during the TheraBand supported phonation? Is it brighter, steadier, freer, or more stable in pitch or airflow, or is it the same? As always, please put your answers, thoughts, and questions in the chat.
let's celebrate.
Good.
Birthday of our Savior. Lift up your voice and sing. Lift up your voice and sing.
Okay, come away from the wall. What did you feel and hear that time?
The breath support that I got when I wasn't like tensing up.
Okay. Did you hear all of that vibration and fullness to the sound?
Yes.
And how supported it was?
Yeah.
Okay, I want you to think that.
Okay.
Come away from the wall.
Relaxation.
I need to give it a little bit of movement. Like, relax and move with it.
Birthday of our Savior. Lift up your voice and sing. Lift up your voice and sing.
Better?
Yes.
What'd you notice that time?
I felt relaxed in my body. I did not tense up like I did sitting. Like I just felt more loose. I had more breath support for sure, but I think for me, just not like tensing, like closing up internally. Like that was a bigger thing.
As we pull everything together, let's consider this from a generalization perspective. Think about how you might modify or sequence these techniques to support carryover into her everyday life. How might you layer or blend these approaches so she gradually transitions from externally supported tasks into independent functional phonation? And if you were designing her home program, which exercises would you prioritize?
As you reflect, think not just about the techniques themselves, but about why you would choose them, what specific physiologic targets they are supporting, and how they advance this particular patient towards stable, sustainable vocal function in everyday life.
Okay.
Let's apply.
Hold on. How do we? Oh no. See if we can go forward on that slide. Okay, so we're now at the Q&A, which unfortunately, because of timing, I am so sorry. I have such limited time to do the Q&A, but I will stick around in the chat to kind of answer any questions. One of the questions was, what are your instructions with wall technique and placement of the body? So I typically have them stand about a foot from the wall. They place their forehead gently against the wall, and they're kind of leaning forward a little bit. And then I have them relax their shoulders and just dangle their arms, like disengage everything. And what it does is it kind of creates like a resonance bubble around them. They get extra proprioceptive input and extra vibration. They can feel their placement a little bit better. It's kind of like putting a fishbowl over top of your head, like it amplifies all the vibrations. And so it can be really effective for patients who have trouble with kind of that kinesthetic, proprioceptive, interoceptive awareness piece of the resonance placement. Any other things that I can help with really quickly before I pop off into the chat? I'm hoping you guys all gained something that you can walk away with next week and try with one of your patients.
Thank you so much. Okay. I'm going to introduce our next speaker, Dr. Lori Morgan. I just changed a setting. Hold on.
So I think my audio is on, but I can't seem to disable the video block. I could sign back in. Can you hear me?
How about now?
There we go. Hey, start my video. Okay, awesome. And I'm not sure what's going on. I seem to be having like this Stranger Things moment with my camera on the is like flashing on and off, and I don't quite know why. I tried adjusting all my lights, so I'm not sure. Any suggestions? I don't want to give anyone a seizure.
Joy, do you have any suggestions on lighting? I wonder if it's just a Zoom. hiccup.
But yeah, I tried adjusting my lights. Mallory, do you want to try turning that light on? I'm going to try one more time because I got it to stop for a second and then it started back again. But I know it's super annoying. I promise a Demogorgon is not going to jump out. Well, I guess we'll just go ahead and get started, as annoying as this might be. So, hi, everyone. I'm Lori Burkhead Morgan, and I'm super excited to be here to talk to you about surface electromyography. And I will have my daughter here to help me in just a moment to demonstrate how all that works. So first, maybe if I get off of my face and share my screen with you, and we can get to the slides and some other things, maybe that will make things a little bit better. Let's see. Okay, so here's the name of my talk. These are my disclosures, some financial and some non-financial volunteer work that I do for the medical SLP and the MedSLP Ed and the collective. This is the agenda. We're going to chat just a little bit about the rationale of SEMG, and then we'll jump right into some fun demo stuff. So here are the learner objectives. I mean, basically what I'd like for you all to do is to figure out a little bit about what SEMG biofeedback is, how to target some specific parameters. I wish I had many hours to show you all the different things that can be done. I've used this for hemifacial asymmetry, with speech production, lots of different things. But today we're going to focus on swallowing onset, hyolaryngeal elevation, and how to decrease baseline muscle tension. Those are some of the main things that I work with and that I'm sure that you would be encountering as well. And I would like for you to be able to describe the primary electrode placement for providing this SEMG biofeedback for swallowing exercise, particularly the swallowing, effortful swallow, but also the Mendelssohn and also the relaxation. So we'll get started. A little bit about me. So I'm
sorry, we can't see your slides.
Oh, you can't see my slides? Oh, goodness. Let's see. Let's see. Well, it worked yesterday. Let's try. So I'm on screen share. Can you see it now?
Yep, it's not in slideshow format, but I can see them.
How about now?
Yep, you're good.
Okay, great. Nothing like some, so maybe the Demogorgons are here because in the test run yesterday, this worked beautifully. We'll blame it on the Demogorgons. Okay, so I do have about 30 plus years of experience. So I come to you not only with my academician hat, but also as a in the trenches speech pathologist. I've worked everywhere from a level 1 trauma center, inpatient, outpatient, and a variety of diagnoses, as you can see there. After about a decade of practice, I got super frustrated and wanted to contribute to how we can improve the delivery, particularly of dysphagia rehabilitation as it relates to motor learning, exercise physiology. So about 2005, I ended up getting my PhD, and then I've been teaching, doing research, and still doing clinical practice ever since. Never stopped giving up clinical practice. So the sources I'm using here today were collected recently, and it's a compilation of the resources I collected as well as my experience and evidence-based practices and my expertise, and of course, pulling from peer-reviewed publications. These are my attributions to where I got the images for my slides. And then here's a great list of, well, I hope you think is a great list of some of my favorite articles with reference to SEMG. And I'll be referencing these throughout the talk, but then also this would be a great reading list that I would suggest for you all. And I wanted to point out this one, Leach and colleagues from 2022. That is a really great article, a more recent article where they talk about updates in motor learning. And this is in a physical therapy journal, but I think the concepts certainly apply to what we do in speech pathology. And like I said, when I went back for my PhD, I glommed on to exercise science, exercise physiology, because we're asked to do exercise in our field, and yet we really have not gotten much of any of that training until recent years, really, in speech pathology. So that's a really great more recent article about how to, it gives you specific suggestions on how to incorporate motor learning into your therapy sessions. And that can apply not only to swallowing, but also to motor speech. So what is biofeedback? I guess we can start there. Let me move this little guy around. There we go. So biofeedback really is a process that enables us to learn how to change physiologic activity for the purposes of improving health and performance. So that's the basic gist of what biofeedback is. It does go on to say that precise instruments that measure physiologic activity. And I stop and pause and highlight that there because that's what we're going to be talking about today, how to just use an instrument. There are lots of instruments available. SEMG is not the only biofeedback instrument. We'll talk about that just a touch. But it's using an instrument to help measure physiologic activity. It can be everything from brain waves, heart function, breathing, muscle activity, which is SEMG, skin temperature, etc. So these instruments are supposed to give a real-time or rapid and accurate feedback information to the user. The presentation of this information often in conjunction with changes in thinking, emotions, and behavior supports the desired physiologic changes. Over time, and this is the most important part, this is where motor learning comes in. Over time, these changes can endure without continued use of that instrument. So you don't have to use, and hopefully would not want to use biofeedback in life. So this is a tool to help patients move through motor learning much more effectively than us just sitting there going, swallow harder. I think you can do it harder, because that doesn't measure anything at all. And it's kind of ridiculous when you think about it. So biofeedback in swallowing rehab can be even used during the instrumentation phase, and I would argue should be used in the instrumentation and evaluation phase. So I do this in my video fluoroscopy by turning the monitor in radiology, pointing out just some basic structures, usually the hyoid, the airway, and the base of tongue, the jawline, to the patients. And then based on what I'm seeing or what I want the patient to do, I'll ask them, I want to see that little hyoid bone go up and forward. And the way I want you to do that is press your tongue against the roof of your mouth and swallow hard. So instructions for an effortful swallow with a lingual focus. And when we do that, hopefully I'll tell the patient, hopefully we'll see that little bone move up and forward, and that should make everything else work better. And hopefully you won't see any residue on this swallow. Let's give it a shot. And then we go ahead and do that under fluoro. Ianessa Humbert has also published an article. It's not referenced in here, but she also published an article talking about the kinematic biofeedback with video fluoroscopy and how that's superior than SEMG, because they're seeing kinematic biofeedback, not just muscle activity. So this is frequently used, and there's precedent for it in the literature. So I would encourage you to consider using biofeedback in your instrumentation. Much easier with fees. We can have the patient try different maneuvers and make sure the maneuvers are causing the types of structural change, perhaps, or physiologic change that we want to see during the swallow, or that residue is decreased with that immediate biofeedback. What I like to do, because in fluoro, obviously because of the radiation exposure, our time is limited. How much biofeedback we can do is very limited. But in fees, we can do it a lot longer. As a matter of fact, even outside of the evaluation phase, I'll drop a scope and have a patient do some maneuvers and get that immediate biofeedback with the endoscopy during my therapy session. So by doing this in your instrumentation, in your assessment, you're looking for stimulability for exercises or techniques that you want the patient to do. And also it helps encourage proper technique of these exercises or maneuvers. It's also great to use negative feedback. Okay, I want you to do it the old way. Now swallow the new way that I showed you, and let's see what changes. Less residue, faster swallow, better movement, whatever the case, whatever your target happens to be. So in therapy, as I mentioned, I would use endoscopic biofeedback, SCMG biofeedback, which will be highlighted here today, and I'll be showing you how to do that. But you can use something as simple as a mirror, even a heart rate monitor in the ICU settings, or the pulse ox. One of my favorite things about working in the ICU is that patients are hooked up to everything. I know a lot of folks find it scary to be in the ICU. I find it less scary because I know exactly what's going on with breathing rate, oxygenation, heart rate, all of those things. So one way I've used biofeedback in the ICU is with placing passenger speaking valves, either in line with the vent or just on trach collar. So we can look at heart rate, we can look at oxygenation level, we can look at all sorts of things. But that's, again, yet another form of biofeedback. So it's any tools we can use, as low tech as a mirror, or as high tech as video fluoroscopy or SEMG, just giving patients that feedback of what their bodies are doing and how they can change that. So the thing about SEMG biofeedback that I think is kind of crazy is that it's one of our most evidence-based practices that has been in the literature for decades, and yet it's something that we're not using. So it was first cited in the literature by Haynes in 1976, specifically looking at SEMG biofeedback in dysphagia rehabilitation. Another resource I just wanted to point out to you, if this is something you'd like to learn about in your practice and you want a tutorial, the tutorial written here by Crary and Grower in 2000, absolutely fantastic resource. So I would encourage you to use that kind of as your Bible when you're starting biofeedback, SEMG biofeedback. So as I stated in the earlier slide, this using biofeedback helps with motor learning. So motor learning is defined as it helps us create automatic movements, patterns and skills that we do repeatedly until that pattern or skill, the new pattern or skill, is ingrained in the motor system. So this starts out as a highly cognitive task, and then as more practice ensues, eventually it becomes autonomous. So that's what we do with the biofeedback. We're bringing the muscle activity and the pattern of muscle activation to the forefront for the patient to be able to modify over time. Then we take that off. They start learning, what does it feel like when I do it the right way or my new way? We have them use the biofeedback, and then I'll block the biofeedback, maybe have them look away, have them do the new task like the effortful swallow or whatever our goal is, and then have them look back at the screen and say, hey, did you do it right this time? Once they get to a place where they don't need that visual biofeedback, then we can take the biofeedback off completely. And then that's when the patient just starts using it automatically. At first, they might have to really pay more attention to it, but the goal is eventually patients don't even need to think about it. Their body has learned this motor pattern, and then it just works. So as I mentioned in this Leach 2022 article, that the mechanism of motor learning, or this instructive motor learning, is a mechanism where motor learning is elicited when the learner is provided specific external feedback. I emphasize that because that's what we're talking about here today. But that's what instructive motor learning requires. So what do we use as a speech pathologist? What are you going to use? What is that external feedback? If we're not using some form of external feedback other than, I think you swallowed harder. I don't know. Let me feel. What are we feeling? First of all, don't get me started on that. But, touching and feeling and guessing what's going on is not truly external biofeedback. That's called educated guesswork. Better than nothing or not. Again, conversation for another day. But external feedback is necessary. So that learner is provided with specific external feedback about a movement, error, or performance that's related to a task. So in our task, that's swallowing. And that will prompt the development of an internal error-reducing movement strategy. Sorry, there's a typo there. I'll fix that. So an error-reducing movement strategy. So here's just some screenshots of some examples with SEMG biofeedback. The one with the purple tracing over here shows muscle tension. And muscle tension, if the larynx is riding high and there's not a lot of room for movement for the hyolaryngeal excursion during a good swallow, that can alter the kinematic pattern. So if someone starts out with excessive tension, what we can do, you don't know that, right? I can touch and feel, and I don't know if touching or feeling if a patient's got tension or not. But using biofeedback, we can work first just on that. That's oftentimes the very first thing I work on. When I hook a patient up to biofeedback, their relaxation scores, or the resting scores rather, are quite high, as you can see with the purple tracing here. And so then we work just on that, and then we can start working on more normal motor patterns. On the right side of your screen, where you see the blue tracings, those are examples of extraneous movements or disruptive movement patterns. So this might be tongue pumping, or other movements, tongue movements in and out of the mouth that disrupt a normal swallow pattern. So just to give you the overview, this is my son. So you're getting to see both of my teenagers today. This is my son, Max, my 15-year-old, showing how I would put the electrode on a patient. So every electrode, whether you use the one I'm going to be demonstrating today or a different brand, or you don't even have to buy anything. The other thing I always tell therapists is to go hang out with your PTs and OTs and ask them for their biofeedback equipment. A lot of times they'll have some laying around, particularly the OTs will have some of this equipment laying around in a supply closet collecting dust. And go get that out and just put it on your arm or on your suprahyoid muscle group, on any muscle, and start playing with it and see how that particular machine works. So again, this is device agnostic. Get any biofeedback device. However, when you are putting on a biofeedback electrode, there are a couple things to be aware of. A biofeedback electrode will have active and ground contacts. So here on this little patch, all the way around the left side of the screen, you see two small metal contacts. Whoops, sorry about that. Those are the active electrodes. Those are the ones that are going to be collecting muscle activity. On this particular electrode patch, there's a larger contact, and that one is the ground. Now, I have gone into OT closets and pulled out things where there would be 3 separate wires, 2 active and 1 ground. You want to have the active electrodes pretty close to each other because they're going to be collecting information between the 2 contacts. So I like using these patches where everything is a constant distance from each other. But just know that if you do run across a biofeedback unit that has 3 separate wires, leads, identify which 2 are your active and which 1 is your ground. Now that ground wire can be placed anywhere, but it's away from your active muscles that you're wanting to collect the information from. The other thing to remember, if you're, again, just pulling something out of your OT's closet and trying to play around with that, is that all electrodes must have a medium for electrical activity to be conducted to the electrode itself. So you need some sort of electrode gel. So I've used units where I had to put a little, like the ultrasound gel on each of the contacts before putting it on the patient. If you put a dry electrode with no transducing medium in there, you will get weird signals that are not picking up muscle activity. So again, the pre-gelled electrode is what I have here. The electrode patch, many of them come with pre-gelled electrodes now. And this is just kind of a sticky, tacky substance, and it just sticks right on the skin. It's not the goop like ultrasound gel. It's a lot less messy, but it is pre-gelled. The other thing is if any one of these is ever pulled off, if the gel is off of the electrode, you just have to make sure you stick it back on. Okay. So those are the important things. Make sure you understand and can identify the active leads versus the ground lead. The active leads two leads need to be over the muscle group of interest, and the ground lead can be basically anywhere else. With this pre-gelled electrode, which was specifically designed for swallowing rehabilitation, it's nice and small. It fits right in the spot where we want it. As you can see on Max here, I have it on the submandibular triangle. So in the space between the hyoid and the anterior mandible, that fleshy area, that's where the suprahyoid muscle group is located. And that is the muscle group of interest when you're working with swallowing and trying to target things like hyolaryngeal elevation, better oropharyngeal or pharyngeal swallowing activity, okay? When we are collecting data from that area, what we're getting is not specific muscles. The only way that EMG can collect information from specific muscles is by doing hook, wire, needle electrodes. Ain't nobody got time for that. So that is not what we do. That's even not used a lot in research. It's a difficult thing to do. They have to be basically kind of surgically placed. So what we're collecting here is a conglomerate signal. We're getting a merged signal. Dr. Palmer and colleagues tried to figure out when we are doing SEMG biofeedback with this little patch electrode in the submandibular triangle, what muscles are we even getting information from? And using hook wire electrodes in conjunction with the patch electrode, he was able to identify there are three primary contributors to the SEMG signal. That's the mylohyoid, the anterior belly of the digastric, and the geniohyoid. So what's important about these muscles is that they are the primary drivers of hyolaryngeal elevation. And hyolaryngeal elevation, we know from many studies, is a primary marker of swallowing safety and a surrogate marker of range of motion, strength, pressure generation of what's going on in the pharynx. Just to be clear though, all we're looking at is muscle activity of the submandibular triangle, the suprahyoid muscles. And we're extrapolating that information to help us better understand or target what's going on in other aspects of swallowing. But just know that all we're really doing is looking at the activity of this group of muscles. And just to help you visualize that a little bit more, here are the muscles that we're looking at. The geniohyoid, I try to get really creative here. The geniohyoid is up under there, but they all contribute to this muscle with the activity and the electrode placed on the submandibular triangle. So there are lots of different SEMG resources out there. The two that I have worked personally with the most clinically that I like, and I've also done some research with one of them, are the ones offered by Prometheus Group and also Accelerated Care Plus or ACP. With their permission, they let me show you a few pictures here. So the top, and what I'll be showing you today, is the eMyo. So that's from Prometheus Group. The website is there. There's the MR25, which is the older version. That's the first one I started using. That's a portable little unit that can stick in your pocket, in your lab coat pocket, and you can bring that right into the ICU. It has some light bars on the front of it that show the muscle activity. It's a little more low tech, but it's portable, super portable. However, the unit I'm showing you today, the eMyo, can be used with a laptop or can be paired with a large monitor for like gaming, using your submandibular muscles. And what they do, you can actually play games. It's really super fun, especially with pediatrics. Because of time constraints, we're not doing that today. But again, maybe I can come back another day and we can check all that out. But these are the two units I use today. I'll be using the eMyo. I will say though, ACP more recently has developed a portable unit with a laptop, and it's also a fabulous unit. And that also you can still take a laptop into the ICU or all around the hospital building, inpatient, outpatient, whatever. So it's all super portable. But it also has a cart for something a little bit bigger. So lots of options. So let's get to it. Now let's see if I can stop sharing. Okay, hi. The Demogorgons are still here. Let's see. Let me minimize this. Oh no, actually, I want to share my screen again. Share. Okay, what I want to do is escape. There we go. No. Let me try escape. There we go. And I will minimize that. We're done with slides for today. Now we'll get into the good stuff. Okay, I need to turn my unit on. So this is the Prometheus group. It does password protected, so you always have to type in your password. On this particular unit, it also has like which hospital you're working at. If you're in your inpatient versus outpatient or different sites, it gives you the ability to document that. And then you go ahead and log in and start. And I am going to put my little girl, Mallory Sue, pull her up. Okay. And we'll go ahead and just pull up the screen, but then I will stop sharing because I want you to see my baby girl. Hi guys. But also I want you to see how we put on the electrodes. So, okay, I'll stop sharing for a second. Okay, are y'all seeing my face now?
Yes.
Okay, great. There's my baby girl.
Hi guys.
She is actually not a snarky, snotty little teenager. She's awesome. Okay, so what I'm going to do here is just take a alcohol pad and just wipe off under her chin any dead skin cells, any oils. Teenagers have oils. If you're working with men, they have to be clean shaven. And if they have a beard, I've had patients keep their beard. I just ask them to shave it up to the jawline so they still get the aesthetic of their beard, just not up under the chin. So they don't necessarily have to shave. Men will freak out if they have beards and you ask them to take them off. So, okay, so this is the eMyo. This is connected by Bluetooth through to the laptop that I'm using. And it has, that's great, has this little lead wire that attaches to the unit. So I'm going to attach that. And on the bottom of the unit, you'll have channel A and channel B, which will become important because what I like to do with my patients is to do the therapy with them. I find that it's much more better. It's much better if I can stop talking and start showing. So I show them what I want them to do instead of talking. And so if you have patients with language disorders, that's much appreciated. Here are how the electrodes come. They come in a little packet like so. And they come on this little strip. And here is the electrode lead. And you just have to line it up. Let's see. And I'm going to put myself on channel A and Mallory on channel B. You're the B team.
No, I'm cooler. B for better. Oh, she just got burned.
What did I say about her not being sexy? Okay, so what I'm doing is you want to feel for where her the hyoid is, and you want to make sure you're about a finger's width anterior to the hyoid, but not on the mandible. Okay, and we want to get that on there good. Okay, and then to keep the lead from pulling down, I tuck it behind the patient's ear, or you can pin it or clip it if you want to. For patients who have a lot of subcutaneous tissue or fat there, or elderly patients with a wattle or loose skin, you can take, I use Curlex and just wrap that around to keep the electrode not hanging. So the other principle to remember is that you want to have the active electrodes right on top of the active muscles. So if the loose skin is down here and the muscles are up here, you're not getting an accurate signal. So just be aware that you would want to press it up by using Curlex or whatever the patient's comfortable with. Okay. Oh, I need to.
Prep it.
I know. I have to.
Your skin is oily. You have to prep it. And if you have a beard, you have to shave your beard.
Well,
I'm learning.
At least she's listening. She doesn't always. Okay. Let me let that dry. I had a little makeup on mine.
It's yellow.
It's makeup. Okay. Okay.
I'm looking good.
All right. Okay. All right. So now that we've done that, let me go back to screen share. All right. So hopefully you're seeing my screen, a big white screen right now. Is that correct?
Yep.
Okay, good. All right. So I've already pulled up Mallory Sue. So now what I need to do is pick the protocol that I want to use. So they have some preset protocols in here. You can modify them or make your own custom electrodes, or I'm sorry, your own custom templates. So the first one I want to do is baseline single. Let me pull that up. And this is actually me. You're B team right now. This is me. And so I'm talking. And so here's another principle to be mindful of, is that, again, this is electromyography, surface electromyography biofeedback. Any movement the patient's going to do is going to register because they're activating the muscles. So it still takes a skilled therapist to be able to keep your eyes on the patient and make sure that the patterns that they're eliciting and showing on the screen are actually swallows or whatever it is that you're asking them to do. Because I'm talking and I'm getting all sorts of activity here. Patients can get really good at just tensing their muscles, but not actually eliciting a swallow. So you just have to make sure that you understand the limitations of what this is recording, which is just muscle activity, which can be anything from just tensing their muscles or talking to doing what you really want them to do. And so that's where the skilled service comes in, is you're still watching the patient and making sure that they're doing their exercises. This just provides biofeedback. So now I'm going to stop talking, and I want on the next screen sweep, to show you what relaxation should look like. So that's good relaxation. Very little muscle activity. You see a little blip here and there. I moved my tongue, but it essentially good baseline relaxation. The next thing I want to show you is relaxation, then followed by an effortful swallow. So I'm pausing that just so we can look at that. And that's something you can do with your patients. If they do something great or they do something really awful, you can pause the screen capture, and then just talk to them. So hopefully you can see my cursor. And I'm pointing here to the relaxation. This is the tall, skinny peak, which is a good, healthy, effortful swallow. So you see a good, quick onset, high peak. It looks like I got up to 50 something there, and then a good offset, and then relaxation. Okay. Next, I want to show you a Mendelssohn. So I'll just put continue. Okay, and I'll pause that for just a second. So here you see a good baseline followed by an immediate onset. That's my hyolaryngeal elevation. And then this is the struggle of the suprahyoid muscle group to maintain that hyolaryngeal elevation. And then when I stop the sustained contraction, then you see a quick drop off of muscle relaxation, followed by a good resting baseline. So that's what we want to see. So here is an effortful swallow. Here is a Mendelssohn. Okay. And now let me add Mallory in. So let's go to, we're going to keep it on baseline single, but now I'm going to modify the protocol. It's asking me if I really want to do that. And yes, I do. And now I'm going to come up here to screens, and I'm going to switch it to dual screen. So now let me pause it. Oh, so what it's asking me is, do I want to save the application protocol? This is where I can save it and name it like Mallory and Lori double screen. And then I can pull that up every time it's a saved protocol. I don't want to do that. So I'm just going to hit cancel. Oops, hold on. Modify protocol. Yes. Screens. Dual. Okay. All right, there we go. So now you can see Mallory on the bottom in purple, and you can see where it says channel B up here in the top left of that graph. And then on the top of the screen is channel A, that's me, with the blue tracing. So what we're going to do first is see how well Mallory can relax. All right, Mallory, I want you to do what I do. Look at my screen on the top, and I want you to do the same thing I do. Okay. Do y'all see here how my relaxation is pretty low and Mallory's is not? So I chose Mallory specifically because I wanted y'all to see how she does not relax very well. So Mallory is a singer, and one of the things that she does is struggle with extralaryngeal tension. So I'm going to change this single screen channel. Whoops. I'm going to change it to her channel, and we're going to just do. There we go. Now it's channel B. All right, Mallory, this is okay. And this is an example of how I would work with a patient who has a lot of muscle tension. Not uncommon with dysphagia patients. Okay, Mallory, what I want you to do is on that screen earlier where you saw my tracing was all the way at the floor. I want you to see what you can do to get it down to the floor. Now, first, let's do a couple of relaxation exercises. I want you to open your mouth and stick your tongue out all the way down like you're trying to touch your belly button with your tongue. Good, good. All right, now put it back in. Okay, so that's trying to help release a little bit of tension to the muscles. Okay, Mallory, now I want you just to relax your muscles. Take a nice deep breath, relax your shoulders down, and get your tracing down to the floor. So y'all can see she's doing a little bit better, especially right here. She has the potential, but she's still not quite getting it. And y'all, we're not staging this. This is truly Mallory.
I can't do it. I don't know how you do that.
This is truly Mallory. So what I'm going to do is I'm going to give her a goal. And I want her, I'm going to turn this on so it has a really annoying beeping sound when she is above the goal I'm going to set for her. I don't know if it's pretty soft. Okay, so I have it automatically starts at 10 microvolts. So what I'm going to do is bring it down. Whoops, there we go. Bring the goal down. She started relaxing pretty well. I'm going to bring this down. Let's try it 2 microvolts. So Mallory, can you relax and try to get the machine to stop beeping? So stop laughing. Okay, and then you did a great job. Here you are. Look at how great that was right there. Okay, try to relax and get below the line. Make the machine stop beeping. Y'all, she's laughing. Okay.
I'm trying, I swear.
She keeps laughing. Okay, so let's try it one more screen and then I'll take it off and we'll do something else. Okay, so one more time. And I'm keeping my instructions pretty simple. Get your line to the floor. Good.
When I did it, I started laughing because I was proud.
Yeah, I don't know if you guys can hear. She was proud of herself because she got it down below the line and she started laughing. Okay, let's do it one last time. So you can see that the visual biofeedback is what's helping her get that down. Not me talking, but her just figuring out what to do with her body to release the muscle activity. And go. Nice work. Okay, great. So she finally accomplished it.
I couldn't do that before. I couldn't do that earlier when we practiced.
Yeah, we were practicing this earlier and it was really hard for her.
You know,
So
the trick, you just go.
So what she was able to do is she used the biofeedback and was able to improve her function. So that we're switching back to me now. And what I want to do is switch to a different protocol because once you get, this is the most simple screen where we have the patient activity and we can tell them, we can either hook up ourselves as well as the patient and show them, model for them what the screen tracing should look like. And then once we establish the motor pattern that we want to establish, then we can change it into a screen or a protocol for them to quote unquote work out. So I have a protocol here that I created. I'm going to pause. So every time you change a screen like that and start collecting data, it gives you that countdown so the patient is mentally ready to start. The way I've structured this screen here is that I have 10 seconds of work, 5 seconds of rest. I've set the goal for the work, and the work in this is defined as I want the patient to do an effortful swallow. I want them to do an effortful swallow where the peak muscle activity goes above the line on the screen, above this dark blue line or the bold blue line. But then I want them to relax. So I have a 5-second relaxation period, and I've set that relaxation at 2.4 microvolts of activity. So in this, I'm asking the patient to get an onset within the 10-second time frame and an offset, and then 5 seconds of relaxation. So here, I'm not only working on peak amplitude or a surrogate of strength of swallow or high laryngeal elevation, but also I'm working on onset and offset. So this is a way that you can, in a defined time frame, get a person to stop with extraneous tongue movements, tongue pumping, or other things. So here's what this would look like. And this will be me. I don't think you can see my face now. So this is me. Doing an effortful swallow and a rest. So I'm going to pause it here so you can see here I purposefully, this was me talking in the first one, followed by an effortful swallow and a resting baseline. And then I did 2 effortful swallows. In the second one, I got nearly 100 microvolts. And what I did there is I pressed my tongue more to the roof of my mouth to engage the suprahyoid muscle group before initiating an effortful swallow. And that technique, the instruction of pressing the tongue to the roof of the mouth before initiating an effortful swallow, that was published, back in the 90s, I believe, maybe the early 2000s, by Huckabee and Steele, talking about the importance of the lingual focus in the effortful swallow. When we tell patients to swallow hard versus press your tongue to the roof of your mouth and swallow hard, we get different responses. So just as a little caveat, make sure that you're using an effortful swallow with a lingual focus. But anyway, that is how that works. So you can also use, I like this customized screen to be able to also do Mendelssohn's, and that's what this would look like. Okay, so there you see a sustained contraction or a sustained muscle activity, and then a drop off with relaxation. So again, you can increase or decrease the work time versus rest time based on your patient's needs. Let me show you quickly how to do that. So I would go into modify protocol. Yes, I want to. And I can change the timing. And again, I'm not sure, it's really quiet on my computer. I don't know if it's because we're on Zoom, but I had changed it so it tells the patient work, rest. You can just change it to a beeping sound, and that is changed in this screen where it says voice. You can have no cueing whatsoever from the computer, and you can do it yourself or let the patient self-cue, know when they have to work and rest, or you can have a voice that says work, rest, or you can just have little pinging sounds. I like the voice. I think that's pretty cool. So let's say you have a patient who's having a really hard time initiating a swallow, and you want to give them more time. So let's say 20 seconds of work, and let's still keep a 5-second rest period. But again, that could change also. So actually, let me go ahead and change it just so you guys can see how easy it is to change. Let's say 10 seconds of rest. Okay. And now you see the screen has changed. So now they have 10 seconds to work. So let's say instead of me talking, this is tongue pumping, a patient is working. But then they finally got their effortful swallow. That was an effortful swallow right there. Okay. So it just gives them more time to feel some success. And then if it takes them more time to relax, then here's a 10-second relaxation period. Anyway, you get sort of the gist. This can be changed in real time. So let's see. So if I want to change the goal, let's say the 10 microvolt goal for an effortful swallow is too low for this patient. Whoops, I started changing the rest. Okay, so I come over here. This is, you see where it says work and rest. So we want to go to the work screen and I can increase that. Let's say I want it to go to 25. Okay, I really want to work this patient. Or let's say that you want to change the resting goal. That can also be changed with the up and down green or red arrows here. When it sweeps to the next screen, now the patient has to swallow up to that new goal. So it can be changed in the moment without having to close out the screen and disrupt the session. You can keep the session going and be able to change these things. So let's see. I wanted to show you how to change. You can change the goals permanently again, or you can just do it on the fly. The other thing you can do is based on whether the patient's goal is to relax or to contract, you can have a tone that signals to them, it beeps when they hit their contraction goal, or like I did with Mallory, I had it this annoying beeping sound and I had it stop when she hit the relaxation point that I set for her, the goal I set for her. So you can change that in this menu by saying you want to tone the above tone. So when it goes, when the muscle activity goes above the goal that you've set, or a below tone, meaning the tone will sound when the patient goes below. So you can change that however you see fit. Okay, another thing you can do is change the display type. So for patients who are visually impaired, you can change the background and the foreground colors, which is super helpful. You can also change the graphic. So for instance, this one, my muscle activity is the blue bouncing oval, and I want it to go outside, and you'll see that the goal I set on the previous screen, 23 microvolts, there's going to be a tone sound if I swallow and make my blue oval go out of the circles. Let's see how that works. So now we're on the rest screen. So I need to keep my oval small and inside the dotted lines. It changed to work. So now I have my goal with the larger circle I need to swallow. So my circle goes outside the lines. And when it changes to rest, you'll see the small circle reappear. And then I need to keep my circle inside the rest boundaries. And unlike Mallory, I can do that. Okay, so we'll change the display type. What else is kind of fun? You can change this to a bar. So what I'm doing here is an effortful swallow followed by relaxation. And it's a more simple visual output. So maybe for patients who the scrolling line is too much, you can do a simple bar. Oh, there's the rest. I have to keep my bar below the rest line. And now the work screen has reemerged. And I'm doing some effortful swallows. Okay. So I can easily switch this to a dual screen at any time. And so because my channel A was set on the bar, I'm still on the bar. Mallory, I haven't changed hers. Hers is still the scrolling ribbon there.
That's resting. That's resting.
That's your resting. That's kind of sad. We need to work on that. So
that is just normal.
so this is just a way to show how that can bounce back and forth. So let's see what else I might have time to show you. So again, the goals I already showed you. It also has markers. So you'll see that, let me get out of here. Okay. As you're working with the patient, they might cough or sneeze or have an actual swallow. You can mark it by tapping on one of these mark buttons. So I just marked a sneeze there. Let's say during relaxation, they coughed. You can mark a cough there. So this is great because you can go back, and if a patient has a lot of muscle activity, you can identify, okay, you really did try swallowing here, and here's what happened. It just helps you be able to make sense of the muscle or the muscle activity tracing. Because again, in someone like Mallory or someone who has a lot of muscle tension, you want to be able to see that and discuss it with the patient. For research purposes, I've used those markers for other reasons. And those are also easily modifiable. So I can go into modifying the protocol and go into markers. And let's say I want to change marker number 4 to, let's say, tongue pumping. Oops. And then when I mark it, it's going to, let's say, TP on channel A. Okay. Modify protocol. I'm finished. I actually like that one, so I'm going to save it to my protocol. And so now you see here's TP. I can mark tongue pumping, tongue pumping, tongue pumping. And there's a swallow. So again, it's a way to help make sense when you're going back and looking at the data. And we're out of time. Oh, shoot. We're out of time. So I won't get to show you some of the other features, but you also have the ability to, here, let me pause that. Whoops. Exit. Yes. Okay. Whoops, let me get out of there. Yes, I'm sure. There we go. So you have the ability to pull up one session, like their first session versus their 12th session, and compare the data one to the other. You have the ability to print out a report. And so I'm sorry, I've used up all my time, but that's what this is for, is demo and discuss. And we got some good demo in. There are a lot of other things you can do, but I just hope that you're able to walk away from this knowing how to do a basic setup for swallowing rehabilitation, set up screens and see how you can help patients increase muscle activity, decrease extraneous muscle activity, and improve muscle patterns like onset and offset of swallow using this external biofeedback. Because telling your patient that was good, no, it wasn't, is ridiculous and really is not going to help them with motor learning. So I hope you've enjoyed this. And if there are any questions, maybe y'all can get those to me later. Oh, I can't hear you.
Sorry.
Oh, there you are.
There was one question. Is using any SEMG, like borrowing from like OT, as effective as using something like, I guess, Prometheus that you just demoed?
I mean, I would, in general, the basic answer is yes. Of course, I would look at the manufacturer, make sure they have good reliability, make sure that the equipment is doesn't have any frayed cords, make sure it's in good operation. Basically, it's sort of like, is any one mirror better than the other? As long as it's reliable. then sure. And quite frankly, you're looking at the patient's activity relative to themselves. So, yeah, let's say if you use the Prometheus one day, one of your colleagues used it, and then you're like, oh, shoot, I really want to do biofeedback. And you grab the OTs and you start using that. Yeah, I mean, again, it's just if the readings are off on the OT one, you're just looking at relative patterns. So the exact microvolt might not make all that much of a difference. We're looking at motor patterns. So it should be fine. Yeah.
Well, thank you so much, Lori.
Thanks. Thanks, everyone.
Lori.
Hi. See, my mom's a professional. Yeah.
I did not pay her to say that.
No, but I'm saying it because she's awesome.
Oh my gosh.
Hire this lady. She does great work.
Oh my gosh. Working with kids and animals, you just never know what's going to happen.
I'm not an animal.
Oh, they said you're awesome too.
Oh,
okay.
great.
Thanks, everyone.
Bye. Thank you. Okay. I'm going to introduce our final presenter. Last but certainly not least, Carl Larson.
Hi.
Hello.
Hello. Thank you for having me. I will round out the day with peds and cleft palate. So I am going to share my screen. And this is let's see here, make sure I've got the sound here. And let's go from the start. Okay. Casey, you can see that, right?
Yep.
Yes. Okay. So I'm going to talk about feeding challenges in infants with cleft palate. I'm Cara Larson. These are my disclosures. I work at Boston Children's Hospital and I teach cleft palate and craniofacial at Boston University. So we're going to do an overview of the bottom systems that are available to you. I'm going to do some live demonstrations on how to put the bottles together. And then I have both video fluoroscopic as well as video swallow studies. This is one of my patients here with a bilateral incomplete cleft lip and palate on the left and complete cleft lip and palate on the right, who you will see a little bit later in the presentation. These are our objectives. We'll go over the cleft palate bottles, the three most common ones that we use, and talk about feeding modifications, and then talk about clinical signs of swallowing dysfunction. This is part of my team at Boston Children's. We dressed up as moderately thick, honey thick liquids for Halloween. That's kind of nerdy, but we always do some feeding theme. This is our aerodigestive team. And I oversee 22 speech pathologists in our feeding and swallowing program. And when I'm not working, I enjoy spending time with my husband and my 2 adult children skiing. Okay, all my sources are listed at the end. All of the updated references are there as well. Anyway, okay, let's get started. So we are going to talk about 3 specialized bottle systems in working with children with cleft lip and palate and or craniofacial anomalies. And we have 2 patient populations. We have the infants that will have cleft lip and palate, and they are non-syndromic, so they don't have any other issues. And then we have our syndromic cleft lip and palate, and those are the patients that may have a genetic syndrome and have more extensive craniofacial anomalies and will be a little bit more difficult to feed by mouth because of their comorbidities. But the main 4, I will say, bottles on the market are the Medela Special Needs Feeder, that used to be called the Haberman, the Dr. Brown, I've got it here, specialty bottle. I've got the Haberman here. Then we'll go through the Dr. Brown specialty feeding system. And then we'll talk about squeezable or compression type bottle systems. Okay, so the Medela Special Needs Feeder, which is here on the next page, you'll see. This used to be called the Haberman feeder. It has a one-way valve system, and that prevents the milk from flowing back into the bottle. The nipple at the top here has a slit valve with 3 flow rates, and you can see those on the bottle, a very short line, a medium, and a long line. And that allows the caregiver to control the milk flow. And whatever flow rate that you want the infant to be on, you line up the line on the nipple with the baby's nose. And then you can move or rotate the nipple clockwise or counterclockwise to increase or decrease the flow rate. As well as when I show you how to put this together, this is the parent can provide gentle compression. So this can assist with fluid extraction. And also this is does accommodate infant-driven feeding, which is what we're going for because of the compression. And it's really important, and we'll talk a little bit more about this, about educating and training families on how to properly use these bottles. And so if we have an infant with a prenatal diagnosis, we will have the family work on feeding the baby doll. I've got my little baby doll here. And we will have the family practice with the bottle system on a baby doll prior to delivery, and it really improves parental confidence in feeding their infant. So when you think about the Medela special needs feeder, the feeding velocity is about 3 to 5 mLs per minute. When compared to the other bottle systems, and my research articles are at the end here, there was no difference in weight gain, whether you use the Medela or the Dr. Brown or a compression style bottle. But it does require, like I said, that squeezing here, or what we call assisted delivery, despite it being an infant-driven design. If a child especially has a wide cleft, the family or the feeder is definitely going to have to provide that assisted delivery in coordination with the infant's suck, swallow, breathe pattern. And that's why it takes a little bit of time for families to feel comfortable and then get in rhythm with their baby's suck, swallow, breathe coordination. In a minute or two, when we put these together, the only tricky thing about the Haberman feeder or a Medela feeder is that it does have a disc here. And this is the one-way valve. And it has these little bumps, as you can see. And so I always tell parents, speed bumps up so that they put the disc in the correct way. Because if you put the disc in with the other side up, it's not going to work correctly. And so we'll go over that in a minute. But it does take a little bit of practice to get the parts together correctly and know how to squeeze and tip it over so the fluid gets into the reservoir, which is that top part. So the Dr. Brown specialty feeding system, which I feel is the go-to, especially in infants with non-syndromic cleft lip and palate. So number one, it's readily available. Number two, it looks like other bottles that babies are drinking from, because it's just like the Dr. Brown bottle, but it's going to have this one-way valve at the base. This is the one-way valve. In a minute, we're going to put that bottle together. But this is the difference between a regular Dr. Brown bottle and then the Dr. Brown specialty feeding system. It is available in different nipple flow rates. As you may be aware, Dr. Brown goes from ultra preemie, preemie, transition, level 1, level 2, level 3, level 4, and a Y cut. And again, the goal is really infant-driven feeding, and the Dr. Brown bottle promotes and supports that infant-driven feeding. Interestingly, similar to the Medela special needs, the feeding velocity is about, again, 3 to 5 mLs per minute if you're using about a level 1, and probably closer to 5 mLs with the level 2 nipple. And again, there was no statistical significance in differences when you looked at the Medela and the Dr. Brown feeding system in terms of velocity and calorie velocity and inner complications from the bottle. So here's the Dr. Brown bottle, which we'll put together in a minute. Again, it does have the reservoir, that green valve that you should use. So you're using the whole bottle properly. And that is supposed to provide venting to help reduce air swallowing and help improve comfort during feeding. And then the third class of bottles for babies with cleft lip and palate would be a compression or squeezable bottle. Here I have, this is pretty old school, but this is the Mead Johnson cleft palate bottle. And the bottle itself is very pliable. You can squeeze it very easily. And again, this is what we call assisted delivery, where you as the feeder are assisting with the extraction. And that makes sense because if you think of an infant with cleft lip and palate and you think about their sucking, the issue that they have is with negative pressure. So in order to have normal sucking, right, we have negative and positive pressure. With the positive pressure, that's the expression phase of sucking. But with the negative pressure, the suction is lost because they have a hole in the palate. So they don't have a closed system. So it's the suction that they have difficult with. And so the compression helps sort of override the deficit of that suction. And because the palate is typically not repaired till about 1 year of age, depending on the center, it could be anywhere between 10 to 12 months of age. So with a cleft lip, the lip is repaired at 3 months of age. And then after that, the palate was repaired closer to a year. So we have to remember that these infants are feeding and using these bottle systems for the first year of life. And it's really important that they're feeding efficiently. If they're not gaining adequate weight, then the surgery may be delayed if they're not in adequate weight to go under anesthesia. So it's super important if you're a speech language pathologist and you're in a NICU, in the hospital, in a private practice with infants, or in early intervention, which is a really important setting where we really want you to be equipped and know how to feed babies with cleft palate. So just going back to this compression bottle, this is the Mead Johnson. The other one available on the market is the pigeon nipple, which I'll talk about in a minute. So this is a little bit of what we would say passive delivery because the feeder is squeezing. And again, that education with the family that they're squeezing when the infant is sucking and they're not squeezing when the baby is swallowing or breathing. Many find it easier to use than some of the rigid bottles. And there was one study that showed with the squeeze or compression style bottle that there was improved weight gain at 12 months, as well as improved head circumference. So when we look for a baby to be gaining weight and growing, first we look at the weight, and then we look at the height, and then we look at their head circumference. And if a baby is having growth faltering, the last thing that would stop would be the head circumference. If the infant's head is not growing, it's very concerning, and the pediatrician and medical team should be taking a look at that. Some of the bottles are a bit expensive, and then some are more readily available. So we'll talk a little bit about pricing. So again, this is the Mead Johnson squeezable compression bottle. This does not have a valve like the other two. It does, though, if you can tell a little bit, have a cross cut. And so if you needed to thicken liquids because the infant had aspiration, possibly if they had a certain genetic syndrome, if they have neurological deficits or low muscle tone or pharyngeal hypotonia that may be causing aspiration, and you have to do thickened feedings, this is a good choice, as well as the pigeon nipple system. So the pigeon nipple system is also pretty readily available. That has an interesting nipple shape where the top is thicker and the bottom is thinner, and it also has a Y cut, and it just takes very little expression for the baby to extract the fluid, and it also has a little disc that looks similar to the Dr. Brown bottle. Okay, I'm going to stop sharing, and we are going to put together the Medela special needs feeder. So I was looking on Amazon, and you really get a wide range of pricing, anywhere from like low 20 or 28 or $29. So it's still still on the expensive side. And I think that's why I feel like the Dr. Brown system has become more popular, because it's easier to obtain and the price point is much better. So this is just a Medela feeder. So if you work in the NICU, you probably use these bottles to feed babies. So I'm going to pour water into the feeder, try to put 30 cc's or 1 ounce. And the next thing I'll do is take the little disc, the little one-way valve, speed bumps up, place that on top. I will then take the nipple and the collar, place it on and twist it. Now you can maybe see those 3 flow rate, slow, medium, and fast. The next part here is key. So you pinch the reservoir and flip the bottle. And so the reservoir is now filled with liquid. What is in the reservoir will not go back down into the bottle. So that's why we call this a one-way valve. Okay, so look at my doll here. I'm going to start on the slowest flow. So I'm going to line up that line with the baby's nose. And then you're probably going to see this dribble out, but I'm going to squeeze in rhythm with the baby. So suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. And then if I thought, well, the baby's really alert, they're doing really well, I'm going to turn the nipple clockwise and then go to the next flow rate. And what it does, and people are always asked, like, how does it go from slower to faster if you have the same nipple? So it has to do with the vertical slit at the end. And so the orientation of that slit when you squeeze will increase the bolus size. Okay, so that is the Medela special needs feeder. If you have to thicken liquids, this can be a little bit tricky because of that one-way valve. So I have found that I've only been able to do slightly thick liquid in this bottle. And if an infant needs, say, mild or moderately thick, then you probably need to do a different bottle choice. Okay, next we have the Dr. Brown special needs feeder. And so this is the key component. This is the one-way valve. This side is indented, and then the other side has the disc. So then I'll take the nipple, I will put the disc in there so that the little sharp point or the underside, here we go, the underside of the disc is pointing down into the bottle. All right, and now I will pour a little bit of water into the bottle. Thread this on, and again, a bit of a similar technique. Squeeze the nipple, and then you'll see the liquid entering in there. And again, like I said, this is going to just, it's a one-way valve, so it's going to keep the nipple full. And again, it promotes that compression style of sucking. But what I don't have to do is I'm not going to squeeze the nipple. It's a one-way valve, and it would be really easy for the baby to extract the fluid. Okay, so that's the Dr. Brown special needs feeder. The last one I had just showed also is this Mead Johnson. I find this used to be used more in the US. Now I find it is still used in Canada and Europe. If you look for this online, I actually looked this afternoon. It was $5.99 out of a website in Canada. And then it's in Europe, I know like in Greece and Italy and other countries, they do tend to still use this bottle, where I feel like we don't use this as much. I did once, we had a patient where we used the bottle portion because it's very pliable and that's really helpful. And I did have one patient where we did put a Dr. Brown nipple on this bottle. And also there are some nipples that will thread onto this bottle because you may want a shorter nipple. Another component of this bottle is that if a child has a cleft lip in an anterior cleft, say in the alveolar ridge, because the nipple is long, you can use the nipple to occlude where the cleft is. So you can occlude the cleft lip and then a cleft of the alveolar ridge in that bony, hard part of the palate. If that is not the case, also with the Haberman, placement of the nipple, if it's a child with a bilateral cleft lip and palate, you have to look under in their mouth to see where they have more, where the palatal shelf is more substantial. With the Haberman feeder, again, you can occlude the cleft lip, or you could try to place it more on the opposite side or the side if it's a unilateral cleft lip and palate that is intact. Okay, so those are our bottle demonstrations. Let me go back to the PowerPoint. Okay, this is an infant here that you see a left incomplete cleft lip and palate, incomplete. because the cleft does not go through the floor of the nasal cavity. If the cleft goes through the floor of the nasal cavity, you have more deformity of the nose, but here you can still see the nostril on the left side. So it's a left incomplete unilateral cleft lip and palate. And what's great is the before and after. And I think when families first see their infant diagnosed with cleft palate, it can be a bit shocking. But when they can see before and after pictures of other patients and other infants that have undergone repair with the surgical technique these days, these babies end up looking amazing. Okay. All right. So clinical considerations when we think about the bottles that we just, I know there's some questions here too. Oh, someone's asking if the pigeon cleft bottle, it is not. The pigeon cleft bottle is not off the market. In fact, I did see it on Amazon this afternoon. I think the Mead Johnson is difficult to find, but it is available, like I said, in Canada. But the pigeon cleft palate bottle was listed on Amazon this afternoon. Okay, so let's just go back here. Let me just get rid of the chat on my screen. Sorry about that. Okay, so in addition, let me just make sure I'm on the right side. Okay, so here we go. So no bottle is going to normalize feeding in infants with cleft, right? So they have an anatomical difference. And again, that disruption is in that negative pressure or the suction. And so they do typically have a prolonged feeding duration, which is between 29 to 32 minutes, and that the milk transfer and the rate of transfer is reduced, which isn't surprising because it is a bit more effortful for them. The squeezable bottles are more reliable and require less intervention. And then that mean weight, the Z-scores, remain below 50th percentile, regardless of bottle type. And again, I can't underscore enough how important weight gain is in the first year of life for infants to prepare for surgery. So our dietitians will look at the Z-score, which shows how many standard deviations in their weight it is from the average, with 0 being the average. So if they're 1 or 2 standard deviations below the mean as a Z-score, we're really concerned about their rate of weight gain. And then our dietitians or gastroenterologists would assist us with increasing the caloric density of the formula, or we're going to talk a minute about what the role of thickening the feedings would be. But mainly what the study showed was that educating the mom or the primary feeder was more consistent in benefit than the bottle selection alone. And so you'll have a copy of these slides, and this is just a chart from the articles that will just compare the 3 types of bottles in terms of weight gain, ease of use, cost, and availability. So that's a nice chart to refer to. Okay, so some people will ask, if none of those bottles work, what other options do we have? Or if an infant is using one of those bottles, are there any other supplemental or in addition to the bottles, what can we use? And syringe feeding is not something that we will do at our clinic, but many NICUs or hospitals may do that. We really caution against syringe feeding unless it's just for a very short period of time. If you have a 10 ml syringe, I might push it 1 ml at a time. Someone else might push it 2 to 3 mLs at a time. And the concern would be, right, with the baby, with syringe feeding, even if like oftentimes nursing will say like, oh, I'm just squeezing it into their cheek, but it is a thin liquid. So it's probably going to dribble out. They may cough and choke and have clinical concern for aspiration if the syringe feeding is going too quickly. But certainly syringe feeding can be fast because it's very passive and you can squeeze the liquid. All right, cup feeding is something that we may work on. I wouldn't in an infant ever rely on cup feeding as a primary method of feeding, but as the baby got older and they're preparing for cleft surgery, this is the pink nosy cup. which you may be able to do some supplemental feeding. If you were going to do any type of cup feeding, I would recommend that you thicken the feeding, otherwise it will dribble out. So if it was formula, you could add a little bit of rice or oatmeal cereal if that was cleared by the dietitian. And if it's breast milk, I would recommend the use of gel mix, as that will adequately and reliably thicken the breast milk. So I always look to cup feeding as a supplement. So if I had an infant that had cleft lip and palate, but they also had a genetic syndrome and they had aspiration, but they were cleared for thickened liquids, then if we couldn't do bottle feeding, we could try a little bit of thickened liquid in the nosy cup. This is a Munchkin cup. This is a lidded cup that has a little bit of a hole. I like this for older babies, say like 9 months and older. It's easy for them to hold. You can do thickened liquids, but it won't come pouring out. The lidded cup has a slit that will kind of regulate the flow. In terms of NG tube and G tube placement, if it's a baby with non-syndromic cleft lip and palate, we really wouldn't expect them to aspirate if they have no other comorbidities. If they are, then I would question the feeding technique that may be causing the aspiration. You know, sometimes parents really want their child to eat. They might cut a hole in the nipple and make it much faster than the baby can handle. We think about supplemental NG tube feedings leading up to cleft palate surgery to help with weight gain if the infant can't take enough by mouth. If an infant has a wide bilateral cleft lip and palate, it's really hard to have them maintain full oral feeding. They may need some supplementation. Now, if you have a bilateral cleft lip and palate, you're not going to be able to keep an NG tube in place because of the defects in the floor of the nasal cavity. So perhaps the infant would have an orogastric tube that would be dropped for each feeding or remain in place, which that is a tube that goes in the mouth and then down the pharynx and into the esophagus. We think about G-tube placement in infants that have a genetic syndrome, especially Pierre-Robin sequence, which is a triad of micrognathia, which is a small jaw, and a U-shaped cleft of the soft palate, as well as glossoptosis. And glossoptosis is when the base of the tongue falls into the airway. And so with Robin sequence, infants often have a very at-risk airway, and in severe cases, they may need to have supplemental G-tube feedings until they await surgery for lengthening the jaw, and then again, getting ready for the palate repair. Some cleft palate centers will use a palatal obturator, which is sort of like a retainer that's molded to the infant's mouth to occlude where the cleft is, or a palatal plate, some people will call it. That works better if it's more of an anterior cleft of the bony part of the palate. But the problem also with that is that the infant's mouth grows so quickly that the palatal plate doesn't often remain securely in place with growth of the oral cavity. Okay, so now I'd like to just show a couple of cases, and I definitely will have time at the end to answer some questions or get your thoughts on things. So this, interestingly, is one of my patients that actually does have a nasogastric tube here. So you can see he has an NG tube in his left nostril. He has aspiration of thin, slightly, and mildly thick liquids because he also has a laryngeal cleft. So he has a cleft in his larynx that's like a little tiny hole. And in some babies that have a cleft palate, we call that a midline defect. And a laryngeal cleft is also what we call a midline defect. So if you have a baby with a cleft palate and they're aspirating and you're thinking, why are they aspirating? They really shouldn't be. We will send them to ear, nose, throat and have the otolaryngologist or ENT do a scope. A laryngeal cleft can only be diagnosed under anesthesia, under a direct laryngoscopy. But in the case of this patient, so he has a cleft of the soft palate as well as a laryngeal cleft. So he's eating puree here, and he's getting his liquids through his NG tube. And so I just think it's so interesting how he has adapted to spoon feeding. So I'll play this for you.
buddy, you want some?
Okay. If anyone, I think I can see the chat here. I don't know if anybody has any thoughts on what's happening here. It's so interesting how he compensates. So he still has a cleft of the soft palate, but we will proceed with spoon feeding because he has good head control. It's developmentally appropriate, but he does something really interesting, right? He kind of helps remove the puree into his mouth and then sucks on his fingers to compensate for his loss of suction there. And so he did this all the time. And it helps with his oral transit. It helps propel the bolus from the front to the back of the mouth. So when he was getting ready for surgery for his palate, after surgery, you can't have a pacifier or you can't suck on your fingers. And mom was really worried. Like, how's he going to do feeding because he's so used to using his fingers to compensate from that loss of suction and to just become a pattern for him. And then I have another video of him so you can see how he ended up doing. But, young babies are really interesting how they can compensate for any deficits that they have. So this was interesting. So he got his liquids by his NG tube, but we kept him moving developmentally with spoon feeding. Now, one thing we haven't, but we will talk about is, nasal regurgitation. So in the first year of life, the palate is unrepaired. And so nasal reflux or regurgitation is going to happen, right? Because there's a hole in the palate, there's a communication between the oral and nasal cavity. And so sometimes, some of the puree might go up into the palate and it might dribble down the nose a bit. But that wouldn't be reason enough not to try spoon feeding because developmentally it's really important to keep these patients on track. Okay, so one thing I learned during and after COVID is that telemedicine actually ended up being really helpful to check in on some of our patients with feeding. And I think prior to that, I wouldn't have said that I could evaluate a child's feeding via telemedicine or virtual visits, but it's actually worked out quite well. So here is Ricky at this point, and now he's coming really close to getting the palate repaired. And so we are working on cup feeding so that after his surgery, he can't have the nipple in his mouth because of the surgical repair. If we gave him the bottle back and he had the nipple, it would put pressure on the site of the palate repair where the stitches are. And so we practice with cup drinking to get ready for surgery. And so here he has a little nosy cup with handles with a thickened liquid, and we did a virtual visit to check in and see how he was progressing with the cup.
I think the fact that it's silicone is nice for him because he likes to chew things so much. I know, you want to hold it? You want to hold it, be a big boy?
Wow, Ricky. And then the thickness, he can contain it in his mouth. So I actually was really impressed because the prior visit, we tried the cup, and again, it just takes a while and it's kind of persistence and exposure in practice, but he was doing really well. He was holding it with both of his hands. He was tilting it up. We obviously had it thickened because of his history of aspiration, but it also is helping with oral containment, so it isn't dribbling out. The other issue for him was that the surgeon said that he would not be able to have the NG tube post-operatively. Again, not wanting to put an NG tube right in a fresh surgical site. So it wasn't, maybe we had a little, or mom definitely felt some pressure, like we've got to make sure that he's going to be able to hydrate himself. He can do his purees, and we can do a high calorie mixture of formula and cereal, but we also wanted to make sure he was going to be able to drink. So he was doing really well with the thickened liquids via the cup. I will also tell you, he did get his palate repaired. He couldn't have the laryngeal cleft and the palate repair at the same time, so they were staged repairs, but he was able to continue his full oral feeding. Then he had his laryngeal cleft repaired. And then after that, we kind of weaned him off of thick and liquids and did a repeat swallow study. And he was able, eventually got the NG tube out and was on thin liquids as well. So he was off the NG tube right at surgery, but then he went from thick down to thin liquids and has done really well. Okay, this is a more complex patient. This is a patient that is undergoing a workup for a genetic syndrome. So at the time, had what we call multiple congenital anomalies, but no unifying diagnosis. This baby actually had a G tube put in prior to leaving the NICU because of aspiration, because of low muscle tone and real multiple medical issues. He was also born a bit premature, has a cleft lip and palate, and is on supplemental oxygen when he's sleeping. Mom really wanted to do just really small trials of oral feeds. So we were doing like 10 to 15 mLs from the Medela special needs feeder. And again, this was cleared by our aerodigestive team. And then we, as a group, did a virtual visit to check in on how he was doing because Mom had sent in a message saying she wasn't sure how well the bottle feedings were going because he was coughing. So pay particular attention to any sort of subtle signs that you might recognize of aspiration or what kind of a sucking pattern he has here.
There you go.
So that was what Mom was worried about, and he actually did it during the visit, which was helpful for us to see. He was getting express breast milk. It was really important for Mom to have him take a little bit of breast milk. What you could see happening is that he's becoming really red. He sort of had a prolonged like suck, 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 suck. Didn't, kind of forgot to have to coordinate his breathing and swallowing, and had a bit of a cough. And so we were worried about this. Our pulmonologist was really worried about this, so we actually did pause on his oral feeding for a little bit of time. And also his cleft lip surgery was also delayed that despite having the G tube in place, he still wasn't having adequate weight gain. He was having intolerance of his feedings. He was having spitting up, like reflux symptoms and vomiting. So we decided we would play it safe. One thing you would say would like, oh, could we do pacifier dips with the breast milk? I mean, we could try. Non-nutritive sucking again is still difficult because of that unrepaired cleft. But even with a little swab, putting just a little bit of breast milk like on his lips. So this is a good example of kind of doing some therapeutic feedings in a child who has, comorbidities, and you can tell he has like a very flat nasal bridge, frontal bossing, his eyes are wide spaced. And so he was being worked up for genetic syndrome and just had a lot of comorbidity. So we're really being extra careful with him.
There you go.
Okay, this is another patient in the cleft lip and palate clinic. This is actually the little baby that was at the beginning of the slideshow here. Mom came into clinic and was worried that the baby was falling asleep during feedings and that she hadn't been able to get in the feedings and they were taking a long time. We also have a Spanish interpreter here. Mom's primary language was Spanish, so we had an in-person interpreter. So let's play this video and then we can talk about it.
Watch her in case we have to look it back at.
Solamente es para observarla para que quede en su archivo médico.
How long have you been using this Dr. Brown bottle?
¿Qué tiempo está usando la botella de Dr.
Desde que
Brown?
nació.
Since she was born.
Okay.
Está bien.
And how long have you been adding in the rice cereal?
¿Ya por qué tiempo le viene agregando el cereal de arroz?
Desde el lunes.
Este pasado. Since this last Monday.
Okay. So looking at this infant feeding, some things you might be thinking about are like she is really sleepy during the feeding. She is using the Dr. Brown bottle with the one-way valve. Mom had, as you heard, started thickening about a week ago, so she's adding rice cereal in with the formula. So one of my thoughts was, is the thickened liquid getting through? Again, it's hard to thicken with the valve in there. Even if you advance the flow rate of the nipple, you still have the valve. So the concern was that like her milk transfer was not good. You can see mom's like just trying to do some tactile support. And we were worried about weight gain, but the dietitian decided to add rice instead of increasing the caloric density of the formula. I talked to mom about the pigeon bottle or changing to a squeezable bottle, but mom really said that she had been practicing, felt most comfortable with this bottle, did not want to switch, which that's fine. I definitely don't want to make a major change like that. So what we ended up doing was taking the cereal out and just fortifying the formula because it wasn't as thick, but she still would have increased caloric density to help with her weight gain. She didn't have signs of aspiration, so I didn't feel like, oh, she needs thickened liquids because she's sounding wet or congested. Like all babies with an unrepaired cleft palate are going to have nasal congestion when they're feeding because they're having that nasal reflux. We also kept a close eye on her and made sure that she had weekly weight checks and that mom wasn't feeding her really for longer than 30 minutes so that she's not burning off more calories. Okay. All right. So speaking of nasal reflux, I definitely wanted to be able to show you a video fluoroscopic swallow study or modified barium swallow study of an infant with a cleft. Now, as I said, typically with cleft lip and palate, we don't expect aspiration, but if we have those comorbidities of other craniofacial anomalies or prematurity and cleft palate, then we become a little bit more worried about coordination of swallowing. Okay, so here is a video fluoroscopic swallow study, and I will play it once and then I can stop and identify the structures, but see if you can detect the barium going up into the nasal cavity. I'm going to try to pause this as well. Okay, so let me see if I can. Okay, so what we see here, this is the soft palate, right? But there's a cleft, so it's not moving well. This here is the posterior pharyngeal wall. I'll just put a P there. And then the black liquid is the barium, but you see that it comes in. This is the base of the tongue. We want the liquid to go this way into the esophagus. We don't want anything to come into the front, into the laryngeal vestibule. But what you'll see here is that there's an unrepaired cleft. So the soft palate is kind of not having any movement or excursion. And as a result, the liquid goes the path of least resistance, which is typically in this case up in the nasal cavity. And this is thin liquid from a Dr. Brown ultra preemie nipple with the blue valve in place. If you didn't have the valve in place, the baby would likely have really poor extraction. And so the concern with the nasal regurgitation, if it's significant over time, then the nose becomes blocked up. And at this age, babies are obligate nasal breathers, so they're supposed to breathe through their nose. But if they keep having nasal regurgitation and the nose gets stuffed up, then their whole suck, swallow, breathe is off. Oops, I don't want to do that. Oh, I think I just put somehow I just, oh my goodness, I put the closed caption on. But in the interest of time, let me erase this. Okay, I will play this again. Oh my goodness, now this is not behaving at all. I'm going to stop sharing my screen and then share it again. Here we go. Let me just look at the time. Okay. Let's not do this. All right. All right, now we're back where we need to be. Sorry about that. Close that. Why is this not? Okay, here we go. Shoot, I don't know why that. Okay, here we go. All right, we'll go into the next video. So the prior video was the Dr. Brown Ultra Preemie Nipple. This is now the Dr. Brown Preemie Nipple to help advancing flow rate. Again, this is the Dr. Brown bottle with the supplemental feeding system. But again, as you can see, again, because of the unrepaired cleft, you still have the black liquid, which is the barium, going up into the nasal cavity. So you do want to try to advance flow rate if the extraction isn't great. So with the Dr. Brown Ultra Preemie Nipple, there was pretty good extraction and that looks safe. We didn't see any aspiration. So then you'd say, well, let's see how the Preemie Nipple looks and they may be more efficient with feeding. In this next video, we stuck with the Dr. Brown Preemie Nipple, but we increased the thickness of the liquid. So this is now a slightly thick liquid. And sometimes therapeutic intervention for nasal regurgitation is thickening liquids. And so that again would be using a ratio of a little bit of rice cereal to formula or a commercial thickener such as gel mix if the infant meets the specifications for express breast milk. And so with here, we're looking with the slightly thick liquid, is there a reduction in the amount of nasal regurgitation? So what I'm noticing here is that this baby has several sucks per burst. So again, we still have the preemie nipple, but now we've thickened the liquid. We do still have the blue valve in there. And then something interesting starts to happen. You notice that the liquid is just kind of pooling in the pharynx, and then a little of it starts to dip forward. And that's concerning. You can see some of it go under the epiglottis. So then that's laryngeal penetration and then puts the baby at risk for aspiration. And the swallow initiation is delayed. So at this point, we're thinking, no, thickening liquids is not going to be a good option here. We should go back to just the thin liquid, keep the valve in place, and stick with the Dr. Brown nipple. All right, and then on the next video, oh my goodness, I never have this problem. I don't know why it's doing that. I'm going to stop sharing it again. I don't know why. Okay, this is the next video clip. Now we're looking at spoon feeding. So this is a moderately thick liquid, and a lot of baby food, say stage 1 baby food, if you do the IDD, the IDSI testing with the syringe, a lot of runny baby food is actually moderately thick. So what we wanted to test here was, could we start some spoon feeding that might result in reduced nasal regurgitation? It would keep this patient moving along developmentally. And because with the slightly thick liquids, we saw some of that airway invasion and that penetration, we thought, all right, let's look at moderately thick to make sure that doing some spoon feeding would be safe. All right, I just wanted to play that one more time. Okay, this baby has earrings. That's what you see there on the screen. And again, they looked okay for the moderately thick liquid. Okay, so in thinking about feeding infants with cleft lip and palate in your clinical practice, the Medela or Dr. Brown specialty bottles are really appropriate first-line choices because the outcomes are really equivalent. Squeezable bottles like the Pigeon or the Mead Johnson have ease of use. And these studies said they were lower cost. And I think that's a little bit debatable about what you're ordering and from where. And that, again, like in infant and pediatric feeding and swallowing, individual selection is important. It's hard for us to have a lot of protocols because it always isn't one size fits all. And the most important thing, as soon as the cleft is identified, is caregiver education, having families practice with the baby doll, having them practice put the bottles together, monitoring their growth closely, because their mean weight in babies with cleft in the data shows that they often do fall below the 50th percentile. And so that's why it's so important for speech pathologists to have an understanding of how best to feed the babies. And like I said, if you are in birth to 3 programs, the whole first year of life, if you're working with the family on feeding, is making sure they're feeding safely and efficiently and gaining weight. And again, no standardized protocol exists. And that practices do actually vary based on the cleft palate team. And some surgeons have preferences and some clinics have preferences. So I will stop sharing. I apologize for my AV issues there, but I'm happy to answer questions if anybody has them for a few minutes.
Yes, please add your questions in the chat. We have about 6 or 7 minutes left. I have a question for you actually about that
Yes.
little guy who is using his fingers. Is that something you typically see like in that population, or was that just his specific strategy?
Yeah, it's so interesting. We never see that. And it was so sort of unique. And I just thought it was so also innate, right? Because it's not taught. Initially, we, tried the spoon feeding just for another way to move him on developmentally. And he didn't do it initially. And then over time, mom was like, oh, he does this funny thing now. Never I take the spoon out, or he now is using his hand to sort of swipe the puree and then putting it in his mouth, sucking on his hands, where he kind of like then has a closed system because he's sucking on his hands and it propels the puree back.
Yeah.
And I mean, he did it for months and months. And as I had stated, she was so nervous for the surgery and thought, he would have the little Velcro sleeves on so he can't bend his fingers and get it in his mouth. So mom was super worried about this and also thought maybe like behaviorally he would be so frustrated. And it's so interesting. And we were so nervous. And right afterwards, like a week later, she was like, it's the craziest thing. She said he doesn't, he had started spoon feeding again postoperatively and he didn't do it.
Yeah. Was he also using it to self-soothe outside of meals, or it was
Always
just
with
yeah.
meals.
Okay.
Always with meals.
Yeah, that's so interesting.
It is. Someone said resourceful, and that's exactly what I thought. I thought, don't underestimate like our little under a year old patients because they will figure out a way to do it. He was like a really good eater.
Yeah. Let's see. I'm gonna scroll back to make sure we didn't miss
I
anything.
know everybody might be tired at this point in the day. I do have my email at the end of the slides. If anybody has any questions or things that they think of, it, happy to, if you reach out to me that way as well. Oh, I think someone had something. Do you think?
That one. That's the one.
It's a really good question. And I'm thinking about like how we would teach that, right? If you gave like a spoonful of puree and then did some guided movement.
I wonder with the mirror if that would be really helpful if you just modeled it with a mirror, that motor learning pattern.
Right. I don't know. It's certainly something to think about. It's certainly something to think about whether that would, I certainly would think about it in another child. Someone asked about breastfeeding. That's a really good question. Breastfeeding in an infant with a bilateral cleft lip and palate, you can't do. There's the cleft and the latch and everything. Cleft lip alone, just a cleft lip, which is also pretty rare to have just a cleft lip. We can do positioning modifications for breastfeeding. Cleft lip and palate unilateral on one side is still going to be tricky. I don't ever like to say don't breastfeed. It wouldn't be the primary means of nutrition, but we could at least have them go to a pump breast. I know some people use that supplemental nursing system where you have the breast milk and the tubing and you tape it to the breast. We've tried to use that a lot. I find it's really cumbersome for moms. So it depends on the type of the cleft, the extent of the clefting with the breastfeeding. And then Casey, I think there was a question about the aspiration.
Yeah, how often do you do objective testing when a child has aspirated to know when to advance them?
Yeah, that's an excellent question. So if we have a child on thickened liquids, if out of our program at Boston Children's, we had developed a systematic weaning protocol, and I bring that up only to say, prior to doing a repeat swallow study, if a child and even a baby's on mildly thick liquid, I would try to thin that out a little bit prior to doing a repeat swallow study. So if we have an infant, say we saw them during their NICU stay, they're like 38 to 40 weeks. We did a swallow study. They are discharged home on thickened feedings. If that was their first study inpatient, we would see them back in about 8 to 12 weeks to do a second. If there is improvement, in flow rate or reducing the thickness, then we'll make those changes. But after that, we are going to wait at least 4 to 6 months to do another study. So a study in the hospital as an infant, one at about 8 to 12 weeks. And depending what that shows, then we really need to bump it out. And in our systematic weaning paper that maybe Casey, I can also add to the resources so you have it on hand. We have some patients and pretty good data that if you systematically wean slowly, so that just super quickly means like if they're, I'm going to do it with a Simply Thick because it's easy to say, even though we don't do that till over a year at our hospital. If it's 1 packet to 4 ounces, so 1 pink packet of Simply Thick to 4 ounces. If you did a systematic weaning, you would do 1 pink packet to 5 ounces for 2 weeks, then 1 pink packet to 6 ounces. That would get you to slightly thick. And then based upon the hot child does, if they do well, keep weaning. If they don't, then you do your repeat swallow study.
What are some other subtle cues we would look for to indicate that a baby is struggling to feed?
Yeah, that's a great question. Glassy, watery eyes, redness under the eyes, I think often signal like a baby that like isn't tucked in midline. They kind of start to like arch back and splay their fingers. Babies that have like reflux and regurgitation, now our research is showing like we don't know if it's reflux or aspiration. So signs of reflux also can mimic aspiration. I definitely think though, like some parents will say like they get red around their eyebrows and under their eyes when they're drinking or mid to later in the feeding, frequently pulling off the bottle when they can't handle the flow rate. And again, having those watery eyes are the more subtle signs of aspiration where you should kind of take a look at the feeding and see, should I change the flow rate to slower? Should I change the positioning? Or should we kind of take a deeper look there?
Something that you just jogged a question in my mind with if these symptoms are happening later in a feeding, would you feed the baby not under fluoro and then I guess like I don't know, 10 minutes into their feeding, like maybe bring them into the fluoro suite?
Oh, that's a great question. That's a really good question. So we do in our infant video fluoroscopy have a bit of a timed protocol that we do for trying to capture that because, having like this baby come in and looking at their first 10 swallows and they're fine. So what we would do is put the baby in the seat, do 5 to 10 swallows, turn the fluoro off, wait 30 seconds, turn the fluoro on again, get 5 to 10 swallows, wait, we go 30, a minute 30, 2 minutes, and 2 minutes and 30 seconds. So by 2 minutes and 30 seconds, like, you've been mindful of your fluoroscopy time. So you're mindful of the radiation exposure. But then you're like 2.5 minutes into a feeding, which, if you're going to see something, you may start to see it. And if we're under 3 minutes total fluoro time, which we definitely are by that point, we can even look a little bit longer.
Got it.
Yeah.
All right. Anyone else have any last questions before we sign off? I did also put the link to the weaning protocol in there.
Oh, great. Okay, wonderful. Thank you. Great. Well, thanks for inviting me and thanks for your attention late in the day.
Thank you, everyone. Just a quick reminder that if you want a CEU credit, you have to attend both today and tomorrow live for that live credit and complete the learner assessment that will be available tomorrow on your course page, and you will have 14 days to complete it. See everyone tomorrow.